Yes, yes.
Yes, sir. So I welcome you all on the
Okay.
inauguration ceremony of our first diabetes digital conference of RSSDI. It is organized by our team of Diabetes Technology Network and Task Force, which consists of Dr. Jyoti Dev, Dr. Manoj Chawla, Dr. Mithun. They are there, and Dr. JP Sai and Dr. Sunil Jain. We also have two international advisors who has been recently added to our this task force, Dr. Pratik Chaudhary and Dr. Viral Shah. Dr. Pratik is from UK and Dr. Viral Shah is from USA. We have already done one program with Diabetes Technology Network. We created this network across the country, and it was a full 1 day meeting where we have more than 700 delegates were there. They all are our district coordinators. So first time we have created RSSDI district coordinator. From each district, we have one doctor who is responsible for that district, and we call them RSSDI district coordinator. So across the country, we have more than 700 district coordinator. The primary aim of this district coordinator to increase the awareness and education activity in that district, and at present whatever our RSSDI guideline which is there, and to improve technology and increase the uses of technology in district, they are there to attend the meeting of technology, our type 1 diabetes program, and also RSSDI guideline. Today we have this program which is uniquely designed for 2 days, Saturday afternoon, which we are starting, and it will end by Sunday lunchtime. We have some experts who are actually medical director of some of these companies, like the technology company which is available to our country, like continuous glucose monitoring, self monitoring of blood glucose, pumps, all these instruments which are available to our country, but very few doctors are using them in their day-to-day clinical practice. So I think their usage should improve, because this will improve the care for diabetic patients. And today we invited the faculty which are either founder of these company or medical director of these company, or they are the CEO, or they are the at the higher management level. So most of them are from Europe or USA. That's the reason we designed the program that we are starting by 2 o'clock and it will end by 9 p.m. So late in evening, those who are from USA, they can join us, and while in afternoon time, those who are from Europe, they will join us and they will talk to us. The program, the first topic, which is the keynote speaker, we had given to Dr. Mosh Philip, who is our ATTD founder, who is the chairman of Advanced Technology Therapeutics in Diabetes. He runs a meeting called ATTD. This year, he is going to have his 11th ATTD meeting at Paris. And the ATTD group had created that the last year a guideline on time in range. Today, he is going to talk on digital clinic. That was the last year theme for his ATTD meeting. So he will be talking about diabetes, digital diabetes clinic. Today we will end our session by one more keynote speaker, Dr. Satish Garg. I'm sure all of you know Dr. Satish Garg, who is from India. He is based at University of Colorado, and he is going to talk about the during this COVID time, how we can connect to our patients digitally or distantly. We can monitor our patients. It's really great pleasure that this meeting, Diabetes and Technology, is going to be inaugurated by all our respected patrons of society, RSSDI. And today we are very happy that today we have Dr. B.K. Shah, Dr. Muni Chodappa, Dr. H.B. Chandalia sir, and Dr. A.K. Das, who are with us. Unluckily, we could not get Dr. O.P. Gupta, and Dr. V. Sashay is finding some difficulty to get connected, but I'm trying him on telephone if he can be connected on a video call. I know many of you, I know very well Dr. H.B. Chandalia using technology in his clinical practice. He had used, many of his patients are on pump also and using continuous glucose monitoring. But still this technology, which is the future of diabetes care in our country also, it should be. We have very few doctors who are using regularly electronic medical records, who are using distant monitoring or continuous glucose monitoring for their patient. So we thought that this should be the future, and it should be ideally inaugurated by our patron, and they had given us the path. They had shown the path to the RSSDI, that RSSDI should do some activities which is the future. It should be activity related to research, activities related to the social awareness. That's the reason we have a RSSDI social media platform. So the patron's guidance is very, very important. And we would like to listen from our patron during their inaugural speech regarding this diabetes and technology and their further advice, which we keep on taking, and for that how we should do the activities as far as RSSD is concerned. So first I will request Dr. Sanjay Agarwal for a few words, and then I will request Dr. B.K. Shai, followed by Dr. Chandalia sir, Dr. Muni Chodappa, and Dr. A.K. Das for their inaugural speech. Over to Dr. Sanjay.
Good afternoon, everybody. Thank you, Dr. Banshi. And I think it's a great moment for all of us, because we have been trying hard to see that we can bring better and better academic initiatives through the RSSDI. As Dr. Banshi pointed out, we have been very fortunate to have guidances from so many seniors who have done doyen work in the area of diabetes over the years. They have been the guiding light of RSSDI, and all our past presidents have contributed immensely to the growth of the society. All Dr. Banshi and I and the rest of the executive committee is doing is taking forward the work that they started long back. We now know that the entire world is changing and technology is becoming part of our practice. And it is so important that all of us become technology conscious. And, we need to have a balanced interface between personal contact and technology when it comes to managing our patients with diabetes. This meeting is aimed to have all the world authorities on one platform and give us that guidances as to how we can incorporate this technology in our day-to-day practice, given that we may have some limitations, we may have some advantages, and how best we can utilize all this, by hearing it from the experts today and tomorrow. So I invite all of you, and I hope you have a great time listening to all the experts over the next 2 days. And if we want you to interact, we want you to have all the deliberations, and we want to make this entire platform very powerful over the time. We've also made a task force in technology which will guide us all the way through. We're fortunate to have all our task force members, Dr. Jyoti Dev, Dr. Manoj Chawla, Dr. Mithun, Dr. Sunil Jain, and others, who are contributing so much immensely on the growth of this platform. And I'm sure over the years, this will become a very powerful medium for all of us to treat our patients. So with this, I hand it back to Banshi and to Dr. B.K. Sahai for his opening remarks.
Thank you.
Good afternoon, everyone.
Yes, sir.
Dr. Banshi Saboo, President of RSSDI, Dr. Vasant Kumar, President-elect, Dr. Sanjay Agarwal, Secretary, my fellow patrons, Dr. Chandalia, Dr. Muni Chodappa, Dr. O.P. Gupta, Dr. V. Sheshaya, and Dr. A.K. Das, and members of the Executive Committee and members of the Technology Group of RSSDI. I thank all of you for inviting me to be here today. RSSDI today has become a very vibrant variety society with many ongoing programs, and I wish to congratulate the entire Executive Committee for this achievement. The technological advances are taking place in every sphere of life, and diabetes is no exception. However, newer knowledge emerges with each new technological development, leading to changes in concepts, and the treatment guidelines are also changing based on this knowledge. I have been interested in diabetes since 1965, and ever since I have been a witness to these amazing advances, from simple urine examination as a tool to assess the diabetic control to development of blood glucose estimations, followed by the development of glucometers, leading to the self-blood glucose monitoring. We have come a long way, and most recently has been the development of CGMS, which helps in assessing the undetected hypos, particularly during the night, and the glucose variability On management front, we have moved from animal insulin to human insulin, followed by the development of insulin analogs. In terms of insulin delivery mechanisms, we saw the advent of insulin glass syringes, followed by plastic insulin syringes, then insulin pens and insulin pumps. We also have once a week now as well, thus making the life of diabetic patients better. What is more, we now have the choice of pancreatic transplantation in selected cases, which can cure diabetes and abrogate the need for daily insulin injections. Today's program is going to highlight some of these technology advances and their application in our day-to-day practice with a view to improve the life of a diabetic patient. However, I would like to emphasize that we should not forget the role of dietary advice and regular exercise for use for newly along with the newly acquired technological advances in conjunction with these basic principles of management. Once again, I am also thankful to the organizers for asking me to be part of the inaugural ceremony. I wish that all the delegates gathered newer knowledge and are able to adapt this into their day-to-day. I have great pleasure in inaugurating this meeting with good of tradition and innovation. Thank you very much.
Thank you, sir. We have already 23 delegates who are registered, and we have more than 700 district coordinators who are also the part of this meeting. So they all are delegates. Thank you, sir. Thank you, Dr. B.K. Sai, sir. Now I request Dr. Modi Chadappa, sir, for a few words.
Thank you very much. Now, I started my practice when there was only impure insulin or dirty insulin, as Dr. Ajgankar used to call it. Now, it was a period when there was no economic liberalization. So we didn't even have, except tolbutamide and diabetes, we didn't have anything else. So we used to still manage diabetes in those days. But now, at least somebody like me, this diabetes and technology conference, I wish it was, one-to-one conference so that we could have learned more. Now online, somebody may speak, somebody may demonstrate, but still we may have many questions and we may not be able to get the answer. Anyway, thank you very much for Dr. Banshi Saboo and Agarwal for having organized this conference. It's very important at this stage because continuous glucose monitoring and insulin pumps and so many things are coming, and so many pens also, improved version are coming. So it's important that we people who practice diabetology be aware of the technology so that we can give it to the patients. I'm sure definitely we 20, 30 years ago, we had difficulty in controlling diabetes. Today it's not so. We are able to control diabetes. We are able to normalize HbA1c. So I think very important at this conference. I wish more people register and then online take knowledge. Thank you very much.
Thank you, sir. Thank you, Dr. Modi Chadappa, sir. Now I request Dr. Chandalia, sir, for his words of blessings. Dr. Chandalia, sir.
To begin with, I must thank Dr. Banshi Saboo and Dr. Sanjay Agarwal first to organize this wonderful workshop, and of course with the technology group which has done this wonderful job. Many of the RSSDI meetings that we did in Mumbai and elsewhere, where I was scientific committee chairman, I always try to include a session on technology. And I remember to have done at least half a dozen insulin pump workshops in the country long, long ago, 20, 30 years ago, maybe even earlier than that. The platform that we are using now, of course, you see, and the digital mode that we use, as Dr. Mani Chudappa said, has certain limitations. But let me tell you that it has some advantages as well. You see, you can connect with a lot of people. I have done minimum about 20 programs during this COVID period. The only thing I found that if they truly had a little more discussion on the topic, question answers, this would have become a very good program. So I think that's that part in this technology workshop. I'm sure the question answers will be one of the main, because it truly is more of a workshop. So I think that will be done, and frankly, it can be done with the kind of platforms we have available. Now, coming to the technology, very quickly, I want to just touch upon the basic technology that we all have to use more or less, and that is the self-monitoring of blood glucose and use of insulin pens. I don't think anything. Only thing there is that we still have to really train our diabetologists to select how much blood glucose should be done by a given patient at what phase of his diabetes. So everybody doesn't have to do 6, or everybody, and there are some people who don't require any. And there are some who require 2 a day, 3 a day by rotation. So all that, I think, I don't find that being as ingrained in the training programs, or we all, I think we have not learned that to do very well. And the only other thing we can do, RSSDI can do if they have a program to help patients, is really bring down the cost of strips. Strip cost is the main roadblock towards extensive blood glucose testing at home. So I think otherwise, yeah, I mean, these technologies are great. The sensors are fine. The cost is always a factor. Sensor and pumps, the 2 other technology which we use, I use for a very long time. And only thing I found there is the excellent sensor. Some sensors are very accurate, some are not. Some give more of a trend and pattern. Some give you exact values. So all that we have to, I think, will be brought out in this workshop. Which sensor has what is the strength and weakness of each sensor, and of course the cost will be compared to benefit. So cost benefit has to be examined all the time. What I found most importantly is that you put up a sensor, let's say Libre Pro, for 2 weeks, and if you don't give a very good diary in which patient maintains the activity and food chart, accurate food chart, frankly is worthless. So and what is provided by industry is always inadequate. Industry concentrates on technology which they are selling, and which is their earning point, which is, I think, they have to earn to make further progress. But they paid scarce attention to how to apply it, frankly, because I don't think the very good clinicians at high level are ever involved into this process. And I think with technology workshop like this, we will probably take up the eminence of clinicians in really utilizing these properly. On the end user are the diabetologists, and the patient is the end user. And until it really benefits them, you see, it may become a futile exercise sometimes. For the pumps, which I used for, I think maybe 35 years or 40 years. The first pump workshop in our country was about 40 years ago by me. 40 years ago in Delhi with Dr. Ahuja as my co-convener. I convened the first pump workshop long ago, you see. And at that time, we have one German and one American who had used a lot of McFarlane from US, and from Germany, Dr. Fiber was there, and Joe Ship from US. And we conducted the workshop for 3 days extensively. This is 40 years ago. And I think with that, after that, a lot of my colleagues have picked up beautifully pump use. You see, Banshi has done, Jyoti Dev has done, Sunil Jain has done from in a big way. I have some people who are on pump for 30 years now, 30 years, 35 years. Regular pump, beautifully controlled type 1 diabetes beautifully controlled. Women who had delivered healthy babies, who had bad experiences early. Type 1 is difficult without pump. I must tell you that pump use has to increase. If you really want to treat type 1 effectively, the pump is incomparable to any other, insulin regime you can ever use. It doesn't come anywhere close to the pump. So I think this is very important for us to adopt this little more, this technology, and help out our patients. The cost is always a problem, but I think these all, as we go along, things ease out. There are some, we have to devise some modes of helping patients who you see do not have access because of cost. So this goes on in our country. To make any care available to the poor people is a big exercise. It's one of the biggest problems, because biggest problems in medicine are poverty and ignorance. So I think I see the rest is all fine. So I think if we can do that, I think we can change things and make our patients happier. So very thank you again for conceiving this idea. I'm very happy to see my fellow patrons. So I was thrilled that I joined to see. I'm happy to see that everybody is intact. You see, and is a possession of their faculties, because after some time you will find that I'm not able to recall you. It is possible. It is a natural, inevitable process. We all accept it very gracefully, and we have always done so. Whenever we had the prime time, we have worked for RSSDI. When we realize there are very good people now clamoring to occupy positions, we gracefully bowed out, and we are very happy now to meet them again on the platform. And these are pioneers, those who are doing the work now. They really push the education part so well. They push the technology part so well. Only lagging is the scientific part, the research part. Research is difficult, let us say, of all the things. The rest we are doing is easy, and we are doing it beautifully. But if we can take the research on to the next level, I think, when some of us are alive, it will thrill us. We'll be so happy to see some good research going on under RSSDI banner. There are focus of research in 2-3 places in the country. They are doing very well, excellent. But for whole country to pick up research, I think RSSDI can be the catalyst. So I would say it is very, very efficient, our office bearers, to probably apply their mind to this. Thank you very much. It was wonderful associating with you for this brief inaugural function. Thank you.
Thank you, sir. Thank you for very kind words. And sure, we will take your advice for the research work to improve in our country. And the program today designed in such a way we had kept ample time for discussion. So it will be truly a workshop where a lot of interaction will be there. Now I request Dr. A.K. Das, sir.
Thank you, Banshi. My very senior patrons, my elder brothers, and my dear friends from the executive of the RSSDI 2020 and 2021, and the member of the technical committee and the technical task force, who have really changed the scenario of technology in diabetes in India. Dear friends, I'll start by saying I'll refer to a meeting which Jyoti did in Trivandrum. He invited me to be the chair and to do this context setting. It was by MSD. It was a very simple topic on teleconsultation. And I had some of my students who were elsewhere in the globe watch this meeting. And I'll show you the way Dr. Anand Basu, Andy Basu, the way the various people of my students in UK, they saw the work done by the speaker, namely Jyoti, and they were flabbergasted. So, dear friends, I want to mention that this RSSDI executive, as others, have done exceedingly well. You have introduced for the first time the social bites. I did a program. I was delighted to do that program. We have introduced the district coordinators. You had given me a task which I have done half. That is about the advocacy, diabetes advocacy, Banshi. I'll take it forward. And you have introduced many new. And one of the new things that you have started, of course, technology is a journey. And as Professor HV said that he had done a meeting 40 years back, I remember that meeting. You have really done a new thing today by making RSSDI go digital and making diabetes in India go digital. That's a great thing, and my hats off to you. Second point I'd like to mention that it is very important to remember that the ravages of diabetes are relentless, be it complication, be it control going haywards, whether it is the morbidity which is countless, the mortality which is great, and it's increasing by leaps and bounds. At the same time, the advances in the technology are equally relentless, as you just now heard from Professor Muni regarding the dirty insulin of Asgaonkar to the most modern insulin, which was referred to by Chandelier, about the science behind the newer insulins. Once a week, I think Professor Sahai spoke about it, and getting smart insulin not too far. Second point, starting from the simple monitoring of HbA1c. I remember from Chandelier, your meeting, sir, you convened a meeting in the Taj, and that time you were doing it by TBA method. Remember from Chandelier, sir? And today, even today, the monitoring is going from better to better. And today we have from the simple monitoring to the TIR and beyond. And if you take for the management from the vials and syringes, as just now Chandelier said, we are with the pens, pumps, and other delivery systems. Every specialty has developed behind instrumentation. Cardiology with the cath lab, nephro with the dialysis machine, gastro with the endoscopy. Today we can say with the heart on our hand on our heart that really today diabetes has gone great instrumentation. I remember, my colleagues remember, sir, remember Professor Samji Moses, SGPM used to say that we must have a session on instrumental diabetology. He was very good at coining terms. Let us be informal today. Instrumental diabetology. And today, Banshi, you have really brought the instrumentation diabetes under one roof. And unless we use this instrumentation, we'll be lagging behind. And, I will remember one thing to say before I close, that there is a fear in the mind of the people who are I don't say old, who are here in the practicing with the old system for a long time. For them, again, I'll quote SGPM. SGPM used to say in his jocular vein, fill up and feel the difference. You just fill up and feel the difference. Now here, let us start whether it is EMR, whether it is teleconsultation, whether it is pumps, pens, and anything. Today's world, we cannot survive without going digital, without becoming technology savvy. Now, you see the point of care. Once he introduced me to people who provide point of care. Once I'm grateful to you. Today, in my place, I have got 3 point of care instruments, one with Georgie Abraham, nephrologist, one in my room in PIMS, and one more. So, point of care HbA1c, point of care diagnosis. So I must tell you that technology is the buzzword. And I like the way it was discussed today. At least there is some bare necessities, basic minimum that everybody should practice. And that is to be savvy about the insulin, the technology and science behind insulin, to be at least savvy about the pens and little bit about the pumps, because it's a must today, and also a little bit savvy regarding the monitoring. We have tried under ICMR to do non-invasive. One instrument has been shown some promise. It has undergone trial at Nikhil's place, my place, and Mohan's place. It will possibly see the light of the day. We are trying to bring the strips, sir, which is about 10 rupees. But it's a long story. Each time we say that, you'll ask me, when is that happening? I hope it will happen soon. So, dear friends, today is a great day for us. I am delighted beyond description. First of all, to be able to see Professor Sahai, whom I had not seen for a long time, and my friends from Chandelier. I saw him the other day, and of course, Professor Muni Chudappa. He's now distancing himself. I don't know why, Muni, and also I can see Dr. Shesha quite often, and others. And second, my joy is no bounds, because I see youngsters who have taken up this technology. And when the youngsters are interested and they want to make a change, the success is ours. Dear friends, before I close, I must tell you that today is the day when, in a big way, RSSDI is going digital and diabetes in India going digital. We'll follow it up with a passion, with a tenacity of purpose, and change the destiny of diabetic patients in our country. Thank you very, very much. And I'm sure this will change the scenario in the country.
Thank you, sir. Thank
Thank
you.
you.
Hardik, can you play the video? And then I request DTN network members for vote of thanks.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु।
Thank you. Now I request Dr. Jyoti and Dr. Manoj. They can combinedly do the vote of thanks.
Banshi, before you close, Dr. Vasant Kumar is just joining. Would you like to just ask him to say one,
Because he is the first person, he is the chairperson for that meeting. So the first
Dr. Vasant, can you address for 2 minutes before we move on?
Thank you, Sanjay. I just put in the chat. It's been so wonderful. I'm so emotionally excited to see all our senior patrons and also listening to such great souls. And I must thank Banshi and you for making this possible. And I'm looking forward to have this great session in the next coming 2 days and wish everyone all the best. Thank you for giving me this chance.
Thank you. So over to Dr. Jyoti, Manoj, and I think Mithun is also there for vote of thanks, please.
I think Jyoti will speak on our behalf.
I will say, and then you can continue. So thank you, Banshi bhai, and thank you, Dr. Sanjay. And pranams to all of our patrons, Chandalia sir, Sahai sir, AK Das sir, Munchudappa sir, Rao sir, and we are all delighted to have all of you here in a single platform. And that is a dream come true. And we have the godfather of technologies over there, Dr. Moshe Philip.
Yes,
and that is inspiration for all of us. And he started the advanced technologies and treatments for diabetes 13 years ago in Europe. And that has been the inspiration for all of us. And this dream has come true because of Dr. Banshi. And now we have the Diabetes Technology Network in India. And thank you. Over to Manoj.
So I think I'll wind up saying that it's a pleasure being part of the Diabetes Technology Task Force, and a big thank you to Dr. Banshi Saboo and Sanjay Agarwal for making and taking this initiative and creating the task force. And of course, a big thank you to the entire executive committee of RSSDI for giving us the opportunity to work in the area of technology. The purpose of this meeting that Banshi and Sanjay have planned is to take technology to every physician practicing in the field of diabetes, and then of course to every patient with diabetes in this country. And it's been wonderful and inspirational to have our patrons here. Listening to them speak is extremely inspiring. I wish everyone here a wonderful 2-day of the technology session, something which is going to be a landmark for all of us to get more acquainted and using technology. And I'm extremely glad that gone are the days, as Dr. Chandalia said, that a technology workshop would be somewhere in the side rooms, and technology is actually taking the front space in the management of diabetes for all of us. So thank you once again, everyone, for joining in and enjoy this 2-day program, the treat that has been planned for everybody here.
Thank you. Hardik, can you share the screen of that some of the important housekeeping announcements? And then I request Dr. Mithun to introduce our chairperson for first talk, for the keynote speaker. Before that, housekeeping announcement screen. So this is for all the delegates. Already we have more than 700 delegates who are already logged in. So now I request Dr. Mithun to introduce chairpersons for our first session. Over to Dr. Mithun.
Thank you, Dr. Saboo. Thank you, Dr. Saboo and Dr. Sanjay Agarwal for this innovative idea that we start with the DTA network. And as all have said, it's a pleasure to have such big patrons here and to bless us for this innovative program that we are starting. Moving on to the first keynote address, I invite the chairpersons, Dr. Rajiv Chawla sir and Dr. Vasant Kumar sir, to kindly take over the proceedings and introduce the first. Moving on to the first keynote address, I invite Dr. Mosif Philip. Over to you, sir.
Dr. Rajiv Chawla is the immediate past president of RSSDI. He is a DNB teacher and guide for 20 years, who have more than 70 papers on micro and macrovascular complication, who authored 7 books on diabetes and more than 10 orations awarded. He is executive editor of International Journal of Diabetes in Developing Countries, which is our own journal, and he is currently president of DIPSI 2019. Dr. Vasant Kumar is a senior consultant physician and diabetologist at Apollo Hospital, Hyderabad. He is president-elect of Research Society of Study of Diabetes in India. He is past chairman of Hyderabad chapter of Association Physician of India. He is a founder and president of Diabetes and Youth Society, which is day supporting type 1 children since 1999. He is actively involved for public awareness program. Now over to Dr. Rajiv Chawla and Dr. Vasant Kumar to introduce our keynote speaker. Dr. Rajiv.
Good afternoon, everyone. Thanks a lot, Dr. Banshi, Dr. Sanjay, and Team Technology for this opportunity. It's a wonderful time when not only you are meeting your all EC members and you are going to have key speakers like Dr. Mosh Philip and others, those who matter in the field of technology, but we had a good time listening and seeing our patrons after a long time, as Professor Das very rightly said, and Dr. Chandali also said that it has been a long time we haven't actually touched feet of our patrons. So it was a wonderful time that not only you could listen them, you could also get their blessings. Thanks a lot, Banshi and Sanjay. Well, it's a privilege to chair this key lecture session by Dr. Mosh Philip, man behind technology, who's an endocrinologist and director, Israel Institute for Endocrinology and Diabetes at Children Medical Center. He has had about 20 years of clinical experience treating type 1 diabetes patients on pumps and has been using continuous glucose sensors. He has been chairman and founder of world famous ATD Advanced Technology and Therapeutics and Diabetes, and has authored multiple papers and textbook chapters. Well, as Dr. Chandalia said, that it has been a long way since inception of RSSDI 1972, almost close to 50 years down the line. There has been a lot of advancement in terms of technology, which we are now hearing to and we are using also in day-to-day practice. But I think there cannot be a better time or more apt time for the use of a virtual clinic or a teleconsultation in field of diabetology, not only in field of diabetology, but as such also in field of medicine, especially in this COVID area. So I think it will be wonderful listening from Dr. Mollif about Dr. Phillips about how to use therapeutics, how to use teletechnology in the field of diabetes, and how to use best part of technology to make our patients suffering with type 1 and type 2 diabetes more happy in their lifetime. Dr. Philip, please.
Dr. Mosh, you can share your screen now. You have to unmute. Yes.
1 second.
Your slides are visible?
I'm trying.
It is visible now. Just to make it full screen. That's all.
Can you hear me now?
No, it was earlier visible. Now it has gone.
You have to share it again.
You, but please share your screen.
Can you hear me?
Yes.
Yeah, very well.
Okay, so I'll share the screen again. So now you can hear me and see the screen?
Yes.
Good. So I'll try to change it into good. Is that okay?
Yes.
Fantastic.
So thank you for the wonderful introduction, and thank you for inviting me, the organizers. Saboo and others. I saw many familiar faces already now, and I have many friends in India. And I'm happy to participate in the first meeting of diabetic and technology of this great nation that I admire. So I would like to talk about the digital virtual clinic experience. I believe that it's a huge change for many of you, because I know that very recently it was not allowed to have a virtual or digital clinic in many places in the world, including India. I am sure that we all share the same dream that one day this will be the headlines of the newspapers, that we will wake morning and we will find a headline that the cure for type 1 and type 2 diabetes was discovered, and we can all take a vacation in one of the resort areas. However, the situation is not there yet, and therefore we have substituted the dream to a more approachable dream, which is to use digital tools, digital technologies in order to improve the care of our patients. And hopefully we will get to the day that we will have 99% of the time our patient will be well controlled, and that we will have perfect profile of their blood glucose level, and that we will have also a kind of avatar on their phones, being with them all the time, so the patient will not feel that he is alone, a kind of a physician in the pocket for each of our patients all over the world. So this is the technology dream, which is until we will have a biological cure for diabetes. The problem with the technology dream that the reality is not there yet. And these are the results of the exchange study, which is a network of centers of excellence in the US. And they compared the results of their metabolic control between the years of 2010, 2012 to the 2 years of 16 and 18. And gosh, despite the fact that they had many more patients now on pumps, many more patients now on sensor, despite the fact that they had more people using technology, the hemoglobin A1C of 2016, 2018, the blue line, was worse than previously. And only about 17 to 20% of the type 1 patients achieved the goal hemoglobin A1C, and about 30 to 50% of type 2 patients. And that's despite the fact that there was an increment in technology. And the question that we ask ourselves, why aren't we successful? And the answer has to do with the burden. To the best of my understanding, the burden for both the patient and the healthcare provider did not go down with the new technologies. And actually, in some aspects, it went up with the new technologies. And the burden is an issue that we have to take care of if we want to use technology more frequently and more efficiently. And indeed, when we look at healthcare providers that are treating diabetic patients, there were several reports last year and this year about the burden and burnout of healthcare providers in the field of diabetes. Look, for example, on the electronic records. Electronic records is a huge change. It's a wonderful step forward. We are able now suddenly to look at all the information that we have recorded years ago, that were recorded by other physicians. We have the opportunity to look at x-rays and lab results, all of it on the tip of our fingers. But when we look at the amount of work that a physician and other healthcare provider have to do, in a huge survey of 155 US physicians, they have found that an average 16 minutes and 14 seconds additional time per patient visit was needed in order to use efficiently the electronic records. So if we compare the time that we have spent on a visit years ago, about 20 years ago, to the time that we spend on a visit now, it took us about 2 to 3 minutes to write a note of the summary of the meeting. Now it takes about 60 minutes, and we heard before. It took us about 11 minutes to look at the data, at the diary that the patient had written down the smbg level, the blood glucose measurements, and it takes now 18 minutes for pump data and 15 minutes for bolus calculator. We didn't have CGMs. CGM interpretation and observation and downloading takes time. We used to summarize a meeting on 1 page maximum. It takes now many pages. And it was very rare that patients contacted us via telephone in between meetings, whereas now we get emails, WhatsApp, cell phones. Everybody has a cell phone. So the burden is going up. Add to it the fact that the number of healthcare providers is not going up at the same rate or the same pace as the number of people with diabetes all over the world, and it is not just in India, it is everywhere. So the number of healthcare providers is going down, the burden of work goes up. And when patients were interviewed in the US in 2016, 54% of physicians reported at least one symptoms of burnout. They claimed that we are spending our days doing the wrong work, meaning a lot of technology, typing, computer work. And in every hour physicians spend with patient, they spend 1 or 2 hours for documentation, phone calls, ordering tests, reviewing results, and so on. And actually, Earl Hirsch had published in 2018 a beautiful piece of work where they looked in their center of how many hours they are spending in between visits, each of the team members. And I'm not going to go over the details, just to highlight the idea that there is a lot of work in between visits. Add to it that in 2020, JAMA published a manuscript trying to describe to us how should an ideal clinical visit look like. And in their manuscript, they claim that the physician have to prepare himself to the meeting, to the interaction, and to listen very closely and completely to the patient's story and agree of what matters the most within him and the patient, and connect with the patient's story. And eventually, the demand from high quality visit is, again, attention and time. What about the burden of the patients with diabetes? As you remember, all of you remember, diabetes is a 24/7 disease. There is no day off. Day in, day out. Patients with diabetes have to make sure that during the entire day, the entire activities that they are doing, they will be in a reasonable blood glucose control. So there is actually no 1 minute that they are free of their diabetes, and it never ends. There is no horizon that it will end soon or at least in the next few days or weeks or months or years. And indeed, patients are spending a lot of time on their care. And if you look at the literature, you'll find several manuscripts that try to assess how many minutes a day a patient devotes to his diabetes. And there is a manuscript that calculated 58 minutes, about an hour a day. Another manuscript that interviewed many nurses that are CDEs, and they estimated that the type 2 patients spend about 66 minutes and the type 1 78 minutes. And families of children with diabetes spend even more. But I like this description that was published as a figure in a lecture that was given by David Marrero, that was at the time that he was the American Diabetic, the president of the American Diabetic Association in 2015. In the blue is the time that the patient spent between visits per year, and the white line is the time that he spent with the healthcare providers. So it has been estimated that individuals with diabetes spend almost 9,000 hours each year managing their diabetes on their own. And diabetes is a chronic disease that needs the attention of both healthcare providers, but also of their patients constantly. So why don't the patient get advantage of the new technologies? Why don't we see an improvement in the US, at least, when they introduce pump and sensors into the exchange program? And there are several reasons for that. One reason is that the need to download and to contact the healthcare provider between visits is there, but only 50% of participants actually, let's phrase it differently, more than 50%, between 50 to 71% of participants in type 2 exchange program never downloaded data between visits. And even if they are able to download the data, many are not able to understand and how to interpret the data and how to draw conclusions from the data and how to make changes based on the data and the profile of the blood glucose level. And they desperately need help to do that. And they need help from healthcare providers. And healthcare providers are not available because there is a shortage of healthcare providers, and it's additional burden on what they do. We asked our patients in our center, Dr. Nimi, Dr. Kappel, Dr. Gavan, interviewed patients, and they asked them questions related to how do they manage their glucose profile in between visits. And for the questions of how frequent do you adjust your pump setting between clinical visits, 54% never do that. 26% do it only from time to time. So most of our patients in a sophisticated technology center where we have hundreds of pumps, more than 70% of our patients of type 1 patients are on pumps, they don't adjust in between visits. And this interview was about 2 years ago. And when they do changes, they mainly change the basal, but they don't make other changes. To the questions of how frequent do you amend your insulin boluses according to the sensor, again, only 30% amend their boluses. And for those who do not adjust insulin dosing, the most frequent answer for the reason was that I am not confident enough to do it by my own, or changing insulin dosing is difficult for me. So, despite the fact that you and I, all of us know what is the recipe to improve or to or to better control our patients, despite the fact that we know what the recipe is, it's difficult to achieve because of the burden to both healthcare providers and the patient themselves. And what is the recipe? More frequent visits or interactions with multidisciplinary diabetic clinic team, frequent adjustment of insulin dosing. You cannot put insulin-treated patients on an insulin dose and hope that this will be the dose for the next 2, 3, 4 months until they come to visit you again. And that ongoing training is needed all the time because we think that the patient understood what we instructed. We believe that we did a good job, but when we look at it later, we see that many are afraid to make changes and to adjust their insulin. And the tool that we should take advantage of is the cellular phone. Every child has nowadays a computer in his hand, a cellular phone. Look at the number of billions of people that have cellular phone all over the world. So this, we have already the computer in the hand of the patient. We just have to take advantage of it. And indeed, there are many applications that have been developed for diabetic patients. There are quite a few that have been developed for healthcare providers. However, very few went through clinical studies. Most of them are great ideas without any proof that they work in clinical life. And we have developed one that we took through the entire process of validating it through the studies, through the research steps and studies. So we can take information from pumps, CGM, SMBG, and connected pens. We send it to the cloud where an advisor, an artificial intelligence-based algorithm that we have developed together with a group of engineers, and to give the patient, within a split of a second, an advice of how to, and the healthcare provider, an advice of how to change the basal rate, the correction factor, the carb ratio, and also some personal tips. It's easy when you are looking, and I'm sure that you are doing it every day, when you are looking at a profile of the blood glucose level, you can tell that here, Mr., you skipped giving bolus to lunch. Here, you gave the bolus after you ate dinner, and so on and so forth. So all these tips can be done automatically by artificial intelligent brain. And this is exactly what we have developed. Then we took it into a study, what we call the expert survey study that was published 2 years ago, when we gave 26 physicians from many different centers 15 scenarios of different patients and their profile of insulin and a profile of blood glucose level, and ask them to give an advice how to change the basal, how to change the CR, carbohydrate ratio, and how to change the CF, the correction factor. And if you look here, the blue line, the between physician and, the red line, between physician results, we found that experts in the field, people who are doing it on a regular basis, they agree on the change on the basal in about 40% of the time. They agree on the change of the CR in about 45% of the time, and the change of CF about 45% of the time. So there is not always an agreement or total agreement. When we gave the algorithm to judge and to suggest and compared the results from the algorithm to the results from the patient, we got in blue pretty much the same agreement. So the algorithm, the artificial intelligence based algorithm, the medical advisor that we have, the advisor pro that we have developed, is able to give an advice pretty much at the same agreement with other physicians. So the next step was to take it into a prospective randomized study where one arm got the advice from an expert physician and the other arm got the advice from the algorithm, from the advisor pro. We call this study the Advice for You study. And the aim was to check whether the algorithm is non-inferior to the expert physician from Yale, from Joslin Center in Harvard, from Germany, the Center of Thomas Dane, and Slovenia, University of Florida, University of Colorado, the Barbara Davis Center, and Schneider, our hospital. Hemsley sponsored the study. We got sensors from Dexcom, and we did a study which was published 3 days ago, actually on Wednesday. It was 3 days, yes. 3 days ago in Nature Medicine, showing that an algorithm can do a similar job to a physician, or non-inferior job to a physician from a great center in controlling the diabetes. And I would like to invite you, participants of this meeting, to the session tomorrow between 11:10 and 11:25, where Dr. Revital Nimri will go into the details of this manuscript. So we can conclude that we have developed, and there should probably be others that will develop, another electronic team member that can do a job similar to our ability to adjust insulin dosing. It's not to take care of the diabetes, it's not replacing the diabetic physician, it is just another team member that can give you advice within a split of a second. It's like if you work in a clinic where there are 2 or 3 doctors and you knock at the door of your friend and you ask him, what would you do in this situation? This is the level of the algorithm that we have developed, just another team member added to the team. On February 18, just a day before ATTD started, we organized a consensus meeting to discuss the digital virtual clinic. Nobody talked at that time about a COVID infection, a pandemic, a need to be isolated from the patients. We talked about the theoretical need, the urgent need to develop tools of digital virtual clinics in the world because of the burden, because of the low achievements in the studies, because of all of these situations that had nothing to do with the COVID infection at that time. And we talked about the need to have passive data transmission. We don't want the patient to be educated about how to download. We want that the download will be automatic, that it will be connected to the medical record, that this tool will allow, the tools that will be developed for digital clinic will allow to prioritize which patient has to be seen now, which patient can be seen in a month or 2, because he's pretty much doing great. Decision support system, the kind that I've shown you a few minutes ago, that helps you to titrate the insulin, should be incorporated in such a clinic. Tools for better telemedicine should be developed for this clinic, and diabetes apps that are proven in clinical studies should be the standard for in diabetes clinic. Of course, there are tools for social interaction that can be incorporated in it, reminder messages, movies, and other tools of education. And of course, that this little creature, the avatar that is with you all the time, 24 hours a day, with the patient, we'll also be able to help the physician to do the automatically billing, so we will not have to take care of all these things that we hate to do. On September the 9th, 3 days ago, this manuscript was published in Diabetes Technology and Therapeutics, and it's on online, so you can all share the consensus meeting as if you were there. So if I summarize that consensus, we agree that digital virtual diabetes clinic should be developed for all people with diabetes. Digital clinic aim to empower people with diabetes to self-treat their diabetes, because we are not replacing the patient at all. We try to empower them to do the job. Data ownership should be regulated worldwide. It is for the patients to decide whom to share it with. This is one of the obstacles, technology obstacles, that we have to overcome. The feeling that companies have that the data of the patient is their own. Digital clinic may replace some of the face-to-face appointment. We didn't know that the COVID is coming. We talked about only some of the appointments can be replaced, and increase the interaction between the visits, and easy passive transmission of data from all different devices to integrate and interpret, create a meaningful advice for both healthcare provider and people with diabetes, meaning there will be no borders of a company. The fact that I have a sense of a company X shouldn't limit me to integrate the data with a pump from company Y. And as I've said, we didn't know about the COVID. We talked about only some of the meetings should be face-to-face, but however, so many manuscripts have come out since then, in the last few 2 or 3 months, of remote therapy of type 1, remote therapy of type 2, using digital tools. This is the future to stay. We will have a kind of hybrid between clinical visits and interaction in between clinical visits after the COVID infection will disappear from us. The pandemic will disappear. And the tools for patients are developed as we talk, the kind of the physician in the pocket that will be able to interact with the patient 24/7, and the patient will not feel alone, should not feel alone, and should trust the tool in order to be able to make decisions in between visits. You cannot treat diabetic patients on insulin only in a meeting of every few months and expect to have good control. And with that, I would like to thank you, and again to thank you for inviting me. And I'm happy that you have created the national meeting, and I'm sure that the ATTD will collaborate. We started today. We will continue to collaborate with your new network. Thank you so much.
Thank you, Dr. Moshe Philip. It was wonderful listening to you. And thank you for being our keynote speaker today on this very important eve of I would call it a technological summit. And then you have taken us right from the yesteryears to the present and the future of technology and its usage in diabetes. As you know, Dr. Philip, India is highly advanced technologically. But then I must concede that we haven't been doing enough in the field of technology in diabetes due to various reasons. I think now the time has come that RSSDI, under the stewardship of Dr. Saboo and my colleagues, have really taken this, and we are looking forward to do much better in the coming years. And your talk was very appropriate and very inspiring at the right time. And we look forward to have you more often in these meetings. And since it's a keynote address, we are not really looking forward for any question answers. I would profusely thank you on behalf of all of us for your very enlightening and inspiring talk on an important topic. Thank you, Dr. Mosh Philip.
Thank you so much.
Dr. Philip, for very inspiring words in terms of technology. As Dr. Vasant rightly said, it is high time we also convert ourselves towards more and more usage of technology in practice of diabetes and medicine as such. And there cannot be a better time to adopt technology today. You have shown papers just published 3 days ago and measured the consensus, which came as early as February, actually before the COVID. And that time you were ahead of time talking about use of technology and virtual clinic and practice of diabetology. Thank you, Dr. Philip, for your wonderful elaboration. Thank you.
Thank you so much.
Thank you, Dr. Mosh. Thank you. It was real great.
Thank you for having me with you.
Thank you.
Again on 30th September.
Banshi, proceed for the next session.
Yes. So now I request Dr.
Introducing the Contour Plus One meter and a new age of smart diabetes management. The Contour Plus One smart meter seamlessly connects to the Contour Diabetes app to capture your blood glucose readings and allows you to record your diet, activities, and medication by adding photos, notes, or voice memos to help put your results in context. It's simple to use. Instead of handwritten logbooks, your data can be seamlessly and securely stored on your smartphone or tablet and in the cloud, which over time can help give you greater insight into what impacts your blood glucose results. And even if you've forgotten your phone while out and about, don't worry. The Contour Plus One meter can store up to 800 readings and can be instantly synced whenever the app is within range. Want to share your readings with your doctor? Your patterns and trends can be shared from your phone. It's that easy. And if you want to be sure to remember, you can set up alerts reminding you about appointments. And it will even let you know when your blood glucose result is below, above, or within your target range with a color-coded system. The app will also continue to evolve with new capabilities. So if you want remarkable accuracy from your meter, coupled with remarkable management of your blood glucose, join the new age of smart diabetes management and see your diabetes in a new light. The Contour Plus One meter and Contour Diabetes app. Your diabetes illuminated.
Thank you. Now I request Dr. Manoj to introduce our chairperson for next session. Dr. Manoj is there? Or Dr. Jyoti, you can introduce Dr. Makkar and Dr. Bilkash Bhattacharya.
Yeah, Bansi.
Yes, Manoj, you please introduce Dr. Makkar and Dr. Bhattacharya.
With great pleasure, we move to the next session, and gives me pleasure to introduce Dr. Makkar, who is a senior consultant diabetologist from the city of Delhi. He's the past secretary of RSSDI till 2019. Dr. Makkar has several publications to his credit and also has been the Indian SMBG guidelines. He runs Dr. Makkar's Diabetes and Obesity Center. Course director for the Cleveland Clinic Advanced Certificate course in diabetes, and we had that wonderful symposium 2 weekends back, and has publications in books, national and international journals. Dr. B.M. Makkar. And him, of course, we have Dr. Vikas Bhattacharya, who's director and senior consultant diabetologist at the Sun Valley Hospital, Guwahati. He's the vice president of All India Association for Advancing Research in Obesity and an executive member for the Central Committee of RSSDI East Zone, vice president of NEDS NEDS, and past chairperson of RSSDI, the Assam chapter. Dr. Vikas Bhattacharya and Dr. B.M. Makkar to chair the next session. Dr. Makkar, you will take it from here, sir.
Thank you, Manoj, for very kind words. And good afternoon, everyone. I hope my voice is audible.
Yes, very much.
Okay. So at this outset, I would like to place on record my appreciation for Dr. Banshi and the technology team of RSSDI for putting together this wonderful meeting. Because this is one area which I mentioned, if you remember, Manoj, in my Cleveland meeting also, that we are lagging behind in technologies in diabetes, and this is an area where we must put in all the effort to improve, diabetes care. And that's where we are today. And I am really pleased to see that we are having a full-fledged diabetes technology meeting. So I welcome you all to the monitoring symposium. And on behalf of my co-chairperson, Dr. Vikas Bhattacharjee, I also would like to thank RSSDI for giving us this opportunity. For this monitoring symposium, we have 3 very eminent speakers, and I would request Dr. Vikas Bhattacharjee to introduce the first speaker.
Good afternoon. Thank you, Dr. Makkar. Am I audible?
Yes.
So it's a wonderful meeting. I thank Dr. Banshi and the whole technical team for giving me this opportunity. And I'll just say that how important it is, when you talk about DCCT, Diabetes Control and Complication Trial, we know it is about intensive glucose control. But we tend to forget somehow that there was glucose monitoring at least 4 times a day. So it is so important. It became possible only because there was intensive glucose monitoring also. So that is very, very important. So I think for next few years, blood glucose monitoring will remain important, especially for countries like India. So my next topic is our 3rd generation blood glucose monitor and cutting the dots with Roche Diabetes Care and My Sugar. We have a wonderful speaker. He is Dr. Junia Badro. He is Chief Medical Officer and Global Head, Roche Diabetes Care, Head of Medical and Innovation, Asia Pacific Pharmaceuticals. So I request Dr. Junia Badro for his presentation.
Thank you so much. Thank you so much, Dr. Bikash, and thank you for having me in this amazing conference, totally virtual. I congratulate you for adopting the technology in these times of coronavirus. And it's a real pleasure for me to be here with you and to share with you some of the offerings around the Roche diabetes care solutions for diabetes. I guess I will probably share my screen, and I hope you can give me some feedback that you see it, because when I share my screen, I typically don't see anything else than my slides afterwards.
Yes, Julian, we can see your slide, and we have to make it full screen.
Full screen. Okay, fantastic.
Perfect.
Cool. Thank you very much. So, great pleasure for me to be here today. I will just deep dive directly into the topic of how do we actually connect the dots, and the presentation from Professor Philip just before was really insightful in highlighting some of the facts that for a patient with diabetes, it's a lot of work to connect the data, to have an understanding of the data, and without a closed loop system and artificial intelligence as of today, the burden is still there. So what I will discuss is basically the global challenge of diabetes, the individual challenge that patients with diabetes face, and I will also cover this part of the clinical challenge for all of us in managing diabetes, and offering something that actually is the integrated personalized diabetes management that will help and address the needs of all the different challenges. So we all know that diabetes is the main driver of disease as a disease area worldwide. This will not stop. The projections are that we might reach by 5 years from now 500 million patients with diabetes worldwide. This will come with severe budget impact for all the healthcare systems. And so this is a major challenge. The challenge is also the same in India. My colleague Hardik Joshi in Roche Diabetes Care shared those slides with me. And they are no exception from what we see worldwide. I used to live in India, in Pondicherry. I don't see the data for Pondicherry here, but I guess they might not be very different from the one in Tamil Nadu, where you see a prevalence of diabetes of more than 10% of the population. And that population, as we all know, is not small. The individual challenge is the one that Moshe was discussing. 9,000 hours per year per patient trying to understand and manage the disease. Here the data is probably not very accurate, but if they can, wherever there is access, patients with diabetes would tend to need at least an hour a month with their physician, nurse, healthcare provider, because as we know, the disease is complex to manage. Every day, plenty of therapy taken, and all the data needs to make sense, and the way we document it is going to have a significant importance. This data was also shared with me by my team in India, and they are not so different from what we see elsewhere in the US, in Europe, where everybody has access to technology. Well, we still can't really control at least glucose parameters for patients with diabetes. We are staying at bay, and the vast majority of people with diabetes in India, but everywhere else, is actually not reaching the targets. And not only the glucose targets, the weight targets, and the blood pressure targets. And so this is a challenge that we really need to address. We know it's a chronic disease. Self-motivation is complicated. Moshe also presented the data that shows that 50–70% of patients don't actually download their data, and that 80% of the patients actually don't make sense of the data. They don't adapt their pump or their doses of insulin. So why actually monitoring somehow? And this is the stigmata we are talking about here, and that leads to this clinical inertia. So clinical inertia actually leads to a failure or a delay in treatment intensification, and lead also to a therapeutic failure to achieve the therapeutic objectives that we have set with the patients. This study here by O'Connor was actually calculating the percentage of the responsibility, basically, and healthcare professionals, they don't have time to address all the needs of all the patients that are so numerous with the disease. The patients themselves, they get this treatment fatigue, and it's also their responsibility that they are not really addressing, and sometimes the fear to go from oral drugs to insulin, or the fear to increase the doses of insulin and get more hypos. But also the system. The system is are complex to navigate, complex to maneuver, different in each country, different in each state, and sometimes different in each region. If you are in a city as compared to being in a rural area. So what would be the strategy that we are proposing to reduce complexity while personalizing treatment? So our proposal is this integrated personalized diabetes management. We thought it would be a nice idea, and it actually the term was adopted by both the EASD and the ADA guidelines. So it reached consensus, which is great. The idea is really that we create this holistic, outcome-driven approach in diabetes management that will enable the patients to master the complexity of managing diabetes to improve time in range, that will collect, integrate, and analyze data points to support healthcare professional treatment decisions. And this is really something that we felt was an approach that could really lead to significant outcomes. And we've tested it in a clinical setting. You probably have seen the PRO value study. which was published in 2018, where although we only tested and did the study in Germany, it was a significant study with 900 patients, 51 practice over a year. And the approach was to really test if, when you structure the glucose monitoring by having 1 smbg before and after the 3 meals and before night, when you structure that data in a documented way, in a way that you have everything at your fingertip as a patient, but also when you can share all this data with your healthcare professional, even remotely, so that you can personalize treatment with your healthcare professional as a patient, assess the effectiveness, assess the needs, and then close the loop. This approach has led to significant improvement in A1C, provided higher patient and physician treatment satisfaction rates, and increased the patient adherence. This was a significant achievement to see that just by structuring the way we actually collect the data and share it with our physician, it actually improved things. And we did a cost-effectiveness analysis based on the PDM pro-value study programs, and that led to also a significant and even in life years gain. And did show some rate reduction of major adverse cardiovascular endpoints, and reduced also the hypoglycemic effects. So just by really structuring the documentation, having a possibility to collaborate between the healthcare professional and the physician and the patients and the caregivers to personalize treatment really helped to improve things. So the idea is really, as Moshe was saying, to close the loop and to make this pro-value study program a reality by implementing a digital diabetes clinic where different tools should all be connected together. And the tools we are proposing, as you know, are the new generation of blood glucose meter. We have an AccuCheck series of portfolio in our product with meters that are or not connected, with Bluetooth validation to send all the data to the MySugar app. And I will come back to that in a second. The MySugar app can connect directly with our Roche Diabetes Care platform, which we used to call SmartPix, was renamed. And that platform really gives the physician the opportunity to see everything that happened in the life of his patient with regards to his glucose, his exercise, his diet, and back fast to as long as we want, enlarge some areas where the patient was having less control, and hopefully this will also help us to bring into the loop coaches that will be added to the MySugar offering. Right now we are having those coaches in America and in Europe, and then we would like to enable artificial intelligence coaches for the future. We also want to connect the Roche Diabetes Care platform and MySugar with our new patch pump. And we want also to enable very simple monitoring solution, such as the new AccuCheck Sugar View, and I will come back to that in a second. So this was a bit overwhelming. So an easy way to close the loop and to make an IPDM solution a reality is simply to have a connected meter that sends all the data to MySugar with effortless data synchronization, no more manual diaries, no data loss, no blood on the books, and still a very easy to use, virtually pain-free soft clicks lancing device that has been for a long time the big hurdle for patients when it comes to pricking their finger, controlling their sugar every day. But here, this solution has been helping a lot of patients worldwide. This is just an example of a report that the physician can get from the MySugar data from a patient. and then going deeper, the RDCP platform is really a tool that is a patient management dashboard, basically. So when the patients come and he doesn't have the ability to print out or to share the report from My Sugar, he can definitely just click a button and send it to the dashboard so that the physician will see it automatically, and it's web-based, so there is no need for any device to get access to all this data. That will give you trend reports, standard daily reports, standard weekly reports, metabolic rate reports, and much more. I mean, one of the feedback we get from the RDCP is that there are 57 pages, and that's probably overwhelming. No physician use that in a consultation of 15 minutes with their patients. I wanted to touch on the AccuCheck SugarView app. That's a new device we are launching, and we have had some pilot launches in various countries, in Latin America, Southeast Asia. I guess not yet in India, but I think the plan from the local team is to do that. And this is you will find it very simple and easy. But again, as Moshe was saying in his previous presentation, everyone almost now has a smartphone. So we wanted to tap into that availability of this technology to allow patients to have a single strip where they will have a picture taken from the strip, and they will get a glycemia range. So not super accurate, not the level of what we have been offering with AccuCheck for a long time, but a range above, below, very much above, very much below, and that's it. 5 information, all digitalized. So we would have access, the physicians would have access to the data from their patients and their glycemia that they could have very quickly, very easily, digital, and that would help the documentation. And at the same time, at a low cost, because obviously one single strip, and that's it. No need for meters. Is our product offering for the low mid income countries worldwide, and we are really hoping that we can do a lot of benefit for patients in need to get cheap solutions for managing their diabetes. I also wanted to mention a partnership we have in India, specifically with Wealthy. Wealthy has been a partner with the Roche Diabetes Care ecosystem or environment for the last few years. It's a 24/7 digitalized diabetes health coach that provides a lot of food, diet, activity, and blood glucose tracking, thanks to the partnership with the connected meters of AccuCheck, and allows a diabetes education and learning content. And we are collaborating in trying to understand and make more sense on the data that is provided by both AccuCheck and Wealthy. All this data hopefully will help us to improve things further and further, and that's the beauty of the ecosystem. So I just wanted to provide you an example of when big data comes into play, and we've been collaborating with IBM in building a prediction model using real-world effectiveness data to create an algorithm to predict the risk of patients with type 2 diabetes to develop chronic kidney failure. And this has been a very good collaboration with IBM, so that we got a Nature Medicine publication last year highlighting this tool. 7 simple clinical criteria, and you can predict if a patient will develop CKD. Obviously, basing on this kind of information, a lot of clinical decision support to the patients in choosing the right therapy. So this is in a nutshell, the kind of the present and future offering of our products, both worldwide and in India. as we want to serve millions of patients with diabetes, we can definitely continue to offer the accurate AccuCheck meters. They are connected or not with various apps and digital apps such as Welty or My Sugar. My Sugar connects all the data into the Roche Diabetes Care platform that allows this documented discussion and data making sense for both patients and physicians. And then hopefully connecting this data in a closed loop system with the AccuCheck solo micro pump, which we are at the moment on the verge of launching worldwide. And we also have a partnership with Biocorp for the connected pens, so that we can also make the sense out of this data, and hopefully connecting that further with the next Med solution, which is a tool that will be incorporated in the Roche Diabetes Care platform, that not only will show the healthcare professional the data from their patients, but will then be able to provide some support in taking the right clinical decision, either in the identification of the insulin therapy or in the choice of the oral drugs. And summarizing the value of this integrated personalized diabetes management is definitely for the interventionists in the care of diabetes. For the healthcare professional, it's to overcome errors, and it's to initiate adequate treatment in a timely manner, and it's to manage to identify treatment until the therapeutic goal is achieved. For people with diabetes, definitely increase their health literacy, improve their communication with their doctors, have more confidence in their doctors. And for the healthcare system, it's all about having better decisions, having better care, and getting to that control we are talking about, that we are not reaching nowadays, to achieve the goals and to maintain patients with diabetes in range. And with that, I thank you so much for your attention.
Thank you, Dr. Julian, for a wonderful presentation. That was a good insight into the Roche portfolio and how advances in Roche monitoring systems are going to help us in future. With this, I would like to welcome Mr. Michael Smith from Essentia. Can we have his introduction slide? So Mr. Michael Smith is basically leading the emerging markets for Essentia Diabetes Care from 2017 onwards, and he's also heading in Norway and Finland with the Bayer Pharma organizations. So over to Mr. Michael Smith for the next presentation.
Thank you, sir. I will try to share my screen, so please give me a few seconds. Please confirm if you can see it.
Yes, we can see it. You can go ahead. Make it full screen. Make it full screen. Yeah, that's it.
All right. So sending greetings from Basel in Switzerland, where I'm sitting here today. And thank you very much for the opportunity to discuss with you today. I'm looking forward to a good session. We don't need to spend too much time on this slide. What I would say is that, yes, my name is Michael, but all my friends call me Mike, so please do likewise. Another thing I want to mention here is that I've lived in Africa, Europe, and Asia. And without a doubt, there are different challenges facing HCPs and patients in all of these different regions. The previous speaker, Dr. Julian, showed this information, and I'm sure most of you have seen this kind of information in varying formats. I still find it horrific every time I look at this data to see that there are currently more than 400 million patients with diabetes, let alone what the future holds. What we sometimes forget, we speak about these statistics and numbers, but what we sometimes forget is that each one of these patients is facing their own individual challenges on a daily basis. So they are facing their own challenges. And, you know, it's said that and I'm sure you're aware of this, but every adult makes several hundred decisions on a daily basis, if not several thousand decisions on a daily basis. But actually for the diabetes patient, there are even more decisions to make. I can't reference this because I actually saw a patient with diabetes present this a couple of years ago. But I would actually offer that it's probably even more than an additional 154 decisions per day if you consider what they have to go through. And most of these decisions that the patient with diabetes has to make is founded and fraught with fear, anxiety, and factors which are unknown. We say 154 decisions, but actually if you consider going out for a dinner or to a friend's house for a dinner, within the first 5 minutes, these are the kind of questions which a patient with diabetes has to be asking themselves and has to be thinking about. This slide says going for a gym workout. It doesn't have to be a gym workout. It could be going for a walk. It could be a visit to the supermarket. But in any such excursion, the patient has got to think about a lot more things than the average adult would have to think about. Even something which should be a leisure activity, an excursion out of town, going to visit one's family. There's all sorts of other considerations. What happens if I lose my meter? What happens if I lose my strips? God forbid, what would happen if I lose my insulin pen? I described a couple of activities which should be pleasant activities. But of course, even visiting the doctor can be a really, really stressful occasion for a patient with diabetes. We think that the digital revolution might have made things more simple for diabetes patients, but has it really? Because I think they may have gone from a state where they've had almost no information to a state where there's too much information. And a lot of this is complicated information. And I just want to give you an own quick, very personal example. I don't have diabetes, but it's a different kind of example, which I think illustrates this point quite well. I grew up in South Africa and I got married at the end of the 80s. And I wanted to go on honeymoon down to Cape Town. So that means I had to book flights, I had to book hotels, I had to reserve a car, maybe reserve some meals. How was I going to do this without spending hours on the telephone? So I found a travel agent who could actually do all of these things for me. And it worked quite well. Let's fast forward by 30 years. Last year, I decided to visit the UK to go to the Cricket World Cup and attend a couple of matches at the Cricket World Cup. So I thought, well, now in digital age, it's very easy for me to do all of these bookings myself. So in my browser, I typed in Cricket World Cup, and I was inundated with masses of information. Not only that, once I closed the browser and carried on with my normal life, all I got was spam emails telling me what to do all the time, and I didn't need any of this information. Look, eventually I managed to sort all of this out. But the only downside to the whole thing, besides the pleasant experience, was the South African cricket team's performance on the pitch. But I'll tell you a little bit later in the session how I managed to resolve the planning for this. But the point I'm making is that we've gone from a state where patients had almost no information, where there's a real danger now, where they can have too much information, and in particular, too much irrelevant information. So now they have all this information, or at least they've got access to all this information, and they come along to see the HCP and face this question: why am I not meeting my targets? Quite honestly, when the patient sees this, and I put myself into a patient's shoes, I don't have diabetes, but I can imagine that they might be thinking, well, where do I start? It could be a multitude of reasons why they're not reaching their targets. And as you can imagine, I assume this must be quite a stressful experience. Now, having said that, there are examples of patients who do manage to control their disease and who do manage to control diabetes. Some of them have done it in different ways. And the first patient here, of course, I don't know, but I believe that she gathered as much information as she could and is now a very staunch proponent of awareness and creating awareness for other patients with diabetes. The second patient over here found a very strong source of inspiration from his mother, and that helped him to manage his disease. The third patient you see here enabled and implemented very, very stringent lifestyle measures, diet, exercise, behavior modification, managed to control his diabetes in that way. And the last patient here, I believe, actually focused quite heavily on naturopathy courses and some forms of alternate medicine and managed to control his diabetes. So despite all the fear, despite all the unknowns, there are patients who manage to successfully control their diabetes. These four examples did it in a little bit different way. But I would venture that each one of them actually also controlled their diabetes in a much more holistic way and considered all factors that you consider when you see the patient and that the patient needs to consider. I'm sure that despite your best efforts and despite the efforts of companies and everybody else who's trying to assist the patients, at the end of the day, it's about self-management for the patient. And most of these 154 or whatever it is, amount of decisions that they need to make when they are alone. And most of these decisions, although you can guide them, they make as an individual. Now, I have just said that I think, and I'm sure many of you believe as well, that diabetes needs to be treated and managed holistically. Despite that, over the course of the last 30, 40 years since the advent of blood glucose monitoring, companies have tended to operate in silos. And quite honestly, Bayer Medical Care, or Bayer Diabetes Care, was one of these companies who operated in a silo. And we were very proud of the fact that 50 years ago, we invented the first portable blood glucose monitoring system. And along with other companies, we went on this journey where we all the time showed improvements in accuracy and things which we thought were very, very important. But perhaps we made the mistake of operating in a little bit of a tunnel, operating in a little bit of a silo. And quite honestly, it was only about 10 years ago when the first CGMs came onto the market that there was a little bit of disruption in this glucose monitoring market. And companies and industries needed to start thinking of different things and considering different angles and working together. Despite this, there are still huge gaps in the treatment. I lived in Singapore for a few years and I visited India many times, and I absolutely loved my visits to India. But there's one thing I didn't love, and that is almost every single person that I spoke to in India that was involved with diabetes, a patient, an HCP, a retailer, and outside of India, when I spoke to those payers who were involved in reimbursement, nobody believes that diabetes from a company or an industry point of view is optimally treated. There are still too many gaps. The reason why there are gaps, quite honestly, is I don't think that companies have worked holistically enough and have worked enough with one another. And I don't think companies in Asia, for example, have adequately met and managed the key issues. Some of these key issues in Asia are around awareness. Some of the issues are about access, and some of them are about affordability. And of course, access and affordability very often are interrelated. Now the situation has got even worse, with COVID-19 has actually exacerbated these key issues and these critical issues. And of course, there are many, many other issues besides this as well. And I think we need to adequately address all of these issues if we want to try to reverse type 2 diabetes. Now, this sounds like an outrageous claim to make, but I think many of you highly qualified people are probably aware of a number of publications, and I think the most prominent one is a recent one in the UK with more than 300 patients, where 50% of these patients within a period of 1 year returned to a pre-diabetes state. It must be said these were type 2 patients who were not on insulin. Now, how did they do this? They did this by stringent behavior modification. And as both the previous speakers to me have alluded to, behavior modification can be achieved with the right digital health tools. So I'll digress now for 2 or 3 minutes and just speak very briefly about how Essentia sees digital health and the way forward. So Essentia used to be part of the Bayer organization and broke away as a standalone company in 2016. And within the Bayer is a great company, but it also has many, many other priorities besides diabetes. And within the Bayer organization, we were very proud of the fact that we had a very accurate system. We have and still have more than 10 million meters placed and activated in the hands of patients around the world. But is that actually important? Much more important was, I think, our recent focus when we broke away from Bayer and formed Essentia, that we developed this mission statement, this purpose, that we should start to simplify and improve lives of patients with diabetes. Forget about having a good product. It's what that product can actually do for the patients, which is much more important. So yes, I think we've got a great product. It's very easy to use. There's many, many features and benefits. It's a very accurate product. It's a great product. But it's what the product should do, which is much more important than the product sake itself. When I started off my career with Bayer, I was involved in hypertension and working in the hypertension field. And I went to a congress many, many years ago. And I remember the chief speaker at the congress was speaking about a publication in hypertension. And he said, a study not published and a study not communicated is a study not done. Now that's a little bit extreme, but I would take those words and I would take them into the commercial field and maybe the medical field, the diabetes field. And I would say, quite honestly, if a patient's going to measure their blood glucose and not act upon that measurement, then they are wasting their time measuring the glucose. If it's simply a sake of measuring it, looking at it, and ignoring it, don't bother. It's got to elicit an action. That's why we did launch in Essentia Diabetes Care, the Contour Diabetes app. Again, the previous two speakers have spoken quite a bit about what the right apps can actually bring to patient care. But I'll digress for half a minute and tell you, when I went to the Cricket World Cup, with all of the information that was overwhelming me, how I managed to finalize my booking. I found one app, one booking tool, which I could trust, which I could depend upon, which was very easy, simple to navigate, easy to use, and had the right features and benefits. For my particular trip, I wanted to have the ability to have flexibility to cancel reservations without a fee and book new reservations. I am not trying to compare a patient with diabetes to my trip to the Cricket World Cup. What I am comparing here is a digital solution. And what I am saying is that a digital solution needs to be easy to use, it needs to be simple, it needs to be accurate, and it needs to tick many, many boxes along those lines. We think we can do that with the Contour Diabetes app, and I think there are many other very good products on the market as well. This is available in India, and globally, we've got a lot of downloads. Again, I would say downloads or activations by themselves mean nothing unless they are translated into clinical benefit. And we are starting to generate more and more publications which are directly related to the Contour Diabetes app. But more importantly, they are directly related to behavior modification, which is assisted by this tool. Now, I'm not trying to suggest that we tick all the boxes. I think our company is doing well in one particular area. And I mentioned earlier, to treat diabetes, it's got to be a much more holistic approach. That's why what we're trying to do, and I think more and more companies need to do, is to partner with experts in their field. So I would venture and I would humbly say we're quite good at measuring blood glucose, and I think we've got a very good app. There's a whole lot of things we're not good at, and we need to partner with many, many companies. And these are some examples of companies that we do have partnerships with, and we are continuing to increase our range and reach of partnerships. Also in India, you recognize some of these companies, and recently we announced also in India a cooperation with a company called Goki, which we are very, very excited about, which is really a behavior modification tool. And when patients modify their behavior, there are rewards which they achieve accordingly, besides the clinical benefits. Yes, I mentioned before that I think we're doing quite well in this field, but there are many other things to consider, and one of them is BGM versus CGM. Now, I won't speak too much about this, except to say that I don't think it's either BGM or CGM. I really think there's a place for both in the market, and I think there's a strong, without saying dependency, but relationship, and a very good relationship between having an accurate BGM and an accurate CGM available. Essentially, I did a lot of research. We've got a lot of research in CGM, but we decided the fastest way to get to market was to go with a company called Senseonics, with the Eversense group of products. And we recently announced this partnership with Senseonics, which has literally in the last month been announced. I was going to speak a little bit about the Eversense range of products. I'm not going to
quickly wind up.
Yes, I'm not going to speak about this in the interest of time, and also because we have somebody from the Senseonics group speaking a little bit later in these sessions, who's much more qualified to do so, the Chief Medical Officer. So I will not spend time on this. Suffice to say that India is very much a focused country for essential diabetes care, and we are at present evaluating potential launch in India. I've mentioned already that I think BGM and CGM is not one or the other, but I think having a holistic approach and working on all of these will help to reduce the amount of decisions a patient needs to make, and ultimately help to address our purpose, which is to improve the lives of people around the world. Thank you very much.
Thank you, Mike, for a wonderful presentation. Dr. Vikas, I think we can move to next session, and we will have question answer at the end.
Yes,
Dr.
yes. So again, thank you, Mr. Michael Smith, for wonderful presentation. And I think your company was the first to bring out no-coding glucometers. So it is wonderful. So we have heard from two giants, actually, Roche, then Essentia. Then we have now, is very popular in India, LifeScan. And you are using their meters for a very long time. And we have Dr. Michael Grady. His credentials, he's a clinical affair leadership role for LifeScan advertising. LifeScan advanced range of blood glucose monitoring and forthcoming continuous glucose monitoring. Also, technologies in terms of evidence generation. Key role writing and submitting LifeScan articles for publication in top diabetes journal and partnering with commercial teams to create claims and promotional material to drive growth. So it will be wonderful, I think, from Dr. Mike Grady. Dr. Mike Grady, please.
So I am sharing my screen, I hope.
Yes, yes.
We can see it. Make it full screen.
You see now?
Yeah,
yes,
that's perfect.
Yeah.
Thank you all, and thank you for this invite to this prestigious conference. I'm going to talk about technology advancements on LifeScan products, and I'm going to take a fairly practical approach and start off with a high-level slide to show you our ecosystem. You may be familiar here. Let me see if I can get this pointer to work. Familiar here with the OneTouch VarioFlex blood glucose meter with color range technology. It can partner with the OneTouch Reveal mobile app using Bluetooth. If patients wish to use OneTouch Reveal on their home computer, many patients are find it more convenient to use computers, so it's available on that particular device. And they would go to www.onetouchreveal.co.in to get signed up to get to use that particular app. For healthcare professionals, we have a professional version, and that's really about enabling healthcare professionals to connect with patients in their clinic so that they can do population management. You can imagine you had a number of patients using these OneTouch products. You've agreed to share their information back and forth, and I'll show you how to do that. That's all about using this technology here, this advanced tool, to reduce the burden on healthcare professionals. For the patient journey, and you can share this slide with a patient, they can go to Google Play or App Store. They can download OneTouch Reveal on their phone. They put in where they are, India, for example, a few basic bits of information, and then they put in an optional clinic code. This is somewhat easier if they're sitting in the office with you, because as a physician, you can get a clinic code from your local LifeScan rep or customer service. You will have that code, and you just tell the patient the code, and they put it into the app here, and you will get an email, and if they're sitting right next to you, it'll appear and you'll accept them onto your clinic. Or you can do this remotely, of course, just would take a little more time. But do find your unique clinic code by partnering with any LifeScan local rep, and this will enable that telemedicine to be able to flourish, so that your patients can take advantage of that. Your patients, if they're using the OneTouch VarioFlex meter or some of our other connected meters, they will be asking how do they pair that meter with the OneTouch Reveal app. It's quite simple. You switch on your smartphone and you try and detect local devices. It will immediately find OneTouch VarioFlex, and when you switch on your VarioFlex Bluetooth, your VarioFlex Bluetooth, the meter screen will come up with the code, and that code will be put into this OneTouch Reveal screen. Everything will automatically start syncing, and all the previous blood glucose results the patient had in here will end up in their OneTouch Reveal app. And I would recommend that when patients first use this, or when you use it yourself before you give it to patients, do take the tutorial. It's really good, it's really short, and it's very worthwhile. Now, not everyone wants to use apps or smartphones. I've just heard about some resistance to technology, etc. We developed the VarioFlex meter to give patients insight in the moment so that they can make immediate decisions. And just to clarify what the basics mean, we found in the UK that a lot of patients just struggle with recognizing the context of a numerical value. And just like Ascensia and many others, we've placed in ColorSure technology, or using color, to identify the numerical value. When it's low, we tell them it's low. When it's in range, we point to green. And if it's high, we would point to red. Now, in range is between 70 and 180 mg per deciliter. This can be changed by you or the patient if you wish to customize. But this is a really cool way of just being able for patients immediately to start paying more attention to their blood glucose results and understanding the context. So VerioFlex will share its information with One Touch Reveal. We've tried to keep a very good consistency of the colors so that patients aren't confused. It will immediately give them this color wheel, telling them about time and range and highs and lows. And it's a very good conversation starter for the clinic. It gives them a journey, chronological journey of what's been happening. Manually entered data would appear here, as well as data, for example, the results from the meter. And the meter also automatically finds clusters of results which are low and high, and you might find that a valuable tool in clinic to look at immediately to see any trouble spots, but the patient can be educated to look for those too. One very important feature on the patient's phone is the share function. You'll want to perhaps see what's been happening in between visits. They go to share, they click PDF, they can immediately add it to an email, they send it to your clinic, and it can be based on 14, 30, or 90 days in this instance, and you'll receive this. Of course, the patient could print that out and bring it with them as a paper copy if that's easier. You don't want to be sifting through too many emails perhaps. Or you'll look at the email, and when you've got time to respond, you can respond back to them and say, I've noticed this, you're on the right track, or I would like you to change this. So this is a great way to keep connected. As I've said before, if you go to onetouchreveal.co.in, you can sign up as a healthcare professional to get Reveal Web. And once you've got that, you can then see all the patients that you have using this umbrella of LifeScan products. They will appear automatically within One Touch Reveal. You will also see perhaps in the corner that there's a patient waiting here, and that patient has just done what we've said before. They've signed up in this way with One Touch Reveal. They've put in their clinic code, they've sent the email request to you. This is where it would appear, and you can decide to accept or decline that patient if you wanted to, but I'm sure by and large you've already agreed that you would accept them. You can filter all your patients by type 1, type 2, glucose levels, whatever you want to do, looking at their risk profiles. You can do a number of reports that I don't have time to go into. And we've just been told by Mosh Philip earlier about the burden, but I think this is really a great logbook to see, here's all my LifeScan patients, here's the ones that need the most help, here's the last note that I sent to that particular patient. You can keep track. Let's go back to color range technology. I published a paper in Journal of Diabetes Science and Technology to demonstrate the value of these 3 color bars, because I was pretty sure that patients weren't that good at recognizing values in the UK. So I went to our hospital clinics. These are very sophisticated patients testing very frequently. And this baseline 0 here was the performance of giving patients 50 blood glucose results and asking them simply put those numbers into low, in range and high. They just weren't able to do it very well. Once they had been shown how to classify results by just going through different exercises with these meters, these type 1 patients all improved to this extent, and then a far higher number of type 2 patients improved by a similar margin. As we've said before, literacy, numeracy, understanding, it's so important to just think of the basics. These meters in the moment explain to patients things that even patients that we thought were smart in our clinics basically struggled with. How can you take action if you don't even know if a number is is particularly high, you continue to run high numbers. We have a simpler offering also in India. We have One Touch VarioFlex. We also have One Touch Select Simple. It does all the same things, but it doesn't have any buttons. You can't change the context of the color range indicator, so it's fixed. And we saw really great favorability to this meter in terms of the patients in the UK who used it for a week. They really felt that they were much more inclined to take action based on this meter than their previous meters. And we published this in a local journal in India, along with the accuracy data. We also performed a global study presenting this particular meter in depth to healthcare professionals. But we started by asking patients in these 4 different countries, do you really feel confident your patients take action? And the results were fairly consistent, and 40% of HCPs in India really weren't that confident that their patients were taking action. Whereas after seeing this meter and how it displays information, that confidence level on the basis of using this meter was raised to 94%, agreeing it would probably make their patients a bit more inclined to act, just because they're seeing the importance of the result in the moment. We also just recently completed a study that we published in India. There were 25 sites involved, and we thank all of those sites for their incredible insights and their ability to motivate patients. In this study, after 3 months, using VarioFlex, we saw 1.24% improvement in A1C in patients with type 2 diabetes. And there are many surveys done, but there's a very similar feel in the context and understanding about, you know, I'm having lows and I'm having highs. I'm actually fine, I'm doing something right. And then trying to think, well, what was I doing right that made these numbers in range? Really, that whole thought process comes back to patients and really in partnership with our healthcare professionals. That was a change from baseline study, and you often see larger percentage A1C drops, so of course in that particular scenario. I also did a randomized controlled trial in the Journal of Diabetes Science and Technology, really going head to head with other meters. So I left half of the patients to remain on their current groupings of blood glucose meters, and the other half of patients changed to use our LifeScan meters with ColorSure technology. And here's what happened. The patients who stayed on their current blood glucose meters had A1Cs of 8.6 to start. After 3 months, they were still at 8.6. The patients who moved to our meters were on baseline 8.8, and they improved by 0.36%. And what kind of surprised me as well is that when we isolated to our type 1 patients, they actually did better, 0.5% improvement in those patients using these meters. And there's a 0.6% improvement in patients using the Vario meter, which has some pattern recognition tools, etc. And we'll be bringing new solutions to India in future to go beyond VarioFlex, but I'm not presenting that today. So what about telemedicine and connecting through One Touch Reveal? Published another randomized controlled trial in JMIR. It's a bit more sophisticated, really about providing text messages to the patients. So half the patients were switched from their current glucose meter to VarioFlex only. They only got VarioFlex. And then the other half of the patients got VarioFlex, they got the app, and then we got the text messages. And we found with the meter alone, there's a 0.5% improvement, and with both, it was a 1% improvement. I would like to also raise a flag for the LifeScan Diabetes Institute, amazing institute. Please get your teams and all your colleagues to look into this. You can discover so much about more than LifeScan products. There's webinars, case studies, videos, everything. Go to this site, it's absolutely free, and sign up and you will learn a great deal. It's really great. So in summary, we have ColorShare technology that helps patients in the moment. We have the app for remote management. We can bring both together and prove that we can improve glycemic control. And we also have the Diabetes Institute, which is for healthcare professionals across the world. Please sign up and take advantage of that excellent website. Thank you very much.
Thank you, Mike, for a wonderful presentation about One Touch Reveal and the connected technology about LifeScan meters. Do we have, Manoj, we have question answers here?
Yeah, we have scheduled 5 to 10 minutes before we move to the panel discussion with the same panelists. So if there are some questions in the chat
one
box.
question is, when will Roche CGM be available in India?
That's the question to Julian.
Hi. Yeah, sorry, I was unmuting myself. This needs clarification because the CGM we were distributing worldwide outside of the US until for the last 2 years was Eversense. And Eversense, as Mike said earlier, been partnering with Ascensia for next year. So this is now a question to Ascensia if we are talking about that CGM.
Okay. So can Mike from Ascensia answer this question?
Yes, I can, but unfortunately not with a precise answer. There are 5 markets that we will launch in first, being Germany, US, Switzerland, Sweden, and Italy. Other key markets for us are under consideration, and India is one of them. So I know it's not what you want to hear in terms of a date, but we will bring it to India as soon as we can.
So another very
Today evening we have Dr. Makkar Fancy Kaufman also. She is going to give the answer.
Okay.
No, Banshi, I think we'll get the answer from Mike only. Dr. Kaufman is with Eversense, but in India it's going to be Ascensia who's going to get it to us. So Mike is the guy who has to decide on that.
So another very interesting question is that some of the meters, one meter is using red color for hyperglycemia and the other one is using for hypoglycemia. So that can be very confusing for patients if they change between the meters. So do you think there is a consensus required for using these color codes internationally, which will be much better and much easier for the patients?
Yeah. I think Dr. Grady can take that, and then the others can also comment. I think this was probably brought in first by the LifeScan meters, so probably Dr. Grady can speak about the color coding and non-uniformity there.
Yeah, I would say perhaps I might be wrong that we were the first to bring out the color range indicator on our very first meters in Europe. The thinking was more about low being sort of cold and red being sort of hot and high. There was a lot of analysis done with patients, a lot of sort of human factors work done to try to understand whether patients would understand that connection, and they did. And I'm sure that others have done the same with their meters and found the same kind of data resonates as soon as patients start to use that meter. If they switch, I'm fairly confident if they switch that they would fairly easily transition to that different meter. But I know what you're saying, it is confusing. I know with CGM and AGP and things like that, the consistency is extremely helpful. But even within that, within CGM, there are differences in color that you'll see on the different apps, etc. even now. So I do agree it's a global problem. I don't have the solution.
So don't you think that the industry heads should put their head together and join on this particular issue to come out with a uniform solution?
I think Dr. Makkar, and I would like again the others to come in. I think it was basically a smart marketing or pitch from the other company trying to highlight that red color is a bigger flag of worry for hypoglycemia, rather than hyperglycemia, which was
Well,
what
I agree, Manoj, but the important thing is for patients, we should have a solution which is simple and uniform across the globe, right? So I think their industry has to play a very important role to have a consensus among themselves that as far as the color coding is concerned, they can follow the uniform path. Technologies, they will all have different technologies.
Agreed. So, Dr. Bakkar, if we were to guide them as the
we can always suggest.
Yeah,
we can always suggest.
Yeah. So, what do you think we should, if I was to open this up to all the endocrinologists and diabetologists here, what is a bigger red flag for us? Is it hypoglycemia or hyperglycemia?
Hypoglycemia. Definitely.
I think, Manoj, we have to go by the time in range recommendations. There, the time below range is red.
Is red, yeah. So exactly. So I think the meters which are now using the color coding are using the red for hypo. Probably Dr. Grady and team will have to revisit the color coding for the LifeScan meters and see whether they want to change that. Do you agree, Dr. Grady?
I think that's a difficult ask with such a vast array of meters in the market. So I think for the time being, I would have to say that we need to educate our patients to use whichever meter they are using. And I think you can see from the results that patients are successful on these meters and react to them consistently because they're so simple. That messaging is so simple. As I say, we were first to come out with that. Other things have happened since, so this is how these questions arise.
True, and we must appreciate and congratulate that thought that LifeScan had in bringing that. So it was as simple a concept, but it did make a huge change in the patient's perception and action-taking ability.
Definitely for those who have got numeracy and literacy problem, it is a wonderful thing for them.
Yes,
and there is an international set of guidelines which is edicted by the International Diabetes Center in Minneapolis, were supposed to be the guideline for meters, colors system, and red is definitely associated with hypo.
I'll just ask about one thing, before, because it's data transmission. What about data security? How secure it is?
I think because there is going to be a full session on data ownership and security, we can
Okay.
We have 5 more minutes in this session, Dr. Makkar, for any questions before we move. So we have 5 more minutes for any questions that anybody wants to put up on the SMBGs.
There is one more question in chat box. I don't.
That is on the solo micro pump. When is Roche planning to launch?
When Roche is planning to launch the insulin pump in India?
Okay, I think that was asked. If I was to ask all the 3 from the SMBG companies, there are questions often asked about alternate site for testing. Is there anything happening much which is validated for alternate sites for testing beyond the fingertips? We would request comments from all the 3 speakers for alternate sites besides fingertips for SMBG.
Historically, it was OneTouch who introduced it some time back. Because the LifeScan meters had options for alternate site testing.
Yeah, so we don't see much of that being used. So where do we stand on alternate sites for testing, Dr. Julian Smith and Dr. Grady?
For us, I mean, we recommend to test on the fingers and change fingers. That's the most consistent way of testing.
Tomorrow morning, we are having the session from GenDeal, Dr. Chris, and that will be on alternate site testing with GenDeal and the evidence being generated. I think McGrady will have something to say about some of the meters from the same LifeScan some time back.
Yeah, I think there were original OneTouch meters, and we did studies with Ultra with our early Lansing devices to show that there was PAM testing. I would have to agree with Julian that I would recommend finger testing, even though we've reduced blood volume enormously to around 0.4, 0.6, whatever it happens to be. I still feel that even on the palm, patients do perhaps struggle more with the human factors of filling the strip on the palm because of the flatness of the skin there. It's a little more difficult. But I would recommend finger testing always. And I think Julian also alluded to the advancements in lancing devices, meaning that pain is less on the fingers. And we've just brought out the Delica Plus lancing device. You have the nice Roche lancing devices. That's made it more comfortable for patients to get sufficient blood at lower depths. And I think that's made a much bigger difference in addition to the lower blood volumes of 0.4, 0.6. I did a study where I asked patients to get blood volumes, and their general blood volume was about 3.1 microliter on the finger. But it wasn't about the volume, it was about them understanding, was that a big enough drop for them to see it and to place it into the strip? The volume meant nothing to them. So I would recommend finger.
So general consensus is finger prick only. So Manoj, if we don't have any more questions, I think all the speakers did a wonderful job. Basic learning, I think, from this session has been that there are a lot of advances happening on the monitoring front. Every company is putting their front foot in improving technologies and getting the best solutions for the patients. No technology is perfect, and I think we still need to keep on working with the technologies till we achieve near perfection and can make our patients as comfortable as possible. With that note, I think I will thank you all the three speakers for doing a wonderful job and hand over to Manoj for the next session. Thank you, Manoj. And I would also thank technology team and RSSDI on behalf of Dr. Vikas and myself for this great opportunity to be part of this session. Thank you.
Thank you, Dr. Makkar, Dr. Bhattacharya. Thank you so much for that session and all the three speakers. I think we'll have a break now and we'll have one of the technology videos being played.
Thank you.
Diabetic Foot Care India. Established in 2005, we, Diabetic Foot Care India, are one of the accomplished manufacturer, wholesaler, distributor, exporter and importer of medical electronic equipments for the management of diabetic foot care management. We are considered pioneer in this diabetes segment and are an ISO 13485-2003 certified company. Our products range include variety of vascular Doppler for circulation disorders, neuropathy graded equipments, foot imprinter, Harris mat, plantar pressure system, Podai scan and EMED, neuromuscular stimulator therapy, infrared LED light therapy. We have a team of highly trained and experienced professionals who work untiringly for ensuring flawless and timely deliveries. Their effort and dedication is one of the key factors behind our success and reputations in the industry. We at Diabetic Foot Care India are dedicated towards serving the mankind with complete diabetic management solutions, thereby improving the quality of life for the diabetic patients. We have developed state-of-the-art infrastructure that is built on the most sophisticated designing and manufacturing capabilities. Our production facility is installed with advanced software and machines. Our objective is to be the quality leader in our markets as viewed by our customers, and we implement our quality policy uniformly throughout the company through the development, execution, maintenance, and continuous improvement of the quality functional guidelines and operating procedures, which have been prepared for every major functional organization within the company. We have supplied more than 4,900 of our products across 34 countries, and our products are supported by our international distributors in some countries. Our major markets are in Australia, Indian subcontinent, Europe, Africa, Gulf countries, Caribbean, South America, and Asian countries. Thank you for watching our video. For more details, please visit us at www.diabeticneuropathy.co.in.
Well, with that, we move on to the next session, and it gives me great pleasure to welcome the moderators for the next session, Dr. Sujoy Ghosh from Kolkata and Dr. Jaiprakash Sai from Hyderabad. Can we have the introductions for both of them up here, please? RX team, can we have the introductions for Dr. Ghosh and Dr. Sai? Dr. Sujoy Ghosh is a senior endocrinologist from the city of Kolkata. He is the EC member and for RSSDI. He is he's a member of the Endocrine Society of India and office bearer with ESI. Has several publications to his credit. Is a very integral part of RSSDI team, constantly helping and guiding us on various initiatives that the RSSDI team takes. Dr. Sujoy Ghosh from Kolkata. Dr. Jaiprakash Sai comes from Hyderabad. Dr. Jaiprakash is a member of the RSSDI Technology Task Force. Again, a senior diabetologist from the city of Hyderabad. And both Dr. Ghosh and Dr. Sai will be conducting the next panel discussion with the previous three speakers and Dr. Jyoti Dev and myself joining in with the panelists. Dr. Sujoy, Dr. Sai.
Thank you very much, Dr. Manoj, for that kind introduction. And I welcome also Dr. Sai as my co-moderator of this session. And, the topic or the title of this particular panel discussion is quite interesting because it talks about who will be using SMBG in 5 years' time. Now, I always love looking back at history and looking at the present before I jump into the future. So, we've got international faculties here as well as Indian faculties here. So why don't we first start with the international faculty and ask them, if you look at the total number of patients with diabetes right now, people who are eligible for glycemic control, what proportion of them are actually using any form of glycemic monitoring worldwide? We are talking about things which are, relevant, but it's great to say that, everybody should be doing an SMBG. But what does your market data tell us? That out of 100 people who should be monitoring, how many are monitoring at all in the first place? And in that, what's the breakup between the various kinds of ways that we monitor, whether it's the SMBGs, whether it's the AGPs, and whether it's the CGM? Any one of the international faculties, maybe Julian to start with.
Well, I can start off, and I can say to you that, and then I would defer to my colleagues after that, but I would say that the information and the data is extremely varied. It's varied, of course, between the different patient segments, type 1, 2, and pre-diabetes, but it's also extremely, extremely varied by country. And there's a huge difference between the emerging markets and some of the more developed markets. And even within emerging or developed markets, we see big differences. A lot of these are because of affordability issues and reimbursement issues and a number of other issues as well. But it's very difficult. Of course, we could probably drill into specific countries and give you data for that. But on a global or even a regional perspective, it's very, very difficult.
Would
anyone? Yeah, I would completely agree with what Mike just said. I mean, you saw the numbers. We have 400 million people living with diabetes worldwide, and 70 million have access to any kind of SMBG. That leaves a lot of people without any access whatsoever to any monitoring, and this is a huge unmet medical need that we need to address. Now we're talking about CGM. Great, fantastic technology, beautiful little tools. 2 million people are using them worldwide, and this is the big gap. And so definitely technology might be getting cheaper, and the cost of daily CGM application might go below $3 in the future. And that will increase accessibility, but not for the 300 SMBG is going to be essential for another numerous decades. Not to mention that, you know, a lot of things are being discussed about how do we close the loop and do we have a closed loop system? Great. But that's where you definitely need a lot of calibration, a lot of checkings, and a lot of accurate measurement of glycemia, because you cannot rely only on a CGM system.
Right. Mike Bradley, would you want to chip in? We've understood that depending on whether someone has access to healthcare, what kind of reimbursement, what's the financial status, and all of that we do understand. And of course, the type 1s are more likely to get SMBGs done, maybe people with gestational diabetes. Any other feature that you would think actually determines which patients get to at least do some kind of SMBG internationally? And then I'll come to my Indian counterparts.
Yeah, I think that, partly this is about the advances in the pharmaceuticals that are coming out too. We're seeing quite a lot of advancements in the GLP-1s and the, whole spread of different ways of taking those particular drugs and the SGLT2s. So I think with the advancements that have made on the pharmaceutical side, that may in fact be making people complacent in some way, that they don't need to test now. And I'm not sure that's particularly helpful. I think even with those pharmaceuticals, it becomes much more important that patients have access to monitoring tools frequently and sufficiently to look at the performance of those medications for those very important patients. And as patients move to insulin, it becomes more important. And that's where we have these arguments about cost effectiveness and who should get it, and frequency of monitoring and structured testing, and actually using the tests in a way that's cost effective for the patient and meaningful to the patient, instead of just testing and let's all agree that someone's testing. That's not very helpful. And you'll remember that when the first Libre trial came out, the Replace study, there was actually no difference between the patients using Freestyle Libre and blood glucose monitoring. And I think most of us put that down to the fact that it demonstrates that if patients are not successful and understand the rules of the game in self-monitoring with BGM, how can you expect them to go to CGM and suddenly become whiz kids and be fantastic at using that technology because of seeing more results? And I think those CGM but I think the pharmaceutical thing we start with, we have to still have that insight for patients with those medications. As patients go on to insulin, we have to understand it's about structured education and insight and behavior change. And beyond that, when it gets to the type 1 patients, of course, you can see many countries leaving BGM behind, depending on their healthcare system. But of course, most of our data is from the top clinics and T1D exchange, and we look at that stuff and we get this blasé impression that everyone's wanting and using CGM and being successful, and actually even in their data they're not successful. It's a very difficult picture. I'll leave it there.
Dr. Jyotidev and Dr. Manoj, all of you see patients, and probably both of you see patients who are relatively at the top end of society in terms of their financial capabilities and affordabilities. But if you speak to most colleagues, and maybe I'm sure both of you are aware of the hard realities at the grassroots level in India. So in India, you think, what scope do we have of actually expanding the base? Because if you look at 100 patients, because we've got over 7 crore people in India with type 2 diabetes, right? What proportion are actually doing any form of glycemic monitoring? Whether that's good, bad, whether we are taking steps, adequate steps thereafter after having monitors is a different question. We'll come to that later. So what do you think we are doing, and what are the things that in India, at least, we could do to at least improve the uptake of glycemic monitoring in the first place?
Bansi, you want me to, Jyoti, shall I? Okay. So, Suja, I think that's an interesting question. And when it comes to India in terms of monitoring, I think in the overall sense, India is still a country where we are able to offer our patients the GLP-1s and the newer basal insulins, which may be as expensive as they are here. But at the same time, a significant proportion of our patients still use human insulin. And I'm not sure whether in part still the animal insulins are being used, which were till few years back. It's clearly a country with diversity where in terms of acceptance of newer medications and newer technology, we have a segment of population where we are able to offer them the best of technology. But at the same time, we are trying to still offer the benefit of the basic medication to a larger population out there. So coming back to technology and monitoring, if I was to answer it in terms of the larger question of the panel discussion itself, as to what happens to blood glucose monitoring or SmbG in India, even with increasing technological advances in the real-time CGMs being available now and in the near future, assuming and hoping that their accuracy data gets better, the affordability hopefully gets better, but that's still going to be restricted to a niche, small percentage population in countries like India. Blood glucose monitoring, at least for the next decade, will still form the basis of our basic monitoring. And then we still have a long way to go in terms of increasing awareness amongst our physician colleagues for the need for basic monitoring. The fact that in diabetes, unless you see, you do not act is extremely important. I think we in the physician community keep arguing about what is the need for monitoring in patients with type 2 diabetes, especially if they are not on insulin. I think a lot of us clearly believe that monitoring is knowing, monitoring is seeing. And unless people monitor, irrespective of whether they are type 2 on orals or insulin or type 1s, you don't have reason enough to make changes in your lifestyle, in your diet, compliance with medications, and so on. So I think we still have a huge way to go in terms of constantly improving the awareness on the need for monitoring, and that needs to go down to the grassroots level. Well, affordability hopefully keeps changing in every nation, and as our nation also gets more affordable right from the ground level, if we are convinced about the advantages of monitoring, that has to be accepted at the ground level itself.
So, Dr. Jyoti, before you start, do you have any data to tell us that out of 7 crore people in India, what proportion are actually doing any form of monitoring in terms of even SmbG?
Because I have asked the same question to some of these device manufacturers, and the approximate numbers using SmbG or other glucose monitoring in India will be less than 2% with diabetes. And earlier it used to be less than 5.5%. So it is increasing. So remember when Libre was launched 5 years ago, we all thought that is going to be the end of SmbG. But actually in practice, especially after this COVID-19, the monitoring with glucose meters have gone up maybe 2 to 3 times. And the patients have themselves realized the importance of glucose monitoring. The physicians have themselves realized the importance of intensive glucose monitoring and treatment, since most of these deaths due to COVID are secondary to either a new onset diabetes or a hyperglycemia during the critical stages of COVID-19. So with this perspective, I would say that SmbG probably is never going to die. So remember when the CGMS Gold was launched, and we started using it in 2005 in India. So we thought that we all used to teach our doctors that this is a video and the SmbG is like a picture. So looking at the real world, if you look at the videos and compare it with the pictures in real world, did the videos replace pictures? No, it has never, and it will never replace the pictures. The photos will exist, and the photos are going to be more prominent and prevalent and more in number when compared to the videos because of several factors. But the biggest hurdle I believe using even the glucose meters in India are the doctors. That Dr. Manoj has highlighted that many doctors were actually not convinced with the accuracy. So of course, in the beginning, it was difficult to manipulate the glucose meters. I still have the AIMS reflectance glucose meter with me in my archives. It was difficult to use in the beginning. The accuracy was less. But during the last 10 to 15 years, or during the last 5 years, especially with some of these branded glucose meters, the accuracy is much better. And this message is not properly conceived by the physician community. That is the biggest hurdle. That many of us are not aware of the fact that glucose meters are now very, very accurate. And another problem, CGM we have a lag time. And CGM is not accurate with the numbers. It's more to do with the trend, but CGM is improving. But even if the CGM is going to improve, you know, there is a minority of patients who are developing allergies and infections with CGM. And when they continue to use CGM, there'll be more numbers developing allergies. But I am yet to see a patient on smbg developing an infection with a prick. I have never seen it. So for comparing with the CGM or for monitoring and for deciding on the dose of insulin, this will exist. smbg is going to exist. But I think the message on glucose monitoring technologies and the message of smbg and how it need to be used, it need to be more widely spread among the physician community, not in the form of just guidelines, but and the technologies which we are discussing, the connected meters, the downloading the data, the digital diabetes diary, and they are all fantastic and fabulous, and we are all using it. But many physicians are fearful to use it. But there is a phobia attached to the use of technologies. And we are extremely grateful to all of you sitting over there, the international community, that these extra features with glucose meters are available in India at no extra cost. So thank you.
Just before we move on to, again, Dr. Manoj, you've highlighted one of the very, very critical points. We are talking about technology, but we understand only 2% of Indians are actually doing any form of SMBGs. That, I think, is the biggest problem before we decide upon, the finer bits of monitoring with blood glucose. And one of the points that you've highlighted is, if you look at the barriers of the greater usage of CGM is, of course, the inertia of the clinicians. We need to spread the message better, tell them that the machines are good. But, that 2% of people that you're talking about who actually are using it, what proportion of our patients are we actually empowering them to actually make changes? Because that, I think, again, is a huge problem. So the ones who are even using it, you've not empowered them to make the changes on the basis of the readings that they have, which actually beats the entire purpose of SMBG. So what could we in India do to improve uptake of SMBG and CGMs, apart from, educating the doctors about the machines and about empowering the patients? Dr. Manoj, would you like to respond to that?
Sure. So I think that's where the concept of structured SMBG comes in. I think that's the concept by many of the SMBG companies. From our aspect, from physicians, I think we've been appealing to all our colleagues that every time you ask for an SMBG and the patient comes back to you, spare those few minutes to go through the patient's either physical logbook, diary, or the digital logbooks, to spend some time to go through those readings, to give a feedback as to what should have been done in the interim period, whether it was reduction or increase in insulin or other medication. Look at the patterns. So I think that the important aspect is having a conversation with the patient on the SMBG readings, giving a feedback and encouraging the patient. This in itself encourages the patient to do more. Now, as I said, yes, today, all the integrated care network models which were shown by the three speakers for their company products clearly shows that there is advancement in that. And for those who want to really see those patterns of what is happening only at the pre-meal time, post-meal time, so on and so forth. All that is available. But even where this may not be, and at the time that we're talking about technological advances, for a lot of our patient users, we still want to be as simple and who do not want to get completely bogged down by the intricacies of the advances in technology. Even the simple diaries and logbooks that they write their readings into, I think it's extremely important that we as the physician community do pledge that we're going to be spending time, whether it's us, our diabetes educators, somebody in the healthcare team needs to spend that time with the patient to give the feedback about what is being done and explain to the patient what needs to be done and how to use those SMBG values when they are doing it. Because as you rightly said, doing the value and not taking any action onto that, and worst scenario that as physicians, we just glance at those readings and keep it on the side because we in India here are so busy apparently that we do not value those readings, I think, and sets that complete cycle of discouraging our patients, of non-motivating them to really continue doing the SMBG. In fact, Suja, I think there's a problem which all the three speakers and Jyoti can allude to. When we speak about 2% of our patients probably using, my belief is many more patients today have more than one glucose meter with them in the house, but they aren't using it. So I think the actual capacity of being gifted one or having bought one at some time has been much higher, but the actual active users are much lesser for some of these reasons.
Right, and because we've got three international experts here, in India, for example, a lot of people can't even read. This is a harsh reality. And even the ones who can read, they can only read the local languages. So, we've got mobile phones, which has got local languages. We've got other machines, which are talking machines. So why can't we use simple technology like changing the language to the local language of the glucometer? And why not the glucometer automatically telling us what the readings are? Instead of, thinking of everybody's going to use a smartphone and stuff like that. Personally, I believe in India, things will work better if you use that, all glucometers have the option of changing into 10 different local languages, or maybe even telling out what the reading is. And this could be useful even for people who have difficulty in reading, So why isn't the international companies coming up with machines like that in India?
Yeah, absolutely agree with you. Look, I can speak on behalf of Essentia, but I'm super confident that both of my colleagues on the phone as well can verify that. I'm sure their companies are also doing a lot of work in this regard. And, one of the reasons, which, it just goes to your point about reading and patients not being able to read, but a lot of companies are doing work on products impaired patients, because in any case, a lot of diabetes patients have difficulties with vision. So which would go directly to your point as well with patients who cannot read or are unable to read. I also noticed there was a question within the comments here, and I think it also goes to the heart of this. And one of your colleagues was asking, why are companies not doing more manufacturing in India? I think companies are starting to look at much more cost-effective manufacturing sites. Not only that, many of us are also employing IT facilities and experts and expert positions in India because of the favorable costs. Now, the reason I mention that is that means I'm sure all of our companies are able to bring the price of the product down that we are able to offer and still offer a quality product, which is able to meet the needs of some of the things which you have spoken about.
So, Joy, another big issue in India is with the cost of the meters, because they go for a low-cost meter, and that need not be a branded meter, and the values are going to be inaccurate. So, I would like to get some opinion from all the three of you on how you have enhanced the accuracy of these meters, since many inaccurate, cheaper meters are more popular in India.
Can I just add, be the devil's advocate here and make things even worse here? I used to work for NHS Scotland. So in UK, for example, you don't pay for the meter.
the meter comes free. You buy the strips, you don't buy the meter. And the other problem that people have often told me is, these companies are very naughty. They make you buy a meter today, and after 3 years, those particular strips are no longer available. Therefore, you have to buy another new meter. So what is the solution for both of these problems?
Those same
May I
people will
answer
change.
and
Sorry, I was just making a remark that those same people will change their iPhones every few years. So go on.
I will just speak from more a commercial perspective, but I would also love to hear from my colleagues. But you're absolutely correct. There are many countries where we place meters free of charge. One of the challenges with doing that in India is the very, very low patient testing rate. So normally in countries we're placing the meter free of charge, and then you get the cost of the meter back when the patients are testing, of course. But in India, because of the very, very low testing rate, if you place a meter free of charge, it can take years to recoup the cost of the meter. So if the patients test more frequently, then of course we would likely be able to place the meters at a lower cost or no cost at all, no charge at all.
Yeah, and maybe I agree with what Michael was saying, and the other things to consider is a single strip, as I was showing you with the SugarView products that would definitely tackle most of these issues.
There are some questions in the chat box if you'd like to take those.
I'll let Dr. Sai ask those questions. But last point, I think Dr. Jyotidev and Dr. Manoj, Dr. Banshi is probably listening to us. Do you not think on behalf of RSSDI, we should be doing advocacy, going to the government and telling them, these are people with diabetes in India, 7.5 crore people with diabetes. Even if we are not talking about 100% of the population, even if we are talking about that every patient with gestational diabetes, every patient with type 1 diabetes, why does the government not provide these people with the machines and these people with the strips? For example, in my state, all medicines are free in West Bengal. Whether you're talking about canagliflozin, whether you're talking about linagliptin, but even for the kids with type 1 diabetes, I have had to fight specially to get them the glucometer and the strips, which is still in process. But do you not think our patients, at least we can look at, okay, we won't be providing it to 100% of the population, at least choose out the most vulnerable ones and say, please, Government of India or the government states, please provide our patients with the glucometer and the strips because they deserve it. I think on behalf of RSSDI, we should be doing this. Dr. Banshi.
Yes, I fully agree with you, Sujoy. And this is the problem even with there are ESIS and ONGC, and even we have to fight with them that the glucose meter and glucose monitoring is very, very important in type 1 diabetic, definitely in GDM, but even many of our type 2 diabetic patients also. So it's not just only type 1 and type 2 diabetic, type 1 and GDM patients or only insulin taking patients. And I fully agree that as a RSSDI, we can take some initiative as an advocacy group also we can create, and we must influence the state government and the health department to provide the glucose meter and glucose strip. But one more question to many of these glucose meter providers who are here, because the cost of the strip is also a very major challenge for many of our Indian diabetic patients. Forget the free supply from the government, but those patients who are buying on their own, that's also a major challenge. And that's the reason many of our patients are not regularly monitoring. Even they have the glucose meter, they are not monitoring it very frequently.
So the question of the cost of the strips is always a very valid one. It's how do we adapt our prices to meet the power of people in certain countries to actually pay for those in absence of a national healthcare reimbursement system. So we are collaborating with you and with your various state systems to try to bring the best possible price and to get the best access for your patients to our strips.
Dr. Sai, if you could take some of the questions in the chat from the chat box, please.
During this current COVID era, we have seen a lot of patients' acceptance for glucose monitoring has gone up. And in our clinic, we use a glucometer, which is called by name Glucomi. If a patient checks the blood sugar, the doctor gets an SMS in phone, the reading. And we'll have one diabetes educator also gets the reading. The patient feels very happy, is empowered, he's checking his blood sugars and he's adjusting his diet patterns and his physical activity. So when a doctor monitors, the patient feels very happy that from the app, the doctor gets an SMS of the reading. So I am seeing during this COVID era for the past 3 months, almost 100 plus patients have bought this glucometer for monitoring their glucose levels. So I think SMBG will hold a very important part for at least another 5 years, because even if they check weekly, twice, thrice also, it makes a lot of difference. Because in India, it's only less than 2% of people are monitoring. So SMBG has a very good role. Only thing is, a lot of patients have questions which glucometer to choose. Because choosing a glucometer, what is the difference in compared to the lab? How do we choose? What is the standard deviation? What is the percentage in comparative with the lab and the glucometer? I want the international faculty to just throw on the accuracy of the in comparison with the lab reports.
So your question is about what is the most accurate blood glucose meter?
The question is on whether all the glucose meters are accurate and the comparison with the lab value.
I think the three speakers you chose are representing three companies that have a very long history of focusing on accuracy. And so we can probably not speak for the white label blood glucose meter that are available at low cost, because those are probably not meeting the standards that are required. But for LifeScan, Sensia, and Roche, you can definitely expect the best possible accuracy.
One of the delegates is asking is how frequently we should do the calibration of the meters, even if it is provided by the best of the best company like Roche, LifeScan, or even Essentia. I mean, do they require regular calibration?
A lot of new ones don't, to my knowledge, Banshi. Maybe they can clarify. The new machines don't require calibration, isn't it?
That's true.
Yeah, that's correct. Sorry, Dr. Brady, for jumping in, but I want to say, yes, that's correct. And I also just want to come back to and give you a quick answer on this comparison versus lab value. I would be asking any product or any representative that came into your surgery, I would say, what is your comparison to the lab value? And certainly you should, I don't think you should be considering using a product which is anything less than 10 to 15%, maybe even 10% versus the lab value accuracy. I think if it's worse than that, then you have to question the need for testing. And at the same time, I would answer another question which is in the chat and says, where do we stand with regards to non-invasive testing? Now, a couple of years ago, there was a lot of hype about potential glucose testing from tears or saliva or something like this. And at that stage, I went to our head of research and development and I said, is this a threat to our business? His answer to me, he said, it took us 30 years to come within 10 to 15% versus a lab value in the blood. 30 years. He said, how accurate do you think those non-invasive ones are going to be?
I would just like to come back on that too, and thank you for your great answer. 10 to 15% compared to a decent internal reference is industry standard, and it's better than many of the generic meters that are out there. And all the big companies do their post-market surveillance. Batches routinely go from the factory to clinics. It's not just the paper that was published 4 years ago. There are years and years and years of demonstrated accuracy for the repeated batches that come out of the factory. And that is so important. And I think that is one of the costs that's taken on board by companies like Roche and Ascensia and LifeScan, because we're all continually doing that in the background, and you don't see that with the other small companies. And that's a real difficulty, keeping that quality badge when you don't get any thanks for it, essentially because people don't see it. I would also say that in terms of the CGMs, is a great point. It took us 30 years to get here with BGM, with our 1010 and our 1515 accuracy. If you look at the MARD values of a distribution of CGM sensors in a study, they can be anything from maybe 4% to 25%, maybe 30% MARD. That whole distribution is what the patient gets in their hands every time they buy another sensor. If you look at the distributions of MARD for BGM strips, they're like 3 to 7, you know, for the top class BGMs, and they don't really deviate from that. That means patients can rely on that accuracy, and I think that message really needs to get out across all these regions, that you're dealing with a product that is highly accurate, almost lab accuracy, compared to CGM's still got a journey to go before it reaches that precision that you see currently with BGM, for point values at least.
Okay. Joy and Jai, if I can ask one question, as I can see we're running out of time. One question to all the three speakers. Like in the insulin pump section, we've seen as advances are happening, they're making products which are specific for the developing countries. Basal only patches and simple pumps. Do we have plans from either or all of your companies to have products which are specific for countries like India, which are going to be for a base user, absolutely basic, no advances? You can have the top end products, but to increase the usage, having a base product with minimal cost of the strips. Any such plans for India?
Yes, from our perspective, indeed. Now, the lower the cost of the meter, the less the features you will get. Cannot afford Bluetooth connectivity, cannot afford certain of these additional benefits of the top-notch meters. So it's a trade-off.
Thanks, Julian. It is a challenge. I know I presented the One Touch Select Simple. We specifically took out all the buttons from that meters. We added audio so that it buzzes when it's low and high. You don't need to just fixate on the numerical value. We need to do more. I'm hearing that from all of you. We need to do more on that with the local languages. We could probably simplify it further and take Bluetooth out. Maybe there would be a cost advantage there. I just need to brainstorm that. We need to do better all the time. That's all I can say to you. I'm listening to what you're saying.
And last one more aspect. All of the companies have different lancing devices. I think we could improve upon the lancing devices as well. It's not just about the glucose. The fact that the people who've actually been using it.
It's very important.
It's one of the issues which I feel, particularly my kids with type 1 diabetes, they will come and say, that machine isn't good. And if I go back and ask them why it isn't good, it's more about the lancing device rather than the glucometer.
And they won't be changing the lancet also. They may be using the same lancet several times. That is another
I agree with you, Dr. Jyoti there. Yes.
Yeah, that's a very well-known issue.
Right. Okay. I think we've discussed a lot of issues. You realize that when we are talking about where will SMBG be in 5 years' time, I think it will be much better place than what we currently are. 2% of the population of diabetes in India doing SMBG. I want that up to go up as much as possible. Easily accessible to the entire population of diabetes in India. Affordable. Patients being made more aware in terms of the benefits of SMBGs. Doctors made to understand the importance, overcome the inertia. Creating a milieu or a system wherein we actually empower patients who are doing SMBG so that whatever readings they get, they're able to make the changes themselves and then see what happens to their disease, see the benefits. And of course, getting different kinds of machines to cater to different kinds of population. People who are, relatively more educated right at the top end of the spectrum in India with smartphones. Of course, you want them to have all the fancy apps so that they can take things to the next level. But what I think as a physician, as an endocrinologist, who unfortunately works in 3 different sectors. One is a corporate high-end hospital, one is a university teaching hospital, and then at the level of the community where I work with type 1 kids in villages, I see there is a need of different kinds of machines and different kinds of settings, because India is a big country and majority of the patient will actually be at the bottom of that pyramid, where the market is actually much bigger than the one that you and we are discussing about. So if I was into business, I would probably concentrate at the bottom end of that pyramid, because that's where the scope is.
Nicely summarized.
Final words, Dr. Sai, before we wind up.
Thank you. I thank all the international faculty as well as the national faculty. Thank you.
Thank you.
Thanks, Dr. Sujoy, for nicely moderating the session. Thanks, Dr. Jayaprakash Sai, who is the part of our DTN network member. Now over to Hardik for technology video. Once again, I thank all the speakers and the moderator, Dr. Jyoti Dev, Manoj Chawla, Sujoy, and Jayaprakash Sai.
Thank you.
Thank you.
Over to Dr. Manoj or Mithun Bhartiya to introduce for next session chairperson. Dr. Manoj? Dr. Mithun?
No problem, I am here.
Okay, I am there. So I will introduce Dr. Jyoti, is close friend of mine. Can you just put this slide of Dr. Jyoti Dev? Dr. Jyoti Dev is a technology man of our country. Dr. Jyoti is a FRCP of all London, Glasgow, and Edinburgh. He is also fellow of American College of Physicians, American College of Endocrinology. He is also fellow of RSSDI. He is RSSDI Diabetes Technology Network Task Force member. He had done endocrinology fellowship training at Mayo Clinic, USA. He is a chairman of Jyoti Dev Diabetic Research Center, Trivandrum, Kochi. He is also reviewer of more than dozen index endocrinology journals, including Diabetes Care and Diabetes Technology and Therapeutics. He is associate editor of Journal of Diabetology. He is having multiple awards, and he's having a JDC, which is an JDC center, which is an IDF recognized center for excellence in diabetes care and center of education, which is also accredited center of RSSDI for course of diabetology in India. Over to Dr. Jyoti. Then we have Dr. Shalini Jaggi, who has done a diploma diabetes and diploma endocrinology from UK. She is fellow of Royal College of Physicians from again London, Edinburgh, and Glasgow. She is also fellow of American College of Endocrinology USA. She is a member of Executive Council of RSSDI National. She is a consultant diabetologist and director at Life Care Diabetes Center, New Delhi. She is also attached with the Apollo Cradle Hospital and Clinic, New Delhi. She is a joint secretary for RSSDI Delhi chapter. She is recipient of National Fellowship of RSSDI 2016 and also Fellowship from Diabetes India in 2017. She is recipient of National Diabetes Awareness Initiative Award by Diabetes India in 2017. She is a joint course director of Master Course in Clinical Diabetes for Physicians certified by RCGP and Diabetes UK. She is faculty and tutor of Cardiff University UK and University of South Wales. She had done her observership at Joslin Diabetes Center, Boston, USA. She is a certified trainer for insulin pump, CGM and FGM. And over to Dr. Jyoti Dev and Dr. Shalini for the next session of insulin pump. Dr. Jyoti.
So thank you very much, Dr. Banshi. Once again, congratulations to Dr. Banshi for arranging this mini ATTD in India. So I am getting a lot of positive feedbacks from the doctors across the country for this very unique event. So next we are going to have the insulin pump symposium. So insulin pumps have been a very passionate topic for me. How many of you know that insulin pumps were launched before insulin pens? So pumps have been around for almost half a century now. So we started off with big pumps, and then came the smart insulin pumps, and then the sensor augmented pumps in 2006, and then came the pumps which can eliminate hypoglycemia, and then the hybrid closed loop systems, and then the artificial pancreatic systems, and now it is the era of do-it-yourself artificial pancreas. So we have three giants for the next session, and I hand over to my co-chair, Dr. Shalini Jaggi, for introducing the first speaker.
Thank you so much, Dr. Banshi, and thank you so much, Dr. Jyoti Dev. So our first speaker is Dr. Ohad Cohen, and I think most of us who use insulin pumps would know him well. He's the medical director at Patron Diabetes. He's also associate professor medicine at the Institute of Endocrinology at the Sheba Medical Center and Sackler School of Medicine, Tel Aviv, Israel. He is active in promoting better care of diabetes with the use of technology through research and education of healthcare professionals and patients. So over to Dr. Cohen, please. And he's going to take us from MDIs to automated delivery, all the clinical evidence that exists for these.
Thank you, Dr. Banshi, for inviting me, and thank you, Chairperson, for your introduction. I will share my screen right now, and we can start the presentation. Good. I hope it's all clear, and we can start. And the request for me was to discuss the journey.
Have you shared the screen?
I think I did. If I didn't,
it's not visible. Shalini, is it visible for you?
No, not yet.
All right.
Apologizing. I see it's on my screen. It seems to be.
Maybe you can again stop sharing and share again.
I will do this. I will do this exactly in a minute.
Because we are very fortunate to have Medtronic, and that is the first speaker who introduced insulin pumps in India.
I will do my best. Now it's visible. Fantastic. So we will be in a minute. So I'll speed up. So I will not take.
No, we are on time. No issues.
We are in time. Then we're good.
Yeah.
Are we good now?
Yeah, good. Good to go.
I'm good to go.
Make it, yeah, you need to make it full screen. Yeah. It is appearing. Yeah, now it is good. It is okay to go.
Fantastic, fantastic. Okay, so thank you so much. And again, I was requested to do a small presentation of a journey from MDI to insulin to automated insulin delivery, which took more than, as you just described, more than 40 years. And you wanted me to do this in 20 minutes. I will try, but then I'll have to be a bit short on too much on the background. So I'll go straight up and say, why do we need automated insulin delivery? Why can we not have enough with the what we have discussed before? We said smbgs, insulin pens, and so on. And the reason is that we are unable to get to the goals of therapy in type 1 diabetes that we wish to. And that is not only in countries that are using SMBG in almost all of their patients, but even those countries who are started to use CGM in almost 40% of their population with type 1 diabetes, we can still see the famous slide of showing that even in the last 10 years, there has been I would not say an insuccess to reach beyond the goals that we want to reach, and that's an A1C below 7. And later on in the next sessions on CGM, we'll discuss. They will also be discussing the time in range. Now, I added here a new slide because it tells us the numbers that we see in the percentage of patients who reach goal. On the right side, in the UK, just published during the COVID epidemic, that less than 15% reach an A1C of less than 7. We look on the left, another new, just brand new publication looking and comparing the type 1 exchange in the US and the DPV cohort or registry in Central Europe, Germany, and Austria. And we can see that in both countries, the obtainment of an A1C of goal of less than 7 is not reached in the majority of patients. So there is a lack of success on reaching the goals that we want our patients with type 1 to be. The question is why? And the answer is not simple. Okay, and the answer is not simple because getting to the control that we want our patients with type 1 diabetes to reach is difficult, and I will just main 2 reasons or 3 reasons. Number 1, you need to be accurate in assessing the carbs that you eat in order to have a correct bolus for meals. And we see it again and again that almost 60% cannot do this accurately. And not only that, the people with diabetes actually complain that counting carbs every time they eat is one of their biggest burdens. And then when you go to the correction boluses, and I think this was discussed in the previous sessions, to do a correction bolus is go through a whole mathematic kind of a program. You have to calculate how far you are, what's the trend, what are you eating, what are your exercise, and so on. So correction bolus is also very difficult. And even if you get the counting right and you get the correction boluses right, then it's right for what? For a specific day, but every day is different. So you have a huge variability in the glycemic control between day to day because counting carbs and correction boluses are only 2 of more than 40 different aspects or on the glycemic control. So every day is different. Very difficult for patients to get to the glycemic control that they should be to prevent future and complications. So what do the patients do? They need a lot of data. Again, discussed before. So patients who do a lot of SMBGs, even have more than 10, it is associated with lower A1C. Scanning. If you do scanning, you can get to a better A1C, but it requires almost more than 40 scans a day to get a time in range of about 70%, and almost more than 20 scans a day to get an A1C below 7. And the patients cannot get to this level of follow-up and this level of dedication and to the treatment of their diabetes. Now, I want to stop here and say, before you go to the automated insulin delivery and the future of the devices, it does not mean that we should not continue to do the best we can with the SMBG and the scans in the situation that the markets cannot afford to have these fancy devices that I will talk about. So still, there's a lot to do, even though there is a glass ceiling that you can reach with these it's important to get as much as you can to that glass ceiling. So that's important to not forget what we have in the past before we jump to the future. So having a lot of SMBGs, a lot of scans provide information, and the output of this information is frequent bolusing. And we know that the more boluses you give, the better control you have. And this is the classic DCCT data. 2 injections a day was the control. Multiple daily injections were in the intensive group, and those who had a more intensive regimen received a better control. But the burden on the patient is incredible. This is just one day of a patient with type 1 diabetes. I'm sure you're all aware of this. The outcome of this is that patients, when they are not in a strict study like the DCCT, once they go to free living, they cannot continue with this amount of burden, and they go back to higher A1C, higher than the goals that we want. So what is the solution? That is why we need to think about a new way to treat type 1 diabetes, away from the classic thought that we can base the therapy according to the past, rather than now, how about using the same elements, the sensor, the sets, the data management system, and the glucometers. How about getting them together with the pump, but in this time, the pump is the one who's going to define the insulin therapy and not the patient. First step was, let's start with automating the basal rate. And that was the 670 system. That was the first automated insulin delivery that reached the market. It only automated the basal rate. So instead of having a basal rate based on the past, it defined the basal rate by giving small boluses every 5 minutes, and every 5 minutes it was an independent bolus, taking into account the whole algorithm to see if this amount is safe and if this amount is adequate to the dynamic of the glycemic control. But not only the glycemic control, it also has individualized patterns that is dependent on the patient's specific characteristics. And these characteristics are changed, adapted every 24 hours so that it will match the patient's need in real time. What were the results? Here you can see on the left side the way that glucose is controlled in the manual way. On the right side, you can see a much smoother glycemic control with less variability in the glucose, but you can see that this less variability in the glucose is actually secondary to an increase in the variability of insulin, which is much more imitating the physiological way that the pancreas works. So what are the results? Because the theory is nice. What does the outcomes of studies and real-world data provide us? So the pivotal study was the first study that 124 patients were assessed in the ages of 14 to 60 to 75 for 3 months. And it's the first time that the average of the time in range was above the threshold of 72.2, and the A1C below 6.9 as an outcome. When the numbers of the study were then compared to the real world data, it was incredible. So this is a bit old. This is half a year of data. The new data will be presented at the ESD in a couple of days. So this were the first 8,000 patients that were using the 670G in Europe. You can find almost identical results of 71.1% time in range with an A1C of 7, and with almost no hypoglycemia. So it's the first time we can see that studies provide the same results as the real world data, and it's not surprising because it's not run by a better or a worse patient, a physician, or a more educated or less educated patient. It is run by an algorithm that is really doesn't know who's running it, who's putting the pump on. But here we found out that if we looked at the different patterns of patients, those who started the auto mode with a lower A1C, and we compared it to those patients who started the auto mode with higher A1C, we see 2 different populations that both improved by automated insulin delivery. Those with a low A1C had a high time in range, but improved time in range while decreasing hypoglycemia. This is the first time we can see improvement in both time in range and decrease in time below range with a therapy. Usually, remember the DCCT, lower A1C, higher rate of hypoglycemia. But when you look at those with a high A1C at start, we can see a significant improvement of time in range from 35.8 to 58, 20%, almost 8 hours of improvement in their time in range with no increase in hypoglycemia. But still, they're not there yet. So just improving the basal rate, not sufficient. That means, how about improving the algorithm to provide more than just automated insulin delivery for the basal rate? Here comes the next level of automation, and that's in the 780G, which has been approved by the CE mark and in Europe, and will be launched soon. And what we can see here, that beyond the automation of the basal rate, as we can see here, again, the 780 has a lower threshold of a lower target of 100. I will not go into these two details because of lack of time, but the important thing that it has, in addition to the auto basal or automating the basal, you have automation of the correction bolus. Remember, we discussed how difficult it is to do the right correction boluses. Here, the new algorithms, I call it correct the correction bolus, because we are used to tell our patients to do something wrong. Wait till the blood glucose is high, then do the calculation and give a bolus and hope that it will be enough. Well, the pancreas doesn't work this way. Actually, the pancreas does not wait for the blood glucose to go high, but the moment the blood glucose is increasing above a threshold, the pancreas starts to secrete the insulin. And this is the same way that the autocorrection works with these new devices. It gives a small boluses of corrections, but very early on, once you can see those blue lines, when the blood glucose is above a certain threshold, a certain target. This is how it looks in real life. You can see that the patient has the blood glucose very stable during the night. You can see that after the meal, there is adjustment of the bolus according to the meal, and after the meal, it's not automatically. If it's low, it stops the basal rate. If it sees the dynamic going up, it will increase the basal rate. But what's interesting, look at this point over here. Sorry about this. Okay, here there was a intentional missed bolus. So the patient knew he was eating. It was during a study, did not give a bolus, and we can see that once the threshold was met, small autocorrections were started, and the lack of bolus was mitigated a bit by the device itself. Of course, you can see that giving a bolus before a meal it's the way to use these devices. But if somebody is not accurate, if somebody forgets, the payment is less because you have something to correct the autocorrection. So from the patient's point of view, this is before, this is after. We can see how the advent of using automation for the patients is improving the patient's burden and his satisfaction. Let's talk about studies and results. So what does the autocorrection add on top of the autobasal? So here is the pivotal study for the 780G, and here we can see it was done in the US, and here we can see that using the autobasal with the autocorrection, you see an improvement in the time in range from the baseline. Remember, the baseline is what? It's not their MDI, or the baseline was their short term that they were using the baseline to get the readings right. So the short term before turning the auto mode on, time in range is 68.8, increased to 74.5 when you look at all the group, and when you look at the group that actually use the settings as they are intended by the algorithm, that means with a target of 100 milligrams per deciliter and active insulin between 2 and 3 hours, you receive a time in range which is 75.4 with a calculated A1C, in this case the GMI, of 6.7 with almost no hypoglycemia, very low levels of hypoglycemia, safe and very effective. So the picture is changing. Remember these perpetual reports that people with type 1 diabetes, most of them are not reaching the goals. Using automated insulin delivery system, we can see that it's the opposite. Actually, in the case that was done in the pivotal, almost 79% of the patient reached the time of range of above 70. On the A1C, this is for the whole group, but when you look at the specific group of those patients who were using the target of 100 and an active insulin time of 2 to 3 hours, almost 65% of the patient reached the target of A1C. So this is a big, I don't like to use the term, but it is a game changer. Now we can be more secure that when you use a specific device, you know that in the majority of patients that use this device, they will get to the goal. And if you look at the overall picture now, we can see that there are many devices. There are CGMs, there are smbgs, there are smart calculators. All of them improve. That's what I said before. They're all improving the control of the patients, and every improvement is important. But if you really want to get to the box of where the target today is, time in range above 70, and an A1C below 7, automation is actually the major player, if not the only player, that can provide most of the patient to reach these goals. So I just want to end in this new concept that usually, we discussed that, and I'm talking also on the development market, that they used to use the more sophisticated automated insulin delivery in a stepped care. That means the typical patients can start, that does not count so well, not always remembering to bolus. They need simple things like MDI and CGM and so on. But if they are good students and they go to the University of Pump Therapy, then they deserve to go to the most sophisticated automated insulin delivery. By looking at the data and seeing that actually those who were doing worse improved the most on automated delivery, we like to turn the pyramid upside down, and actually being affordable. Probably most of the patients should be thinking about automated insulin delivery, but those who have specific issues, and I think that it was mentioned in the previous call, skin reactions. Now these things are coming much more into play because they might be a burden or a barrier to get more patients on automation, like was mentioned before. And with this positive outlook to the future, I would like to end, and thank you very much for your attention. Thank you so much.
It was a very, very nice narration of the past 40 years. From Minimed to 640 to 670 and to the most recent 780G and almost 80% time in range. So very, very we'll have the detailed discussions later on at the end of the 3 sessions. Shalini, please. Unmute.
So thank you, Dr. Cohen. We now move on to our next speaker, who again is going to take us through a very important concern that all of us have when it comes to injectables, how to inject. So, so moving on from syringes to self-injecting devices. The journey will be covered by none other than Dr. Ian Thompson, Vice President, Business Development Delivery, Ypsomed AG. So over to Dr. Ian Thompson, please.
Ian, we can see you and you can unmute. Yeah, perfect.
So can you hear me as well as see me?
Yeah, both.
Yes, we can.
Very good. Thank you very much. Thank you for the invitation. It was a little bit short notice. I'm doing this on behalf of my friend and colleague, Mr. Sanjay Rajpal in Delhi. And what I'd like to do, I mean, Ypsomed is a company historically that sold its insulin pump business to Roche. And as you know, we have been back on the in the insulin market now, insulin pump market for about 4 years. And our insulin pump is being rolled out in India this year in 2020. What I'll do then, I'll just share my screen. And can you see it?
Yes, we can.
Very good. Okay. So I actually represent Ypsomed Delivery Systems. So I work very, very closely with pharmaceutical companies in what we call B2B, business to business. So I've been with the company at Ypsomed now for 25 years. I'm sitting here in the office here in Burgdorf in Switzerland. I live in the same town, so I've been coming to the office every day during COVID. And what I'd like to do really is just to give you an idea of the type of work we do here at Ypsomed and the type of development. You can still see my screen, it's fine, yeah? Can you hear me?
Yes, please.
Okay. So Ypsomed has two business units. We have a diabetes care business unit that looks after, of course, the insulin pumps, BGMs, therapy management, and pen needles. And today we have a complete system of insulin pump therapy. We are also collaborating with Dexcom. And as you probably know, we also have the YpsoPump, which works in conjunction with the 1.6 ml pump cart from Novo Nordisk. But what I'm not really going to talk so much today about pump therapy. I'm just going to give you a little bit of the history related to how long insulin pen and self-injection devices have been around and how they have been developed. So what I'd like to do is give you a little overview of the injection device market, the platform approach, which is how we work very closely with our pharma customers, as well as to give you some information about the trends in terms of large volume injectors and connected devices. Because, of course, insulin is not the only therapy that is self-administered today. And these trends are, of course, insulin is typically the first therapy that takes therapies beyond just the simple injection. But there are many, many new therapies coming through. If you look at the development of self-injection devices, it's true to say that we did launch the very first insulin pump in Europe under the name of Disatronic in the mid-1980s. So you are correct that small wearable pumps have been around just about as long as the pens have been around. But the very first pens were launched in the middle of the 1980s, mainly from Novo, Höchst, who we were working with, and also for things like growth hormone. It wasn't until the 1990s that the first disposable pens were actually launched. But these were very simple devices. And in the 2000s, these pens were further developed with gearing to allow good visualization of the dose and to enable the actual simplicity, if you like, of performing the manual injection. The gearing actually makes the injection procedure much more comfortable for the patient. Today, there are probably around 15 or more disposable pens on the market for various therapies, mainly peptides and hormones, including insulin. And, the benchmark has always been Novo as the leading insulin company. And today, they even have spring-driven devices on the market based on the FlexTouch technology. Another area that's really grown recently, and I think it is relevant today because we're talking about diabetes treatment, and that is auto-injectors, which are becoming pretty important in the treatment of diabetes, type 2 diabetes with GLP-1s. So, in fact, the very first auto-injectors, and of course an auto-injector is not a pen, although some of them are called pens, auto-injectors are utilized mainly for antibody therapies for autoimmune diseases. And the very first ones, pre-filled, were only launched in 2006 for Humira and Enbrel, drugs I'm sure you're very familiar with. And today, there are now over 25 to 30 different disposable auto-injectors on the market, and they have developed, just like the pen technologies, to a level of maturity which is very, very good for moving on to the next topic that I'll go and talk about afterwards, which is manufacturing these platforms in very large quantities. The auto-injectors have become passive, in fact. This is a device that we just recently launched with Mylan, which is an adalimumab biosimilar. And this device, the patient actually inserts the needle manually, and the injection is activated automatically as soon as the needle is fully under the skin. So, in fact, these pre-filled auto-injectors have lost their buttons, and they have become more manual devices, but simpler to use. If you look at the world of self-injection, there are around 50 million diabetics in the world today injecting themselves with insulin. Of course, around 80 to 90% of those are type 2s. And each year in the world, and of course, this is a market that's dominated by Novo, Lilly, and Sanofi, around 11 million reusable devices are sold. I mean, for instance, we are, as an ODM company, original design and manufacturing company, we are one of the largest manufacturers of reusable pens to independent insulin manufacturers. For instance, we work with Biocon in India, and we're selling our insulin pens, for instance, for the Indian market, as well as for the Malaysian market, where Biocon is also manufacturing insulin. And in total, 1.4 billion disposable insulin pens are manufactured. There are not so many sold and utilized in India as yet, and I'll go on to talk about that in the next slide. But if you look at this slide, of course, we have the pen markets, which are for insulin, GLP-1s, growth hormone, PTH, FSH, and then we have the main auto-injector markets, which I guess I don't have to go into too much detail, but just to show you that the markets for auto-injectors are growing significantly for the treatment of autoimmune diseases and other therapies. Going on to talk about the GLP-1s, and maybe, can you actually see my my laser pointer, can you see my, you can see the laser pointer, yes?
Yeah, we can see the laser pointer.
Okay.
We can see it, yeah.
And can you see my mouse if I switch it off? Can you see my mouse as well?
Yeah. Mouse is visible, but laser pointer is better, but mouse is also visible.
Okay, very good.
Yeah.
So if you look at the market for GLP-1, which is dominated, of course, by Novo and Lilly, there are nearly 90 million disposable auto-injectors are manufactured already just for the injection of Trulicity, mainly, of course, in the American market. I mean, that is clear. But there are also many people, of course, using Ozempic and Victoza around the world, which are utilizing disposable pens from Novo Nordisk. On the next slide, I'd like to actually show you some analysis that we have recently done. We have the IQVIA data for parenteral drugs, and we've been analyzing the number of millions of milliliters of U100 insulin equivalents around the world, and we have been analyzing it. It's very important for our business in terms of who is using disposable pens in green, cartridges with reusable pens in red, and vials in blue. And here you actually have a nice overview of the proportion of patients that are using pen devices for their therapy in different regions of the world. In Western Europe, it's mainly disposable pens. In US, which is, as we know, a bit more of a free market healthcare system, we have about 60-40 disposable pens to vials. In China, it's almost all pens. And in India, it's about 60-40 vials to pens, as I'm sure you're aware. And the disposable pen proportion is quite low. And then you can see this tailing off for all of the different areas of the world. But this has been very valuable for us to analyze the market and see where the growth is, for instance, for disposable pens and reusable pens around the world. And because in India you have a lot of out-of-pocket payment in healthcare, you still have quite a lot of vials in the market. If you look at Saxenda and Victoza, Ozempic, and Trulicity, in terms of the GLP-1s, we have analyzed the market, and you can see here that really the growth of the GLP-1s in value terms, particularly in the Western world, is now going to grow over the next 5 years to be as large as the global insulin market in terms of value. I don't know how well established the GLP-1s are now in India, but it would be quite good to have that as part of the discussion after the talk. So, what do we do at Ypsomed Delivery Systems in terms of developing and further developing these technologies? We are working on what we call platforms. If you look at Lilly, Novo, and Sanofi in the diabetes market, they work with platform devices that they develop themselves and then have them manufactured by contract manufacturers in a fully automated way. And one thing that Ypsomed has been doing over the last 14 to 15 years is developing these products, and I'd like to give you some insights as to how we develop these products and how we manufacture them. So with the development of these platforms, we are actually developing these products, these mature products, in conjunction with who is this laser pointer? This is not me. Could you take it away? Okay, now it's gone. So we are developing these platforms with developing our own technologies, doing our own human factors, building up flexible capacity with these products, and building up end assembly expertise, and then working closely with the pharmaceutical companies to provide these products quickly and easily for clinical trials and then for commercial launch. The reasons that pharmaceutical companies do this in order really is so that we are innovating on their behalf up front. We are reducing risks. We are making it easy for them to get to market and to the clinic and the pharmaceutical companies do not have to make any big investments because we are managing the whole process. These devices have now have now reached a level of maturity, but it also means these devices are actually quite complex. They are typically designed with about something like 14 to 16 plastic parts, and they are manufactured on fully automated equipment. If you look at our reusable devices, on the other hand, that we are manufacturing, they are typically manufactured locally, either in India or in China. But if you are looking at these fully disposable devices, they are manufactured on fully automated lines, typically here in Europe. And the big advantage, of course, for the pharmaceutical companies is that they can just source these products directly from us for the different therapies that they are handling. And as you may know, the world of drugs and medicines is becoming more and more therapy specific. So the quantities that that the pharmaceutical companies are looking for are typically much lower for future therapies than in the past with just big single blockbuster therapies. So now I'd just like to talk a couple of minutes about some of the trends in the markets for injectables and for self-injecting devices. It was a really, there was a philosophical idea about over the last 10 or 15 years that for the use of auto-injectors, for instance, for the GLP-1s, that a patient could only inject 1 ml in one go. And that has been shown to be wrong. We have just recently launched a migraine drug in an auto-injector with Teva for their drug Ajovy for their CGRP. And it's a 2 ml injection, or it's a more than a 1 ml injection. And this is really a trend that is coming through. You see it for the GLP-1s with the once weeklies that are injected 1 ml once a week. And I'm sure we will see GLP-1s in the future that are injected even less frequently. The other big trend that we are seeing is the use of connected add-ons that are being used for our devices, but mainly the connected and digital add-ons that are being looked at for these kinds of devices are mainly for higher value drugs. There is some focus on having connectivity for insulin pens. Novo Nordisk is working on this at the moment. And there is also some activity in terms of having connected add-ons to work in conjunction with CGM or flash GM in order to actually get closer to what you would call a pump therapy. So we believe that there will be a trend in the future of utilizing connected add-ons or reusable connected insulin pens as part of allowing type 1 diabetics to move to something that's getting closer to insulin pump therapy. There is another area that we are working on, which I thought I could introduce you to today. I know I'm not talking about insulin pumps. I'm talking about something called patch injectors. And this is an area where there is a huge demand beyond autoimmune diseases to provide larger volume injections with payloads of antibodies in, let's say, between about 400 to 500 milligrams up to about 1 gram of antibody. A lot of the focus is actually in the cancer market for drugs that are moving from IV to sub-Q, like the checkpoint inhibitors and the PD-1 drugs. And there is a huge move towards even less frequent injections. let's say from weekly to every 2 weeks, more towards monthly or quarterly injections. And these are the kinds of patch injector technologies that are being developed. And this is the kind of device which, it's similar to an insulin pump, but of course, all it's doing is giving a fixed injection within a very short period of time. And these are the types of systems that are being developed for these new kinds of therapies. Of course, we have done a lot of human factors work on this, and for the sake of time, I think I will move on to connectivity and talking a little bit more about smart devices. It's obvious that we are going to have connected devices moving forward in our world of self-injection devices. And initially, we are looking at reusable add-ons. We have something called Smart Pilot for our auto-injectors, as well as Smart Pilot for our Uno pen, which is our pre-filled disposable pen. But in the future, we will see connectivity integrated into those disposable devices. And this is the first product that we currently have. We can actually take an auto-injector and make it connected, and with Bluetooth connectivity, it will talk to automatically to an app. The only issue around this, of course, it has to be fully integrated into the ecosystems that the pharma companies are building up. And we are collaborating, for instance, with Philips Health Suite, which has an ecosystem into which our systems work. Because if you have these systems, just as Medtronic would have with their insulin pumps, you have to have ease of integration of these systems into the ecosystems of our pharma customers, or we manage them directly ourselves in the case of insulin pumps. We have to actually manage the life cycle of these devices. We have to plan them, provide them, configure them, monitor them, and retire them. And finally, we also have to provide encryption so that they are anonymized and not and completely safe to use. So just to summarize, I know I haven't talked much about insulin pumps. It's not really my area of expertise. But what I really wanted to do is give you a flavor of how devices are how they exist within the global economy of healthcare. That these technologies have matured over the last 30 to 40 years. How they are compatible with what I call platforms, because this really helps pharma get these devices to patients efficiently and economically. And that there are really two big trends in the market for these therapies, which is larger injection volumes, less frequent injection volumes, and a new class of self-injection device, which is the patch injector. And on that, and of course, that connectivity will become something of the future. How quickly, though, is another question, and we really have to talk about that maybe in the discussion. So thank you for your attention, and back to you at RDDSI.
Thank you so much, Dr. Thompson, for taking us through different self-injecting devices. And with this, Dr. Jyoti, please.
Please, you can continue. Shanley, please continue. Yeah.
Okay. So now we have another speaker who is going to take us into the future on insulin delivery. So I welcome Dr. Julianne Mader. She is Associate Professor of Medicine, Division of Endocrinology and Diabetology at the Medical University of Graz. Professor Mader's research is focused on diabetes technology with emphasis on insulin pumps, CGM, artificial pancreas, and the decision support systems for the treatment of diabetes. So let's have Dr. Mader talking to us on the insulin delivery, what we have today and the future. Welcome, Dr. Mader, please.
Hello, thank you for the kind invitation. I'm just trying to share my screen in presenter mode. Can you see it now?
Not yet.
Not yet?
No.
You may just want to share, Julia. Yeah.
Yes, now it's visible.
Now it's visible. Very good. Thank you. Sorry. So it's my prime time here on Zoom. Sorry. So I'd like to talk to you about insulin delivery today and potentially in the future. And here is my list of conflicts of interest. And this lecture today was sponsored by Roche Diabetes Care. So what I would like to talk you through is insulin pump therapy, what can be expected, the difference between patch pumps and durable pumps, novel developments in insulin pump therapy, a short look into the ProSolo study, where also Medical University of Graz participated, shortly touch non-modular versus modular automated insulin delivery systems, because Ohad already covered a lot of that, and potential outlook of insulin delivery in the future. So what can we see by using insulin pump therapy? There was a meta-analysis performed by Dr. Pickup from London, UK, and we could see that there is a reduction of HbA1c by 0.5 to 0.6% when using continuous subcutaneous insulin infusion compared to insulin therapy delivered by an insulin pen. And what we can see here, the larger the HbA1c, the larger the reductions are when using or switching to multiple daily injections to insulin pump therapy. But not only glycemic control can be improved, also we can see, so I cannot proceed to the next slide here, sorry. We can also see a reduction in severe hypoglycemia when using continuous subcutaneous insulin infusion compared to multiple daily injections. But what is the important thing about insulin pump therapy? Is it really the insulin delivery mode, or is it nowadays even more important how we measure? So that was an analysis done from the type 1D exchange registry from the United States with about 17,000 participants, all type 1. And what we can see for different age groups, so here to the left we have the younger ones, so below 13 years of age. Here we have the young and adolescents, 13 to 26 years of age, and here the adults above 26 years of age. And here we see the HbA1c distribution in black for pen therapy using CGM. In white, we can see insulin pump therapy in combination with continuous glucose monitoring. Then the next bar shows us pump only, and here we have multiple daily injections only. So what we can take from here, in all age groups, we see that there is no big difference between HbA1c when it comes to the insulin delivery mode. So it's more important to measure glucose with a sensor than the insulin delivery mode. And that is potentially true because the more modern insulins we have, they are kind of more stable and provide us with very good control. And the meta-analysis done by Dr. Pickup, of course, was already a bit of age, and we did not have all the modern insulins we have nowadays. Still, of course, it's very important to have insulin pump therapy, and it should be mainly based also on patient preference, what patients want to use. So if there is a person having fear of injection, of course that person would benefit from an insulin pump, but it's not only the way of delivering insulin, but mostly the way how we measure glucose that has a big impact. So when we come again to the choice of insulin pump, what pumps do we have available at the moment? We do have patch pumps that in most cases are used by a remote control, and they transfer the signal to the pump, and the pump delivers then again the insulin to the body via an infusion cannula. In contrast, the durable pumps, they have a tubing system and again, an infusion set. In that case, the infusion set can be made of Teflon or of steel and is then delivered again to the subcutaneous adipose tissue. So here again, we come to patient preference. For example, people who have small children sometimes have the issue that their children play with the pump, and so the infusion set is disconnected. So patients can, for example, benefit from a batch pump. The same is true for sportive people who do contact sports. They may benefit from a patch pump. So what other advantages are there? There is no needle visible. So for people who have like a fear of injection, they might prefer that mode of delivery because they do not even see the needle when they insert the new cartridge to the body. There is obviously also a reduced risk of tube occlusions. The training can be simpler. The size and weight are smaller. There is a remote control, so you can be more discreet when delivering your insulin bolus, maybe when you're in a restaurant or out with friends and you do not want to show that you have diabetes and that you need to deliver insulin. Of course, there are also some limitations. There is the environmental impact, so we do have potential insulin wastage if we fill it to the limit and we have to exchange it whenever we have to exchange the pot. The site is not visible, so if there is an infection, we potentially cannot see it. There is ongoing discussions about accuracy of patch pumps, but we have seen at ATTD that both basal rate and also bolus insulin delivery is quite accurate also with patch pumps. Of course, it may be difficult to move. So if you use the spots, that's not kind of the perfect spot. You have either to change the complete insertion site, or if it's kind of disturbing you when wearing your clothes. So it's not easy to remove during use and you have to reinsert the whole patch. Of course, it is an additional device and it mainly also comes to cost. So how much will the cost be for a patch pump and is it covered by insurance companies? But most important, again, patient preference, because if the patient doesn't feel comfortable when we kind of recommend to him a durable pump, then we will also not succeed in the treatment. Same is true for a patch pump. If the patient is not happy with a patch pump, we will not succeed in the best possible results that we could achieve when sufficient effort is put into it. So I shortly now want to introduce you to the Accu-Chek Solo Micro Pump. That is kind of the new kid on the block when it comes to patch pumps. And we do have parts that are disposable, that are to the left, and we have reusable parts. So we have the reservoir that can be filled with 200 units of rapid-acting insulin. We do have the cannula assembly, and it's a Teflon cannula that is then within the body. And we have the pump holder. So for example, if we have a person who can go on for 3 days with cannula and the pump holder, but requires to fill the reservoir more frequently, we can keep the same insertion site for the whole 3 days, but exchange the reservoir. We do have then on the other hand side the pump base, the diabetes manager, where we can also use for glucose monitoring, and the insertion device. So you have to put the cannula into the insertion device, choose the insertion site, and inject it. It's quite an easy process. It's a bit noisy what we've heard from our patients during the study, but there was no pain reported in the patients. So just to show you again the components and how you click the pump into the pump holder, and to give you a short view how the size is of the pump. So it's quite tiny compared also to the competitor. And what is very beautiful, we have two insulin bolus buttons on the side, so you can deliver an insulin bolus even when you forgot the diabetes manager at home. So you have to pre-program the pump, and then one press with the buttons would deliver the predefined amount of insulin that you require. So what other important aspects are to be considered when using insulin pumps, and not only insulin pumps, but also glucose sensors? We have reports from severe skin irritations seen in patients, and in many cases that's associated with the component isopropyl acrylate that is in the adhesive, and can cause contact dermatitis. And there were studies performed looking into the difference between the Eversense system and also the Accu-Chek Solo micro pump. And what we can see here compared to other sensors and other patch pumps, we do see quite low solvent extraction when using isopropanol, ethanol water, and sweet sebum. And this is potentially the reason why we see less skin reaction towards the Accu-Chek Solo micro pump. Again, we need to discuss who benefits from such a pump. What we can see that very young children potentially benefit from patch pumps, also children and adolescents. Here we have especially the advantage that it's not adhered to the clothes, but can be directly worn on the body. Also potentially for older and frail people with diabetes, because sometimes they also are forgetful and they might strip off their infusion set when removing their clothes. There have also been first reports on pregnant women using patch pumps, and people with diabetes who have other barriers to other insulin delivery systems. So, but of course, we do not yet have very big database for cost effectiveness, and we do still lack that information, which will be essential for further funding in the future. And of course, user acceptance also needs to be addressed, and this is what we did in the ProSolo study. So this was one of the, or was the first study who looked into people native to insulin pumps. So they were previous MDI users who had diabetes at least for 6 months and who were adults, so defined as being above 18 years of age. And they were then randomized to either continuing multiple daily injections, to switching to the Accu-Chek Solo pump, or switching to the Omnipod 2, using that treatment for 26 weeks. And then the primary endpoint was assessed at 26 weeks, and the primary endpoint was treatment satisfaction. We also looked into device satisfaction, device performance, hypoglycemia, glycemic control reported by HbA1c, and of course, very important with a patch pump, the material consumption and waste. So we just finalized the study in summer. So it was performed in 4 countries, in Austria, Germany, Poland, and the United Kingdom. And 180 patients have been included in the study, and we will report the data later on this year at EASD. So just to go a little bit along the discussions that already Ohad was covering. So I want to shortly touch the field of automated insulin delivery. So what does such a system is composed of? We do have the glucose sensor, we have the algorithm, and we have the insulin pump, potentially also in combination with a glucagon pump. And how does it work? We have the person with diabetes, where we get the glucose signal from. It sends the sensor data to the pump or to the device where we have the control algorithm, and then the dose is adjusted, and the insulin pump delivers the new correct basal amount of insulin. And what we have heard in the previous talk, we do have the non-modular automated insulin delivery systems, where we have the same manufacturer for insulin pump, glucose sensor, and the control algorithm, and it's approved as a single product. and the patient has then to stick, of course, to all of these components, also potentially if he or she do not like one or the other of the components. And the FDA just of recent, so it's now 1 year old, approved also interoperable insulin pumps, and the Roche micro pump is one among those who in the future will claim being an interoperable insulin pump, because that allows the patients to customize their treatment through their individual diabetes management devices. And I will come back to that in a short moment. Just to mention, we had a very strong campaign, especially in the United States, having fast approval also for that non-modular automated insulin delivery device with a girl pretending to inject insulin. We had a heap of needles in front of her, and that was kind of a story being very heartbreaking also for the authorities, and resulting in very, very fast approval of insulin delivery systems. And what could help if we do not have like a whole system to be approved, but kind of a modular approach. So we have this interoperable, or also called ACE pump, and that pump then can be combined with a glucose sensor, with a glucose meter if required, and with a control algorithm. Each product is then approved individually by the regulators, and the patient has more choices to combine the products that he or she prefers. And of course, one component can be exchanged earlier than the other if the patient is not happy with one of them. So I also wanted to give you a short outlook, what could be the future of insulin delivery. So people still are looking into single port concept, where we do have the insulin infusion site at the same site as we measure glucose, especially in small children. That might be of relevance because we have less trauma, less injections, if we can use the same site for glucose sensing and insulin delivery. Extended catheter wear time, also to fit extended sensor wear. So especially when we look into single port, it doesn't make sense if we have to exchange the catheter every 3 days, but the sensor can continue up to 14 days, for example. Then there could be customizable algorithms also telling us when to exchange the infusion set. There can be improvements of meal recognition and unannounced meals, especially when talking about automated insulin delivery. Faster insulins will need to be investigated. So what we've seen also for at this year's ADA, especially time below range can be reduced by faster insulins when using them in combination with automated insulin delivery. Of course, other agents beyond insulin could be of interest, such as amylin and glucagon, but the future will teach us what is essential in that field. So I'd like to give a short summary what we had discussed in the last couple of minutes. So we had seen in history that there is an impact on HbA1c and hypoglycemia by insulin pump use. However, we have to keep in mind glucose measuring technology is more important than the way of insulin delivery when not using it in combination with automated insulin delivery. Pump therapy is more and more used in type 1 diabetes, especially in the younger ones. Patch pumps and micro pumps have potential advantages, also considering higher concentrated insulins maybe in the future. The accuracy and acceptable are critical, but first accuracy data are quite promising also for patch pumps. The Accu-Check Solo micro pump showed its accuracy in insulin delivery. It's also important to consider what materials are used for the adhesives. So if no IBOA is used, it decreases the risk of dermatitis. And I'm happy to share with you in the future the results from the ProSolo study later this month. Thank you very much for your attention.
So thank you, Dr. Julia, for that excellent deliberation. And let me just see, do we have any questions in the chat box? Maybe we can have all the panelists coming in. I request Dr. Ian as well as Dr. Cohen to join us. Yeah.
There are some questions, Shalini, in the chat box. You could start with those.
So we have this question from Dr. Thakur. How cost can be reduced of auto injections in India? Maybe by manufacturing in India itself. So that's a suggestion. And
I think the same suggestion has been there in the previous session as well. Why can't you manufacture glucometer strips, pump accessories from India, so the cost is going to come down?
I think cost is a major inhibition when it comes to taking up of all these new technologies in India. So
Correct.
I think this is something that should really be looked into to make them a little more acceptable, because of course we know the benefits of using all these technologies, but then because of the cost factor, I think they are still limited to a very few niche clientele.
Yeah, I would agree with that. It's because of course you can the new therapies that utilize auto injectors are typically higher cost types of therapy. But you would expect also, why shouldn't the GLP-1s be available in the auto injectors in India in the future? Because the cost of the auto injector or the cost of the disposable pen at the end of the day is not huge, but it is a proportion of the cost of goods of manufacture. The whole idea of manufacturing locally in India is talked about a lot. The problem is though is if it's going to be manufactured to the right level of quality and reliability, it has to be manufactured automatically. And so all of these devices, even Novo, Lilly, and Sanofi are manufacturing almost all of their disposable devices in Europe. Almost all of them are manufacturing in Europe and some in America. And so the lines that they are manufacturing these devices on are typically they are manufacturing 50 million per year for one line. And we have two lines. Our legacy with Sanofi is that we manufacture over 100 million disposable or ready-to-fill disposable pens for Sanofi here in Switzerland. But they are running on fully automated lines with very, very few people. So it's the cost of the investment that is high. They are not manufactured in countries like India and only just starting in China. China is still using reusable pens because of the cost of a disposable pen. Instead of using one reusable pen and 40 to 50 cartridges a year, in China, or any other country, you would need 40 to 50 disposable pens. And each of those disposable pens costs anywhere between $50 and $1 to manufacture. And if you add those costs together, they are almost, they become a significant part of the cost of insulin therapy in India. And it's a simple fact. As soon as the GDP per person goes above about $10,000 per person in a country, the affordability of disposable pen therapy, insulin therapy becomes affordable for that particular demographic, and that's why it's only available to a small proportion of people in India today. Just because the cost of 40 pens a year it's like anywhere between $40 and $50, and there is a cost associated with assembling the device with the cartridge, and then all of the labeling and the packaging and so on. So it's a fact, and you only see disposable pens in countries in large quantities where you have about GDP more than $10,000 per person. And you won't reduce those costs by manufacturing in India. It's a fact. Yeah. It will cost exactly the same.
There's a question, I think, Shalini, relating to availability of patch pumps in India. Well, the fact is, patch pumps are not available in India unless Jyoti is aware of some discrete way that one can get it. But frankly, I think the pumps, I think, we largely have had to contend with Medtronic being the only consistent player in the pumps market in India over the last decade and a half. And two, we've had Roche come in and then kind of go out of the market. Ypsomed, I believe, is available, beginning to get available now. So where, in terms of, if you have to ask the experts and the industry people, what do we do, or what is the vision for improving the insulin pump usage in India?
I think from Ypsomed's point of view, we are focusing on the pre-filled Novo pump cart and making it as simple as possible. So I think it's just the introduction of a very small discrete pump and reducing the overall cost of the therapy without necessarily it having to be associated with CGM. But of course, Flash GM is becoming very, very popular. I think maybe 70-80% of all pump patients are now using the Libre system. And I think this is key. Another aspect that people are talking about, of course, is how long can you wear the infusion set? And can it be longer than 3 days? So these are all aspects that can be looked at. But Ypsomed is just launching in India, and we will see. We are essentially helping at least a certain to provide some competition to Medtronic. I think you have around 7,000 to 10,000 patients in India, something like this, and whether Roche will re-enter the Indian market, of course, we don't know. Julia can answer that.
So I'm not the Roche person, but of course they do have interest, because otherwise I don't know if someone from Roche, I just quickly looked through but could not.
Varsha is there, Harde. Varsha, can you answer that?
Varsha, the question is on whether you are going to be active with the Roche pumps in India again.
No, I think they are active and they are looking for this solo pump, which will be available soon.
Yeah, they're looking for it. So I am always
sorry,
curious
Dr.
with
Jyotidev,
Medtronic.
Dr. Banshi, I was driving, so I could not really.
Okay.
Yeah,
Can you
please
repeat the question?
Julia is asking that somebody from India can answer when again the Roche solo pump will be available to India.
So I would rather say that Q2 of 2021 we are planning. If earlier all the regulatory and quality work is done on time, it will be maybe Q1 of 2021 is what our vision is.
So I think one message to every company which is trying to look at it, well, the rules in India are changing. If anybody wants to get all of these as devices not requiring special studies, is only till December 2020. Come January 2021, and I'm told that the regulations are going to change for all the new devices to be considered and given approvals only after local studies.
I agree with you, Dr. Manoj. The regulations for devices are changing. However, it is more getting regularized for blood glucose meters, because these were unregulated and they are coming into the drug regulations for now. Insulin devices, yes, it will fall under, but not a major impact for sure at this point of time.
Do you think the COVID scenario with the GDP is falling and economy really suffering globally, the device prices for all of you, actually this question is to all of you, right from Medtronic to Roche to Ypsomed, don't you think it's time that we actually think of economizing costs, especially in the post-COVID scenario when it comes to increasing the uptake of devices globally as well as in India per se, where most of our patients still have to pay out of their pockets?
Even Sunil is asking the same thing. Why not they should manufacture in India?
And that
Okay, so I'll pick up this
already been
question.
answered, but Thompson is saying that at present we have around 10,000 pump users, but we are looking for not new competition from Roche and Ypsomed, rather we are seeing the size should increase. We don't want only 10,000 person should continue the insulin pump. We want even 100,000 should use it.
I think price is a very important inhibiting factor why we do not have too many patients latching on to the pumps. At times we do have patients on the pumps, but they go back because of the cost of therapy. Because it's a recurring cost. It's not a one-time cost.
Dr. Cohen wanted to say something. He was.
So we need to give a serious answer, because whatever going to happen, the pumps, whoever going to manufacture and bring this to India, it's still going to be expensive. Okay, it's not going to be cheap. Let's start with this. So competition is good, but at Medtronic, we're trying to think also in a different way and saying, listen, until things change and the economy and the GDP goes up, we still have the patients who are not at goal. The speed need to be better controlled, and in order to have how we say it, to go to the patients where they are. We actually just now acquired a connected pin, the InPin, and we'll try to use all our knowledge that we learned from closed loop algorithms and bring this closer to the MDI users in order to bridge a bit the gap. So getting more patients to the maximum that they can get on MDI, that's how I discussed before. MDI has a ceiling, but not everybody reaches the ceiling. There's enough to do in India to get more patients to the ceiling of the MDI, and then some will be able to afford or not afford the more advanced automated insulin delivery. So I think at this pace, we can wait for, or we can wish for, or can we start working on how to get the patients where they are to better control. And this is one of the things you're going to see with Medtronic in the next couple of years, months, and so on.
Dr. Cohen, you were always world leaders in insulin pump therapy. So we are very curious on why you were not able to come out with a patch pump, because it is more user friendly. So do you have any serious concerns with the accuracy of delivery, or because it's very easy for Medtronic to come out with a patch pump? So why are you not for patch pump?
So is patch? I think Julia actually said that we have to go to where the patients want, because at the end of the day, if you give them something they don't want, they're not going to use it. So there is a lot of advantages in using tether pumps because of the insulin delivery, the way that insulin, we know much more about how the insulin goes out of the pump and into the skin and has to stay for a longer time. We're looking for sets that are going to survive 7 days. There's a lot of chemistry going on. It's not just that every patch can be for 7 days. You see that patch pumps needs to be changed every 3 days for so many reasons. So it's much more complex, and we all want to give everything to everybody. But a patch pump has a lot of issues for the level of Medtronic to make a pump that will be accurate enough, to be durable enough, and to be economically enough to be viable, especially when you talk about India. So you're asking to do things. You wanted to make it cheap, and you wanted to make it a patch pump. So at the end of the day, we have to be serious, and we all want everybody to be healthy, and we right now have to provide the best therapy with automated insulin delivery, but not forget those in the middle that needs now a solution to improve and get the best of what they have right now. And this is where we're heading. And I'm still a pump person. I still believe that automated insulin delivery is the best. And I bet for Julia, for your study, you did 3 arms, MDI and 2 pumps. And I think they're all on CGM. I want to bet. And
so they were not all on CGM. And
oh my God. So we missed the point to see whether if they're all on CGM and the MDI will still do the same as the pump. I'll bet the pump will do better, and in your study will to see the results. But still the pump has an advantage on MDI, and when you add pump and CGM, you get the additional bonus.
If I can,
I think it's very much about how the patient interacts with his devices. So what we see, we have people who are very, very good under control, and they remain very good under control for a year. So that's from our joint EU project that we are currently analyzing our data set. And then we have, on the other hand side, patients who reach not even 50% time in range, with a big part of the time above range, be it on pump or be it on pen. So we have more pen users in that cohort. But as you said, it's kind of the way how we treat those, how we can achieve the maximum for them before advancing them. So, and I think that's the big gap.
If I can ask a question to all the three speakers, and anybody can choose. We have a lot of doctors across India who now believe in technology and pumps, but have difficulties in converting patients to get onto the pump. What would be the best practices that you have seen in self-pay markets like India, and what would be your advice to Indian physicians? What can be done more, or what best practices to adopt to improve the convertibility to insulin pumps and improve the usage in India? Julia, if you want to have some thoughts going to, yeah, sorry.
Julia, I will tell you in short that actually the COVID-19 gave a push to a lot of new innovations in helping people onboard new technologies. Actually now Medtronic has a program that you can actually onboard your patient without even having him come to the office. So everything virtual. So right now, there are programs in order to support physicians who are working and do not even have a lot of experience to onboard even sophisticated, because we made a sophisticated device does not have to be difficult to be put on a patient. So it's a sophisticated device, but we want to simplify the whole process of onboarding, and this is now the way in the COVID and post-COVID era. I don't know if I answered your question, but this is one of the programs we can provide.
Yes, that's on the training part. I was looking at best practices to improve the usage in terms of convincing and any other best practices in self-pay markets across the country. If Ian Thompson has anything to add before we end the session.
Just going back to one or 2 points. Yeah, I mean, patch pumps are expensive because that's why Roche has gone towards a semi-disposable concept. We know the Omnipod and the Insulet product has a very high cost of goods, and that's one of the reasons why it hasn't really been, when the company is only just becoming profitable after many, many years. In terms of, and that is part of the reason why you will see mainly reusable pumps probably for in the foreseeable future in India, and maybe the Solo product from Roche. And we are working on something called Ipsapod. But our focus with the Ipsa pump is really on having as simple as a pump as possible with not too many features, but bringing in the closed loop with the CGM or the flash GM, so that the patients can get on their smartphone an automatic recommendation. And that's the focus that Ipsamed India has for the rollout of the product at the moment.
Yes, Mithun, you want to ask something?
Yeah, I wanted to ask to all the three speakers whether we could, the companies could consider working with private medical insurance companies in India and try to find a way, because even though we know technology is superb, we know cost is an issue, try to find a middle pathway, because we know that it will reduce complications in the future for diabetic patients. So something in that way, a middle point that a person pays an insurance and we know the rate of complications is going to be high, things are going to be under control. Has the company tried that in any other countries? When I was in UK, we had a very robust system because the NHS was doing all the way. I was in UK for a long time, and the services were excellent because it was not out of the patient pocket. Here, it is going to be out of the patient pocket. So maybe a private medical insurance we could find a third party in it to try to move away from the catch-22 situation.
Unfortunately, you're talking to the clinical person in Medtronic, and you're asking for reimbursement issues. I think that you should be in contact. I know they are doing in Medtronic India. They're doing everything they can to find these agreements with the insurance. But you will not. I cannot help you more because I come from the clinical part and not from the reimbursement part. But it's an important question.
Maybe to add just something from the clinician's view, And that's an interesting question that you posed, because in Austria, it's more difficult to get approved on CGM or flash glucose monitoring than on a pump. So it's kind of the free choice to get a pump, but you have to fulfill certain criteria to be eligible for flash glucose monitoring. There it's easy, it's just basal bolus therapy. But for a CGM with alarms, you have to have severe hypo and other reasons why you need such a system. And on a pump, it's just like patient preference, even if it's a quite expensive choice. And even if we are here, one of the largest technology centers in Austria, so like small population, we only have 8 million, but still, it's here that not all the adults want a pump, even if they can have it. So they do not have to pay for it. It's kind of the same cost for them as for a pen, like nothing, but they don't want to go for it. But the pump uptake, especially in children, is quite high. Then we have a drop in the adolescents who do not want to show that they have diabetes. Then there is again an on-take, especially in women who want to become pregnant. And the ones who stick to a pump through their kind of diabetes life, they stay with it. But it's not that we can convince so many of the adults to switch to a pump if they are under good control, because they say, okay, that's what I can achieve. I do not want to have anything on my body that reminds me all the time. And I'm happy with my sensor. And it's about, like, at the moment, I would guess in our outpatient clinic that we have 30% on pump of the type 1s. But in pediatrics, it's like 70 or 80%. But it could be as high, but it's not that patients want to take it up. I think in Vienna at Ingrid Schützfuhrmann's department, it's a bit higher potentially. But even if it's free, it's not just that easy to convince patients that they want to go on a pump.
Brilliant. I think we'd had some brilliant discussion. Over to you, Shalini. Sorry,
Yeah.
Banshi?
Most of the questions that come in the chat box are related to the cost.
Yeah,
I
most
agree
of them
the
are
cost
related to the cost.
Yes, but the cost, we agree that pump cost in India is high, and there are ways by which, but still I believe there are 10% of the patients or even 5% of the patients which are affording. So the idea of this technology meeting is that to improve the care for those 5% of the patients. At least if you put all those 5 or 10% of the patients who can afford, still the numbers can be increased like anything. At present in India, we have 120,000 children who are below the age of 15. As per IDF data, they are type 1. And if you just think of 5% of them, it will be almost, big number will be there, another 6,000, 10,000 patients. All those 10,000 patients which are in India who are on pump therapy, 60% of them are in type 2 diabetic patients, and less than 10% of them are in children. So below the age of 15, we have only less than 1,000 patients who are on pump therapy. We agree that the cost is a major issue, but still I think there are many more patients which can be helped out by the...
Banshi, if you remember the presentation that we did at ATTD on the insulin pump symposium and the Indian insulin pump symposium at ATTD, we did start the presentation showing the amount of Mercedes and BMW sales in India, clearly reflecting that when we say it's
I mean, every time we can't
it's a
just
diverse
cry
country.
on that, the cost. We agree that the cost is a major issue.
I think we have back to Shalini.
I think another issue why probably that niche segment is also not getting the advantage of the pumps is because the doctors themselves need to have that confidence in this technology. So I think besides the cost factor, one more thing that everybody needs to look into is educating the doctors on the technology first, because till the doctors gain confidence in the technology and how to handle it, because many a times I've had referrals where the pump has been initiated by a doctor who himself is not aware of the technology. So he's just not able to, guide the patient on how to adjust the basals and bolus, and ultimately it's the Medtronic people who are doing it for them, and the patient falls off and comes back to somebody else. So I think you need to train a lot of
the idea of these
on the technology as well.
Yeah.
And on our website also, we are planning to come out with a modules for pump therapy, so which will have the education material and everything. And we will again take the support from the Roche and Medtronic.
There are a very few doctors who actually adjust the rates for the patient.
Yes, yes, Khan.
It's just the company who's doing it.
I just encourage you. I encourage you to go to the industry to assist you in this. You go to Ypsomed and Roche and Medtronic. I think there's a lot of education from the industry that is fair and it's a high quality that I'm sure that can enrich your site, and I
That's the
think
idea.
it's a good call. Yeah.
Yeah.
Okay.
Thank you.
So I
Shall
think,
you can close the session.
yeah, so I think we've just had an excellent discussion on the insulin pumps, insulin delivery devices, and the future for everyone. I would like to thank our speakers, Dr. Julia, Dr. Ohad, and Dr. Thompson, for all their insights. And we hope that the insulin pump and the technology uptake improves for all our patients. With that, I hand over the proceedings to Dr. Chawla, and thank you very much, Dr. Saboo, for having everybody here together discussing this very important segment of technology.
Thank you, everybody. Bye-bye.
Thanks, Thompson. Thanks, Cohen. Julia.
Thank you, everyone.
Thank
Bye.
So, before the next session starts, we have a technology video. I welcome Viral. Viral has joined already. Leonie has joined. So let's have the next technology video. Thank you. Once again, thanks to all who logged in. And now I introduce Dr. Manoj Chawla and Dr. Mithun Bhartiya for chairing the next important session. Dr. Manoj and Dr. Mithun both are RSSDI Diabetes Technology Task Force member. Dr. Manoj is a fellow of RSSDI. He is also a fellow of Royal College of Physicians, Edinburgh. His diploma diabetology after doing his MBBS. He's a director and consultant diabetologist at Lina Diabetes Care and Mumbai Diabetes Research Center. He is consultant diabetologist at Asian Heart Institute and Research Center and SL Raisa Fortis. He's the founder president of United Diabetes Forum. He's an honorary visiting faculty at DY Patil Medical Science, Navi Mumbai. He's awarded RSSDI Fellowship for the year 2017, Fellowship of Royal College of Physicians of Edinburgh for year 2019. He's a principal investigator in various global multinational clinical trials and some new compound and devices. Dr. Mithun had done his MBBS, MRCGP, MRCP Diabetes Endocrinology from UK. He is also trained further in Amsterdam as in sexual medicine. He is also a RSSDI DTN task force member. He's a young sexologist from Guwahati, has been awarded a rising star at the International Symposium on Diabetes held in Mumbai in January 2016. He has also previously been the recipient of Edswiller Scholar Award in 2013-14 and prestigious Mayo Clinic USA, Rising Star Diabetes 2013 in United Kingdom. He's been awarded multiple awards in Chicago and then again by the International Society of Sexual Medicine. He represents India at worldwide at AZP Clinical Academy. Over to Dr. Manoj and Mithun Bhartiya for a very important session on continuous glucose monitoring.
Thank you, Dr. Saboo. I welcome everybody in this session. My co-chair, Dr. Manoj Chawla, very good friend of mine. We are going to now discuss on continuous glucose monitoring. Now, from the pump, continuous glucose monitoring, and in fact, continuous glucose monitoring, we might be able to reduce the insulin doses and give a patient a better glycemic variability. We're going to have 5 speakers in this session. It gives me great pride to introduce the first speaker, Dr. Anna Sau. Dr. Anna Sau is an Associate Director with the Abbott's Master's degree in the University of Singapore. She's going to talk today about revolutionizing diabetes time in range, which is the latest concept that we talk about all the time, which is the new fashion in terms of talking about continuous glucose monitoring system. So over to you, Anna. Manoj, you want to add something?
No, just welcoming everyone and thanking Bansi for the introduction. So over to Dr. Sau.
Hello, everyone. Can everybody hear me well?
Yeah.
Oh, great. Thank you, my moderators, and thank RSSDI for organizing this symposium. And thank you all for the ones who's calling in on the line. So for the next 20 minutes of our today's session, we'll be discussing revolutionized diabetes management with time in range. My name is Anna, as introduced by my moderators. I'm the Associate Director of Scientific Affairs, covering Asia Pacific in Abbott Diabetes Care. So in the next 20 minutes, I'll be talking about international consensus of time in range, which is a new concept in the management of diabetes, and followed by the new AGP report. So of course, we'll start with international consensus in time in range. So, yes?
You put your presentation in presentation mode. The slides.
Okay, hold on. Is it in presentation mode now?
I think all the slides are also coming at the one side.
Oh, okay, hold on.
Slideshow.
Slideshow.
Yeah, I'm using 2 screens, so it's in slide mode in the other screen. I just shut it down now, so let me fix it.
Yes.
Can you see now?
Not yet, but I think you were at the right
but not in slide.
symbol at the bottom that you had to click on the right.
I did try, but it didn't work. Hold on. Okay, it's working now.
Yes.
Okay, great. So we are here at this slide. So for the last few decades, we've been highly depending on one endpoint, which is HbA1c. And we've been talking about HbA1c for at least the last few decades, and it's been regarded as a gold standard to evaluate patients' glucose control. And is A1C really that perfect? The answer is no. So A1C, of course, all of you already know that A1C is representing the average glucose of the previous 2 to 3 months. Since it's the average, it doesn't give you whether the patient is suffering from hypoglycemia, whether the patient is suffering from hyperglycemia, and of course, it doesn't really give you information on glucose variability. You don't know that how glucose will fluctuate throughout the day in patient's life. And A1C can be inaccurate as well for the patient who is suffering from anemia or patients with pregnancy situation. So A1C is really not that gold standard as we thought. So let's take a look at these 2 AGP graphs. So these 2 patients on your left-hand side and on your right-hand side, we can see that both of their A1Cs is at 7.7%. However, their glucose fluctuation, their glucose profile is completely different. On your left-hand side, you can see that the stability as well as the variance is way much better compared to the patient on your right-hand side. However, we can see here their A1Cs are exactly the same. So a group of experts gathered around doing ATT this time in 2019, and they're discussing other metrics that could be useful in clinical practice. And the results of this discussion was published as an international time range consensus during ADA's time in June 2019. And this international consensus in time and range is not only endorsed by ADA itself, it's endorsed by multiple international associations, including the European one, EASD. So this time in range consensus is fully backed up by the Diabetes Association around the globe. So what does this time in range consensus tell us? So the expert has included 10 metrics in this time in range consensus, and these 10 metrics can be useful in our clinical practice. So we can see here are the 10 metrics. Number 1 and number 2, the consensus is recommended for the patient to wear the sensors for at least 14 days of time. And then it's also recommended to have at least 70% of data being captured during the wear time. The metric 6 to metric 10 are all about the targets for different timing range. So we could see the timing range with its targets actually counted for a very important part in the control and the management of the glucose for the patients. So what exactly is timing range? So when we look at this AGP here on your left-hand side, you can see the target range. Target range consists of a lower limit and also an upper limit. When the time is spent within this range, it's called time in range. When the time is spent above this range, it's called time above range. When the time is spent below that bottom range, then it will be called as time below range. And in this timing range, the key goal would be decreasing time below range while increasing time in range. So it's more like a traffic light system. So we all want green, we do not want red, and certainly we do not wish to have more yellow too. So time in range is oftentimes represented by green, and time below range is oftentimes represented in red, and time above range usually represented in yellow. So we want more green, less red, and of course less yellow as well. So what exactly is more and what exactly is less for the majority of type 1 and type 2 population who are not having high risk or who are not having pregnancy situation? The target range is recommended by the timing range consensus to be at 70 to 180 milligram per deciliter, which is also a 3.9 to 10 millimole per liter. It's recommended for the patient to spend more than 70% of time in this range. For time above range, it's recommended to spend less than 4% of time below range, or for time above range, it's recommended to spend less than 25% of time above range. So let me give you a different visualization of how time should be spent in different ranges. So here is the stack bar of different timing ranges. So like I said, time in range is oftentimes represented in green. So time in range is recommended to spend more than 70% of time. And for time below range, which is in red, is recommended to spend less than 4% of time below range. For very, very low glucose, when the glucose is lower than 44 milligram per deciliter, which is also 3.0 millimole per liter, it's recommended to spend less than 1% of time below that level. For time above range, it's recommended to spend less than 25% of time. But when the glucose is very, very high, when the glucose is more than 250 milligram per deciliter or more than 13.9 millimole per liter, it's recommended to spend less than 5% of time above that range. So some of you might be already wondering, like since you're all very good at math, some of you might be already adding all the percentages up in here. And if you add it up, you'll find out it's not 100%. Why is that? So like I said, the goal is to expand this green and to push this red and also to decrease this yellow. So this 1% is actually included in this 4%. And this 5% is also included in here. So for timing range, should be more than 70%. And for all this red, it should be less than 4%. For all this yellow, it should be less than 25% in total. Okay, so why are we setting that the bar at the threshold at 70%? Why is that? From these two studies by Dr. Bag and Dr. Vergersky, so we found out that when the time is spent roughly around 70%, the A1C is maintained at 7%. That's why the threshold of time range is set at 70%. From these studies for type 1 and type 2 diabetes, we also find that when the time in range is increased by 10%, there will be a reduction in A1C around 0.5 to 0.8%. So it's important to keep increasing that time spent in range. So here's give you the target range as well as the target for different types of diabetes. So for type 1 and type 2 who are not having high risk or who are not having pregnancy. I already introduced the target range as well as the targets for different time ranges. So how about the elderly, and how about the pregnancy type 1 or gestational or type 2 diabetes? For the elderly or the ones are having high risk, the target range is recommended around the same. However, we're having a little bit buffer for time in range, but for time below range, we do not wish them to spend more than 1% of time below range. But for pregnancy and type 1, if you look at the targets, you'll find out, the targets look exactly the same as the majority of the type 1, type 2 population. But if you look closely as the target range, you'll find that this allowable target range is actually more stricter compared to the majority of type 1 and type 2 diabetes. So actually for type 1 diabetes who's having pregnancy situation, we want them to spend actually even more time in range and less time below and also less time above range. And for gestational and type 2 diabetes, and actually there's no data to have the experts to really list out all the targets, but of course we want them to spend more time in range, less time in below range, also less time above range. Okay, so why is time in range so important? So actually time in range, the concept is a little bit like the A1C. So from a very valuable data set called DCC data here, as we can see in the bar graph A and bar graph B, we can see the frequency of retinopathy and also the frequency of microalbuminuria. In here, we can see that when the time is spent more than 70%, the frequency of retinopathy is relatively way lower compared to the one who was spending less time in range. And it's the same for the microalbuminuria. So to be exact, when there's 10% reduction in time in range, there will be an increase of retinopathy by 64%. And there will be also an increase in microalbuminuria by 40%. So it's a little bit like A1C. Time in range is also a good indicator of the future complication risk. Okay, that's all for the time in range as well as its target. I would like to briefly introduce the AGP report. So in the international consensus of time in range, the expert also introduced a standardized AGP report. This report will allow and ensure consistency of the interpretation of the CGM data from visit to visit for multidisciplinary team. So usually in clinical practice, to help the patient to achieve better goals, not only endocrinologists, diabetologists, there's other healthcare professionals involved, and that have this standardized report will allow all the healthcare professionals to really work with each other to help the patient to improve the glucose control. So in this new report, there's 3 or you can say 4 different panels. As you can see here on the top panel, you'll be able to find the glucose statistics and targets on your left-hand side. On your right-hand side, you'll be able to see a stack bar and also the percentage and also the exact time of the time that's spent in different ranges. And in the middle panel, you'll be able to see the AGP profile, which is in diagram. And in the bottom panel, you'll be able to see the daily glucose profile. So let me briefly introduce different panels. On the top panel on your left-hand side, you'll be able to see here how long the patient's been wearing the CGM device and how much data is being captured. And here it gives you the recommendation of the target for different time and range. And in here it gives you the average glucose, the GMI, which is also called the estimated A1C. And also it gives you the CV, which is called the glucose variability in here. On the top panel on your right-hand side, you'll be able to see the stack bar, the percentage of different timing ranges, as well as the exact time. And in the middle panel, you'll be able to see a big AGP diagram, and you'll also be able to find the target range. And in the bottom panel, you'll be able to see the daily graphs. If the patient's been wearing the CGM device for 14 days, you'll be able to see the 14 days of glucose profile. So that's that AGP report, that CGM, the new AGP report is available in our newest CGM devices. And what about the current timing range in our current Freestyle Libre Pro system, which is available in India? Do we have timing range in our current system? The answer is yes. So in the HCP report, you'll be able to see the time in different ranges. And when you take a look at the daily glucose summary, you'll be able to see the time in range for throughout different days when the patient's been wearing the CGM devices. So time in range and as well as the percentage, you'll be able to find it in your current Libre Pro system. Okay, that's all I have for today. So let's work together to help the patient spend more time in range. Of course, the more, the better. Over to you, my moderators.
Thank you so much for the wonderful presentation. What we'll do is that we'll take all the questions at the end. And now request Manoj to introduce the second speaker.
Right. Yeah, we request all the speakers to stay back for the panel discussion. I'm sure that's going to be interesting. And I can stop sharing, right? So we move on to the next session, and it gives me great pleasure to welcome and introduce an old acquaintance and friend, if I may say, Mr. Paul Amritraj, who's the business director, Southeast Asia. He's had 25 years of experience for global pharma and medical device business. From 1989 to 2007, he was his Novo Nordisk, was a country head for Sri Lanka and Bangladesh. From 2007 to 2010, he was head Southeast Asia business for Medtronic. In fact, I think that's when I met Paul for the first time at a Medtronic pump meeting, I think in Tilochenaz, Switzerland. Paul probably will remember that. And 2011, he's been a business consultant for medical devices. Paul, today, Paul, you there? Yes, of course. Yes. Yeah. So Paul is speaking. In fact, Paul's another colleague, Jason, was going to be with us. Had some family emergency, and Jason couldn't be there. Paul is here with us, and Paul is going to be speaking about the new real-time CGM that we're going to be seeing soon in India, and real soon. Over to you, Paul Amritraj.
Thank you very much, Dr. Manoj Chawla, and greetings to all of you who are there listening online. And it's a great privilege for me to present this product today for all of you. I'll just do a little bit of things which I need to do on the sharing.
Yeah, Paul, now it is visible. You need to just make it full screen.
Yeah.
Paul is sharing the slides. Let me also mention that the product that Paul is speaking for, Infinovo, Glunovo CGM systems, the company has a tie-up with Eris Life Sciences India, and very soon Eris will be getting this product for all of us to use it in India. Over to you, Paul.
Thank you very much. I think you are able to see the slide. Now, the whole topic is titled as Real-Time, Real Care, the first real-time CGM to be launched in India. Unfortunately, it was supposed to be done by Jason Wang, who was the vice president, but his father met with an accident, and then I am chipping in for him. Before we proceed into the topic, I would like to show you a very small video of the product. Okay, being in the market of diabetes for pretty long time, as CGM has been a revolutionary monitoring solution versus the SMBG. As all of you, the clinicians who are present here, know that more and more CGM systems are going to be used in India. And you can see that as on date, there are a few companies who are operating on the CGM side, but in the days to come, there will be more and more companies, and there will be more and more voice on the CGM. If you look at this particular slide, that we have been using the SMBG for a pretty long time. Even today, because of the cost factor, we talked about a lot of cost factor during the pump. But again, when we look into the CGM as well, there has been a lot of talks about the cost factor. But then look at what are the advantages. The finger sticks for a year, 2,190 times versus just 24 times. You have to change the sensors. And then, but the whole beautiful thing about a CGM, as was just given by the previous speaker, is it provides the full glycemic picture for better diabetes management. So that's the beauty of it. You can see it very well here that there is a red mark there where it is dangerously low, where it gives you an alert. The beauty of the real time is that it gives you an alert. And even when it is on the high, it gives you an alert. So this is the real-time glucose monitoring. Now, we have all been seeing the dashboard of diabetes management. We have seen the drug delivery of pens, the disposable pumps, which probably can come, the patch pumps can come into India. The durable pumps and the supplies are already there. We have talked about the costs about it in the last session. We have the drugs, the insulins, the compounds, the other medication, but then it also requires for a clinician the services. The hospitals needs more information. Education. We all talked about education for doctors as well. If you need to use technology, that has to be given by the company side, definitely, because they are the people who have invented that. They have to part with the education to all the clinicians for better management of diabetes for the patients. But even more than that, we are moving into the artificial intelligence. Those are the things which is going to come. So analytics are going to play an important role in the days to come. Algorithms, all the treatment are going to be outcome measurement has to be there. Tomorrow, the patients are going to ask, what is the outcome of the management of diabetes? So for that, there has to be a decision support and there has to be a coach. If a CGM can be a coach, will it not be good? And that is what we are looking at. So what is an ideal CGM? We look at patient side. Patients want comfort. The moment they wear it, it has to be comfortable. It has to be simple to use, but at the same time, very discreet. It should not be shown outside at all. And in India, we talk about the most important factor, affordability. These are the things which the patients look into. But at the same time, what are the things which the healthcare professionals look into? They are very much more important aspect is the accurate data to support therapeutic decisions. Dr. Anna was talking about the TIR, the time and range, which is an important one. If time and range is an important one, then accurate data to support the therapeutic decision is an important factor. Safety for the patients. A CGM cannot give any false, whether in the hypo or in the hyper, it cannot give you a false. Easy to follow up and data approach, how effective the analytical tools are there available for the doctors. GluNova, the third generation CGM, will be our best choice because of its accuracy, the only real time, affordable, and very, very, very simple to use. You saw the video, how simple it is. Accurate. How accurate it is. The clinical trials which has been done in China, if you look at it, the entire thing on the graph, you can see that between A and B, the whole of the accuracy is 99.81%. The EKF testing value took place during the period of 7 hours in all the 3 days. They had a very clear day 1, day 2, day 6, 7, 8, and 14. And you can see that the MARD is around 10%. And you can see the MARD is less than 10% in certain days. So the accuracy part of this GluNova i3 systems, the MARD is less than 10%, is equivalent to 10 or less than 10. So accuracy is very high for this product. Oh, the most important factor, the most important questions. I know that everybody will put it in the chat. What is the cost? So the technique innovation, GluNova helps patients and it's paid to save their healthcare cost. Now, this is how the entire sensor looks like. you have a transmitter where the transmitter can be used for 3 years. Sensor life is for 14 days. Sensor adhesive lasts for 14 days. And compared to many other CGM systems, cost will be lower. It's very simple to use. One-click applicator, you can see the applicator on the left-hand side, the big one. It's a one-click applicator, intuitive app for the patient. It is going to be mobile-based. In your mobile phones, intuitive app for the patient, self-learning. It's going to be cloud-based portal to follow up patients. So all the clinicians can follow up the patients on the cloud-based portal. The cloud-based portal will have all the various analytical tools. And above all these things, it is discrete, comfortable sensors. No pain on applications. And it will work on multi-platform data collection is available for this. The other important thing is the real time. CGM readings are transferred to the app every 3 minutes automatically. It displays the trends in various charts. It provides real-time alarms and alerts for the patients to take action in advance. More algorithm to help patients based on real-time features. Unlike any other CGM systems, whether it is the ambulatory glucose systems or the flash glucose monitoring, any of the things, this is real-time. But then, even if it is real-time, what is the advantages? If my CGM turns out to be a coach for me, for the patient, for the doctors, if it turns out to be a coach, will it not provide more benefits? Will it not be benefiting the patients? You can see on the slide that there is the red one where there is a warning of severe hypo. Your mobile phone will beep when it is going down to the hypo. And then it gives you various other graphs on that. But if you can see during the lunge, you will see that there is a slight rise in the glucose. But then it also coaches the patient that if you do a small walk after the meal, then your sugars can be controlled. So there is a skill unlocked, post-meal walking skill unlocked. Similarly, even in the night, if you see between the night about 8 o'clock to 12 or morning 2 a.m., you can see that the glucose has risen. It's not in time and range of your glucose. It's over 80%. You can analyze that, the patient can see it. But then this is a skill unlocked for the clinicians. Medication is best taken before bedtime. So for the clinicians, it is a skill unlocked. So you can see the benefits of this beautiful CGM, that it is also acting as a coach. So Blue Nova i3 systems provides a complete glycemic pictures with 14 days life. MARD is less than 10% to 10. It's 10% and less than 10%. Very comfortable, real time. Algorithms are there. It is a cloud portal. And what are we have in pipelines? 2020 now, we have the i3 systems. It is calibration free. 2021, we have the data portal and modularized algorithms, which will be coming in. 2022, we have the pediatric label for the sensors will be approved. And then 2023, we are looking at an artificial pancreas along with a pump. And then 2024, we have the Blue Nova, the 5th generation at very low cost with more accuracy, which means that we are still working on the research to reduce the MARD less than 10%, less than 6%, like that. So the research is still going on. Now, the initial clinical trials have been already done, and it has been presented as at the Chinese Diabetes Society. Now, this is a picture of the Chinese Diabetes Society, where the president of the Chinese Diabetes Society is presenting the clinical facts, the clinical trial reports. And he has already put it on during the conference that the best CGMS brand recommended by the Chinese Diabetes Society is Blue Nova i3 CGM systems. Thank you very much for your patient hearing, and we will take up any questions which is coming up at the end.
Yeah, Paul, we will do that. but you've got everybody excited. So one question that you need to answer is, you said this is going to be cheaper, and the entire discussion has been. So you need to tell us the cost that you or Eris are looking at in India before we get on to the other discussions at the end.
Doctor, at present we are just working out, because we know what are the prices which is there in the market. We really want it to be more affordable to the patients. That's one of the criteria in which we are working at it. Because unless the technology reaches the public, the technology can be outside the reach of everyone. So we don't want to have that type of a situation. It has to be beneficial for the clinician. It has to be beneficial for the patient as well. But we are still working on the costings. It also depends upon the scaling of how much India can take it up. All those research are still, the market research is still going on. Probably very shortly, in a few months from now, we will be able to look at some pricing, which will really be nice, a sweet for the patients as well as for the clinicians.
I never knew when you turned a politician. So we will leave it at that, because you're not giving us the answer. And
yeah, Manoj, he has
sure.
said, Manoj, Paul has already said that this is going to be approximately 30% lower. So I feel we should now be able to calculate it, because we have only one.
More question, Paul. After this COVID situation, I don't know how Chinese products will be available in India. We don't know this.
No, we'll see how to work it out there, because our entire thing is based in Amsterdam. The whole thing is based. It's only the manufacturing side is here, but all the other things are from Europe.
Okay, that's good.
Mansi, they're going to market it. Use the CGM, and it comes with a free vaccine. So. Okay. I hand it over to Mithun to introduce the next speaker.
Please. Mithun, you have to unmute.
Paul will keep the price of the 30% cheaper that you have kept for future recommendation whenever you launch the product. So it's pleasure now to invite our third speaker, Dr. Robert Wigelski, who's the Director of Clinical and Medical Affairs, Medtronic Diabetes, former President of the Endocrine Society, and Director of the Diabetes Institute at the Walter Reed National Military Medical Center. Dr. Wigelski is going to talk about the benefits of continuous and ICGM in improving glycemic control. Over to you, Dr. Wigelski.
Thank you very much. Can you see my screen?
Yes.
Okay. You see my...
Yes. Yeah.
Okay, good. Well, first of all, I want to greet everyone and say to the organizers and Dr. Saboo, very hearty thanks for inviting me to speak. I'm located at the moment in New York City, but as many of you know, I live in DC, and I'm just visiting some family here. So very much want to go ahead and tell you about smart CGM and how the smart CGMs actually improve glycemic control through predicting and mitigating glycemic excursions. And I'm going to be talking about Guardian Connect CGM, which is Medtronic's standalone CGM product. So the organization for my talk is to talk about a little bit about the need for real-time CGM, talk about Guardian Connect system and why this is a smart system, and then finally a little bit of a teaser about even smarter CGM. So what's the need for real-time CGM? I think we all know that everybody has a different pattern on a day-to-day basis, and there's really no way, if you're doing finger sticks, to capture this. And so real-time CGM is quite important in understanding patterns for the patient and for the healthcare provider. In fact, in a paper a couple of years ago by Steve Edelman and a number of other luminaries in our field, they said, based on the growing body of supporting evidence, the use of CGM is recognized as the standard of care for the patients with type 1 diabetes and a subset of those who are insulin requiring type 2. And there have been a number of studies that have demonstrated the benefit of CGM compared to SMBG. I've put 5 of the more prominent studies, which many of you may know. On the left is the end of study A1C, and on the right, the end of study time and range. And you'll notice that the time and range, the end of these studies goes from 55 to 62%. They don't quite reach the target that you heard Dr. So mention, about 70%. But also remember that most people with MDI and SMBG are getting time in range of about 50% or less. Now, this is continuous glucose monitoring, meaning 24/7, 365 days a year. And I just want to point out an alternate way to do this. And this is a study that I did and published when I was full-time at Walter Reed about 8 years ago, a randomized controlled trial that looked at what if you gave CGM to people for 2 weeks, real time, and this is in type 2 diabetes, not on prandial insulin, and you gave them a week off and did that 2 weeks on, 1 week off in sequence over 12 weeks. And what you see on the right is that compared to the control group, at 12 weeks, there was a significant improvement in A1C, over 1%. But what was interesting is for the rest of the year, we followed these patients and they did not have CGM. They were followed by their primary care doctors, but the difference between the control group and the intervention group is maintained, about 0.6% difference, despite not having CGM for 9 months. And what this tells us is that, and our interpretation was that the behavioral changes that were affected in the first 3 months were carried over for another 9 months. So I think while this is not a common way to use CGM in the cost containment world that we live in, it may be a way to use CGM more cost effectively. That is, use it for a short period of time, give the patients several weeks or months off, use it again for a few weeks, on and off. And this study points to that. Now, what about the Guardian Connect system that Medtronic has? Here's a look at it. It uses the Guardian Sensor 3 with 7 days of wear time, and the MARD is 9.1%. There's a transmitter that is Bluetooth that sends the data to the phone. And one of the very important features of this system is the CareLink report, which I'll go through in a second, but is a very comprehensive report that helps you manage the patients from visit to visit and, importantly, between visits. And how does this work? Well, the CareLink system automatically uploads the data and can send text alerts to the care partner. And then in this COVID world, where we're doing a lot of virtual appointments, you can see that the upload to the CareLink, as long as it's paired with the physician's practice, can be used to have a virtual visit, and a meaningful virtual visit, because the healthcare provider and the patient can both view the data and make the appropriate changes. Now, the important CareLink reports, and this is the main assessment and progress report, is shown here. I'm going to go into some of this in a little bit more detail, but on top, you see that there's the AGP report, which shows the mean and the interquartile ranges. And then below that, there are actually the intelligence, the pattern recognition software picks out patterns and tells you the number of episodes per day. So the patterns are listed up here, and then there are 4 hypoglycemic patterns, a number of them per day, and hyperglycemic patterns, and so forth. And with these patterns comes some actually suggestions about what may be causing the patterns, and that allows you to make the appropriate changes in the patient's regimen. Now, on the left are the stacked bars, and there's a and B. In this case, there's no data available for the previous period of time, but that will be available if the patient uses this for more than a few weeks. and then you can compare time A to time B. And in this case, on the right, you see this stacked bar showing this patient had 58% time in range, which obviously is not anywhere near target and certainly could be improved upon. But at least you have the data for the moment, and then you can make the changes that you see fit in their regimen. The center section are the statistics, and this gives you the key statistics such as the amount of sensor wear per week, in this case 96%, the average sensor glucose, the GMI, or glucose management indicator, the variability in terms of coefficient of variation, and the number of high and low alarms or alerts per day. And then finally on the right, it gives you a snapshot of the settings. And the settings, which I'll show you a little bit more detail, can be shown as alerts on or before high, and how long before the alerts do you want to be notified, and how long before the events do you want to be notified? In this case, 45 minutes. And then the same thing for alerts on and before low. Now, how about the performance of the Guardian Connect data system? Here's data from that's been pulled from our CareLink reports. This is real-world data in 1,765 patients, and what's highlighted in green is the time in range, almost 65%, between 70 and 180, so 3.9 to 10 millimoles, and less than 1% below 54 or 3 millimoles, and 10% above 250. So in the real world, this, in a very large patient population, this Guardian Connect system is working quite well. But one of the criticisms of CGM has been that people use it but then stop using it for a variety of reasons, one of which may be cost. But we do have data on persistence and outcomes in persistent use of this. And if a patient is using it, and this is in 258 patients who have been using this at least for 9 months, you can see that the time in range, the time above and time below range is quite consistent over time. So the effect of CGM is lasts for time according to these data. Now, what about smart CGM and how about predicting hypoglycemia? I think we all know that hypoglycemia unawareness is a problem. And in this slide, you see on the left the data in type 1 diabetes, in which 40% of people with type 1 diabetes have hypoglycemia awareness. And if you do CGM, blinded CGM on them, you find actually that 14.1% have spent below the range of less than 70 in those who were considered well controlled. So these are patients whose A1Cs are less than 7.5%. The same can be said for patients with type 2. So if you just give a survey and ask patients with type 2, do they experience hypoglycemia and are they aware of it? Just about 10% say yes. But in reality, when you do blinded CGM and look at the incidence of hypoglycemia that's unrecognized, it's nearing 50%. So just asking patients, as I do in every visit, have they had an episode and can they sense it, is really insufficient, and having the data is really quite important. Now, in terms of settings, in the Guardian Connect system, you have your choice of setting or not setting 3 different types of alerts. So a rise alert, so this is the rate of change, a predictive high alert, or a threshold high alert, and then a fall alert, a predictive alert, and then a threshold alert. So there are 6 different potential settings. To start out, we don't recommend the patients set all of them, but the most important ones are the predictive alert, particularly the predictive alert before low. So here's an estimate of how accurate these predictive alerts are. Now, if you don't have the predictive alert, but you just have the threshold alert set at 70, it's 90.5% likely to prevent hypo. But if you have a predictive alert, and it's set, in this case, 30 minutes before reaching 70, there's a 98.5% chance of predicting or preventing a low. So this is a study that was done in 89 subjects, 14 to 75, and I think shows you not only the value of alerts, but how important it is to have accurate prediction. In fact, in the Guardian Connect system, you can set the alerts for prediction anywhere from 10 to 60 minutes before the high or before the low. So this may be changed depending on the time of day. Patients may want to have more time to respond, for instance, during the day, but less time during the night. And this is customizable. And in fact, how accurate and how effective is this is shown in this study. So first of all, on the left, you see that the screen on the smartphone turns red and gives you the information about when the alert is predicted to, when the low is predicted to happen. You can snooze it, and it asks you to confirm this with a blood glucose test. But in terms of actually reduction, what we've done here is shown how likely it is to prevent hypoglycemia with the alerts, predictive alerts turned on compared to when they're not turned on, and just having threshold alerts. And you can see that you can prevent it, these lows, in 65% of the time if the alerts are predictive compared to 36%. And the same difference, even maybe a greater difference in preventing highs. So again, this is a smart CGM. This gives immediate real-time feedback to the patient and to the caregiver, if so chosen, to get these alerts and prevent these episodes from happening. Now, this is some data from Europe, where this system was initially launched in 2017. And what you see in the green dots compared to the orange dots are the alerts that have been prevented. I'm sorry, the hypos that have been prevented due to these predictive alerts. And you can see that the green dots greatly overwhelm the orange dots. Now, what about even smarter CGM? So even smarter CGM has to do with cognitive computing. And the cognitive computing that Medtronic has is in collaboration with IBM Watson. So the data from CGM system, and this includes not only the glucose, but the patient enters activity and meals and what insulin they have given themselves. And to the extent that all this data is entered, the cognitive computing can give you more and more accurate information, but at the very least, it can look back and look at patterns and then provide real-time insights and assist in the daily management of the patient's diabetes. So there are a number of insights that can be provided. Some of these are motivational. It can have some it remembers patterns and can help with glycemic control, and then the patient can log the food in the app and look at their data. And here's a case study which I think illustrates the power of this smart CGM. So this is a 35-year-old woman with type 1 diabetes on insulin for 14 years. Before the insights were delivered, she was developing a pattern where more and more time was being spent below 70 or 3.9 in the afternoon, and you can see this on the left. And then she got an insight that said, I came across a pattern. Of course, I is the computer. I came across an interesting pattern. You tend to have more time below than normal below target, between 3 and 6. That's something to watch out for. And you can see that that was delivered on June 28th. And for the next several days, the hypoglycemia almost completely disappeared in the next 4 days. So this is the kind of glycemic assist and pattern recognition and information for the patient that is really very powerful. Now, finally, I just want to give you a peek to the future. Medtronic just completed the acquisition of Companion Medical, which has a smart pen called the InPen. And this provides some of the missing data that we all would like to have in all our patients who are on MDI, and that is, did they take their insulin? How much insulin did they take? And when did they take it? So now with this information and with the CGM data, and using the same types of algorithms that Medtronic has applied to closed-loop systems, we can start to apply the benefits of those closed-loop systems to MDI patients. So this will include recommending of optimal doses, recommending actions, and this gives also insights, will give insights that will empower the patients, ultimately yielding in better outcomes. Now, this is future looking. We just completed the acquisition literally this week. So over the next year or two, we're working on this, and we hope to have this available for MDI patients because, after all, they represent most of the patients with diabetes, not only in the United States, but around the world. So just some important safety information about Guardian Connect. It's indicated in patients with diabetes from age 14 to 75. And I'll just let you take a second to read this. And the same thing for CareLink. And this is some safety information for the CareLink report. And you can look at this on these links if you want more detailed information. You can just go to the Medtronic Diabetes website. So thank you very much for your attention, and I look forward to discussing this in the question and answer period. Thank you.
Thank you. It would be nice to have you on the panel discussion. We shall do all the discussions at the end. I now request Manoj to invite the speakers.
Sure. Thanks, Mithun. So it gives me pleasure to invite the next speaker, Dr. Kerry Leon, who's a Senior Director, Global Medical Science and Education with Dexcom. And she'll be speaking to us on the Dexcom iCGM, current status and future direction. So for a lot of our delegates, I know there's been confusion, and probably Dr. Kerry Leon could start with explaining, because iCGM stands for Integrated CGM, where he often tends to get confused for intermittent CGM or implantable CGM. So I think there is this issue about the iCGM being misunderstood, and Dr. Kerry Leon will enlighten us, in this case, on the Dexcom systems.
Well, thank you again, Dr. Chawla, and for inviting me to present Dr. Saboo. Can everyone hear me today?
Yep.
Excellent.
No problem.
Well, good evening to everyone in India. My name is Kerry Leone. I'm actually in San Diego, California, so it's early in the morning my time, but happy to be here with everyone. So as we started off with, and Dr. Chawla introduced, is wanted to introduce the concept of iCGM. iCGM means integrated or interoperable CGM, continuous glucose monitoring. And specifically, that's a designation for the United States from the FDA. And actually, it's a new designation that was given to Dexcom as the first CGM to receive this designation, specifically in 2018 for the Dexcom G6 system. And the reason behind this new designation or category of CGM is that as we move forward toward automated insulin delivery and the need by us as clinicians to individualize care for our patients and the patient's unique needs, the idea is to have an interoperable or easily exchangeable continuous glucose monitoring system with an insulin pump and or a smart pen, like Dr. Vigursky introduced, like Companion Medical. So iCGM, again, is interoperable CGM, and there's three really important characteristics that come from this FDA designation. Number one, it actually will obviously meet the appropriate design, validation, and verification needs to prove the safety and efficacy of this device. And with that design, verification, and validation, there is specific communication platforms and protocols that have been met for the seamless integration and communication via Bluetooth or other medical device systems like an automated insulin delivery or smart pen. And then also, I think the most important for us as clinicians and to our patients, the iCGM or integrated CGM designation gives the robustness and the highest standard of accuracy of all CGMs that are available. So when you hear the designation of an iCGM, even though it may not mean as much to the global community, what that means to you and you can have confidence in is that it is actually the most accurate out there as far as sensors, and it meets the standards of what the FDA has set as the most robust and highly standard system. So what does that actually mean? So not only is it the MARD, mean absolute relative difference, that has actually become a little bit more of a passé standard or metric of accuracy. It's more importantly what they call the percent 15-15. So the percent of time when you're low, below 70 or 3.9 millimole, or above 180 or 10 millimole, what is the percent of time that your CGM reading is clinically accurate and within 15% or 15 milligrams per deciliter of that reference? So the higher the number, the better. But the FDA has set these controls, they're called special controls highlighted here in orange, to say if you meet the standards that whether you're low or high, basically 8 or 9 readings out of 10 are clinically accurate. And there is a very little tolerance for any inaccuracies. So the FDA has set a standard that only 1 or 2% of all the CGM readings during a session can be considered to be inaccurate for the safety and efficacy of that patient. So that is now the new standard. And so again, a quick review is that it's easily communicatable to other interoperable devices like pumps or pens, and also interoperable with different control algorithms for automated insulin delivery, and that it meets the highest standard of accuracy. So that is iCGM. So let me introduce you to the first iCGM in the globe, which is the G6. So the Dexcom G6 is new to, I'm sure, many of you in India. Currently, the G4 is what's available. But the G6 is an entirely new platform. Some of the major key characteristics is if you see here in the center, this is our new applicator. It's designed to be a one-handed applicator with placement of the device and then a very easy push of that big orange button to then deploy the sensor. It's a 26-gauge needle, just as the G4, and insert it into the patient. Then the transmitter is here in front of you, in front of the applicator, and that actually is about a third smaller than the G4. And primarily the size has shortened. So the G4 transmitter tends to be a little bit taller and a little bit wider, and it's smaller footprint on the patient's body. And then finally, the G6 can communicate to a receiver that's dedicated to the device, but most of our patients globally are actually choosing to have the mobile connectivity to an Android or an iPhone smart device. One of the other things with the Dexcom G6 is we've completely ameliorated the need for finger sticks. So it's a no finger stick, no calibration device. It is approved for ages 2 and older, and it's approved for insulin treatment decisions or diabetes treatment decisions without confirming with a finger stick. There's a couple new features that are really unique to this device, which I'll talk about. One is known as Urgent Low Soon, which is a predictive alert to alert the patient if they're going to be within 3.1 or 55 milligrams per deciliter range in the next 20 to 30 minutes. Any concerns with acetaminophen and how the G4 has falsely risen the sensor readings from acetaminophen consumption is no longer an issue with G6. You, of course, have customizable high and low alerts, as well as rise alerts and fall alerts. It's now a 10-day sensor wear instead of a 7-day sensor wear. And it's also then communicating to our software platform known as Dexcom Clarity. So I want to speak on a high level to the accuracy of what G6 is, and again, iCGM. And I think the number one most important thing we feel as clinicians is that, is the sensor providing accurate and safe glucose information? And is that reading going to allow the patient to make safe and efficacious decisions in a diabetes treatment? So what we did is we took Dr. Boris Kovachev's standard safety error grid, and we plotted what the sensor read compared to what the laboratory reference was. And if it's in this dark green, oops, sorry about that. If it's in that dark green zone, basically what that's telling you is that it is clinically accurate and there is no issues with the safety of using that sensor glucose reading for dosing decisions. So when we looked in the pediatric space, basically there's 99.6% of all sensor readings in pediatrics were safe and efficacious or had low or no safety risk to using that sensor reading for dosing decisions. And in the adults, 99% of the sensor readings were clinically accurate and safe to make treatment decisions based off of. So to really, again, quickly go into something similar Dr. Vigursky talked about with the Guardian system, this is slightly different with the G6. Not only is it a predictive alert, it actually predicts to, will the patient be 3.1 or 55 milligrams per deciliter in the next 20 to 30 minutes? And why is that important? So if you see the tracing, this person obviously gave a little bit too much insulin and was on their way down to a severe hypoglycemic event. What urgent low soon does is backs up the alert where 127 milligrams per deciliter may not be indicated of a need to treat a potential hypo, but because of the arrow going down and that rate of change, urgent low soon alert will go off, giving the patient plenty of time for appropriate rapid-acting carbohydrates to avoid severe hypoglycemia. That is a new feature, and it's defaulted on as all patients start G6. One of the other things we're tracking now that G6 has been out in the world for the last 2 years is what are some of these features doing for the outcomes of our patients and their improvement in glycemic control. One of the things we saw with tracking all of our de-identified data in the United States is for those people that were using G5 and transferred to G6 and used the urgent low soon feature, there was at least a 6-minute time below range reduction for less than 55 or 3.1 millimole, and a 10-minute reduction of those patients staying at less than 70 or 3.9 millimole. So correlationally, we're seeing that this feature really is helping improve the patient's time in range and reducing time below range. Another important feature for both the patient and potentially the loved ones and caregivers of the patient is we introduced with Dexcom G6 to soon hopefully the Indian market is the remote monitoring feature of Share Follow. So what this ability is the person with diabetes can invite up to 10 people, maybe a mom, dad, husband, best friend, to be able to monitor their glucose from anywhere in the world. So my dad has type 2 diabetes taking insulin, and when he was using the G6, I was able to travel all over the world and see where his glucose was at any given point. And importantly, me as a follower, especially if I was concerned with severe hypoglycemia, could set alerts on my smartphone that would let me know if my dad or any patients that I was following had an impending hypoglycemic event, so I could make sure and follow that they treated that appropriately, and especially overnight, making sure there's no concerns there. Another interesting feature of G6 is that you also have an option to use Siri. So for people that are maybe vision impaired, another option is that you'll be able to ask Siri, "Hi Siri, what is my glucose?" And Siri will come back and say to you, "Your glucose is 110 milligrams per deciliter, trending flat." So that's also very nice for any patients that have vision impairment. We also are looking at the efficacy of this Share and Follow feature. This is specifically with the pediatric population, but we see the same trends with adults, is that whether you're between ages 2 or 5, 6 or 12, and 13 and 18, and also over the age of 45 in the adults, if you're using Share and Follow, there's an increase in the utilization and the wear of CGM. Why is that important? Because we know if patients use real-time CGM 70% or more of the time, that correlates to improvement of overall glycemic control. The more followers patients had, the better their wear time was. And more importantly, clinically, not only did they wear the device more often, they were also able to increase their time in range clinically significantly at anywhere between 4 and almost 10%, which is clinically meaningful, just by using that feature. So there's no durable components to the device. So my last two slides is really kind of talking a little bit what Dr. Vigorsky was speaking to, is that as we move forward in the technology of real-time continuous glucose monitoring, we really want to give patients and clinicians the choice. And with iCGM, you have the interoperable or integrated capability fairly seamlessly because of that communication platform being standardized. And so with the G6, globally, we're able to then communicate seamlessly to the tandem insulin pump, and now the first advanced automated insulin delivery system in the world, where it actually will attenuate your basal as well as give corrective boluses without patient interaction. Also, in the future, automated insulin deliveries like the Insulet or Omnipod 5. In France, there's the Diabeloop automated insulin delivery system. And also in the UK, you have the CAM APS system from the University of Cambridge. All of these systems are integrated with G6 at this point, except for the Omnipod 5, but we look forward to that when they are approved by the FDA. But also, as with the Guardian Connect system, you can also, for those that do not prefer insulin pump therapy, have smart pens like the Companion Medical, the Lilly pen, or the Novo smart pens in the future to be able to give automated treatment guidance based on that smart Bluetooth technology. And so last but not least, I want to leave with the vision of what is real-time CGM and interoperable CGM look like really as a category. This was really the vision of the FDA and Dr. Courtney Elias specifically, that the world should be able to have the opportunity to pick what insulin pump is best for my patient, what CGM is best for my patient, and what is the controller algorithm, the brains behind the insulin delivery, and is that maybe different for one type of eye controller or another? So interoperable algorithms, interoperable pumps, and interoperable CGM, with the vision that the patient and HCP will be able to make those interchangeable decisions that's best for them as an individual. So with that, I thank you for your time, and I welcome questions at the end.
Thank you, Dr. Leon. We shall take the discussion at the end. I ask Manoj now to introduce the last
Thanks,
speaker.
Mithun, and thanks, Dr. Leon, for that interesting clarification on the iCGM concept, and we'll have questions. Now, it gives me great pleasure to welcome our last speaker for this session, Dr. Frank Kaufman. Is Dr. Kaufman here? Yes. So, Dr. Frank Kaufman, who used to be the Chief Medical Officer for years for Medtronic, is now the Chief Medical Officer for Senseonics. She's a distinguished professor emerita of pediatrics at University of Southern California, the Center for Endocrinology, Diabetes and Metabolism, Children's Hospital, Los Angeles. It's a great pleasure seeing you and meeting you again, Dr. Kaufman. So remember the times that we were hosted by you and the group, Dr. Jyoti, myself, and some others at your lovely place in LA, and those evenings after the technology sessions. We look forward to listening to Dr. Kaufman on the experience with the Eversense implantable CGMs. Dr. Frank Kaufman.
Can you just take a couple of questions, because I think she's facing some difficulty in joining in, so we are sorting out.
Okay. Hardik, do you want to play a video, and then probably I will...
Okay.
Hello everyone. As we've heard today, chatbots can help patients in many different ways, the easiest being managing all appointments. So let's say a patient comes in and the chatbot asks, "Welcome to the hospital, how can I help you today?" Okay, so if the patient wants to make an appointment, the chatbot can prompt, "Are you talking about a general health checkup or are you interested in meeting a specialist?" It can list all the doctors available, give an option of booking appointments by looking at the doctor's calendar, or even understand if the patient wants to actually say that they want to book an appointment. Perfect. So if the patient wants to book, that's how easy it is. Another very interesting use case for hospitals is an assistant, which is helping the doctors to go through their entire day. For instance, the chatbot can help the doctors understand how their day looks, how many appointments do they have, see patients' reports in the morning when they come in, to make their day much, much more easier. For instance, the doctor picks today's appointment. It can tell the doctor, does the doctor want to see some new cases or do they want to look at the old cases? So for instance, if the doctor says new cases, it can give the doctor details about the patient information, exactly when these appointments are scheduled, helping the doctor go through the day much quicker.
Thank you.
Thank you, Hardik. I think we are getting some opportunity for starting the discussion before Dr. Frank joins in. We are also pleased to have Dr. Jyoti Dev back with us, Dr. Viral Shah, who's also now an advisor to the Indian Diabetes Technology Network Force, and he's joining us today from the Barbara Davis Center. And of course, we have Anna Saw, Paul Amritraj, Dr. Kerry Leon, and Dr. Robert with us. So if we can start some of the questions, let me take the opportunity to ask Anna the first question. So Anna, when we speak today about the recommendations for time and range, the question very often asked is are these applicable or only to the real-time CGM use derivation, or this is also applicable to the professional blinded CGM derivation, the time and range?
Like can everybody hear me okay?
Yeah.
Okay, great. So in my presentation, in the last slide, I show you that the timing range is available in our current Libre Pro system. So the answer is yes, it's available in the Pro system.
Right. So the question again, very often that's raised in India after the recommendations for TIR came in, especially in the pregnancy segment, is the time and range being changed to 63 to 140? And the software available in India doesn't allow one to change that to below 70, the time and range. So how does anybody change that to 63 to capture the patients between 63 and 70?
So you can change the target range in your reader. That the target range is changeable.
And it doesn't allow, not below 70. It doesn't allow.
Oh, you mean get it even lower? Yeah, in the system, because of the safety concerns, it's not okay to even go lower.
But that's what the international TIR recommendation are now talking about in pregnancy, that it should be between 63 and 140. So if we don't your system doesn't allow us to lower it to 63, how do we follow the international TI recommendations? If Anna or anybody else here wants to come in to answer that.
I think the other systems are having that option. We are using the Medtronic systems, and there is an option, and we can now. But with the Abbott Libre Pro, because we don't have the Libre in India, we have only Libre Pro. There, as Manoj has said, this option is not there for the pregnancy. Maybe they are getting more evidence for pregnancy. Anna, there is one more question from us. We have Libre Pro, and then we have Libre 2. And we know that the accuracies are different for the three sensors. Correct. The MARD is different. And when you compare Libre Pro with Libre, are you using a different sensor since the MARD is different?
All those, so far in India, only Libre Pro is available. And then, of course, sure, in the future, Libre or the second generation will be made available in India. And the sensors for different version of the Libre system are different.
But different systems are different. So the Libre Pro will have a MARD which is close to 10 or even 11, and the Libre will have a MARD of below 9. Am I right?
Yeah, you'll have improved the MARD for Libre, and also the second generation of Libre is improved.
Improved further. So in Libre Pro 2, in future probably we will have the same better sensor.
Yeah.
Okay. Thank you.
And I have a question for you. When you have the expiry on the Libre Pro, when it mentions an expiry, in my experience, it comes 1 month closer to the expiry, the product becomes a little unreliable. I do not get decent data out of it when it comes to closer to the expiry 1 month before. So what do you recommend? If the date is 31st July, do you recommend the last patch put on 31st July, or you put the last patch put on 14th July? I've done both, and closer to the last month, the data has been absolutely unreliable when I compare it. What is your experience? That's one question. Second, it tends to overestimate hypoglycemia. So what is your answer to that?
So when the sensor is within expiration dates, we don't really expect that the MARD or the accuracy will be lower compared to other batches who may have a fresher expiration date. So if that happens, we're welcome to contact our customer service. But in general, we don't really see that happen.
Okay, and what about the overestimate hypoglycemia?
Sorry?
Tends to overestimate hypoglycemia. So if I'm going to use the Libre Pro in time in range, it might tend to overestimate my hypoglycemia.
Also, in a large data set, we don't really see an overestimation of hypoglycemia.
Okay. We move to the question to the other panelists. Thank you, Anna. Paul, are you still there?
Yes, doctor.
Right.
Yes,
okay.
doctor.
So Paul, you presented your new CGM system. In terms of its approval across the globe and its validation, if you can let us know where does this product stand, and where do you place your real-time CGM system as compared to, if I can say, the more established systems from Abbott and Medtronic and Dexcom?
As far as the approvals are concerned, we are already marketing it in certain countries of Europe. So we already have the Europe pre-sale certificates, and it is being marketed in few countries. And it has been, we are expanding in Europe very fast. So that is one part of it. The second part of it is that if you want to compare the i3 systems of Infinova, then it has to be compared against Dexcom. Dexcom is the only one which has the MARD which is coming around 10. So we are looking at MARD around 10 or even less than 10. As you have seen in the clinical studies, the MARD is around 9.9, about 9.5. When it comes to the i5 systems, the MARD is going to be much, much lower. So the research is on that side. So that's where we are now positioned. We are looking at much more better MARDs for the product, and also we are looking at expansions in Europe very fast, and also looking into expansions in India and in the Southeast Asia.
Sure. Thank you, Paul. Dr. Jyoti, anybody wants to ask question.
But there are two good friends sitting over there, Kerry and Vigersky. So my first question is to Kerry. So you have been with Dexcom for a long time. I remember you coming to our center, and from there, I think the sensors have become very, very accurate now. And that is an exciting story. So my question is, when you are assessing the MARD of a sensor, the one that is published, it can be 10 or 9 or 8. It varies in type 2 diabetes versus in type 1 diabetes. So with Dexcom 6, which is one of the best sensors around the world, what is the MARD in type 1 diabetes versus in type 2 diabetes?
Yes, so one of the things we look at is it's one of the standards for looking at MARD. Is there any difference in the pediatrics and adults, as well as people with different BMI? We don't actually see any difference in patients with different BMIs. So often, sometimes people with type 2 diabetes may have larger BMIs. There's no accuracy difference that we see with that. When we look at the overall MARD, just in general for a cohort of type 1 or type 2, our studies looked at intensively managed type 1 and type 2 patients with an MARD that was basically almost exactly the same. So no difference between the two cohorts. What would be nice, maybe just for the panel and the audience to know, there was a substantial differentiation in accuracy for adults versus pediatrics. So our overall mean absolute relative difference for pediatrics ages 18 and older was 9.8%, but for pediatrics ages 17 or younger down to age 2 was 7.7%.
Oh, excellent, excellent.
This is Viral Shah. Jyoti, can I add a comment?
Yeah, please.
So thank you for bringing up a point about the MARD. I feel like the MARD is probably like an A1C. It does not provide you all the information you need. So take the MARD with a pinch of salt. MARD is a mean of absolute relative difference, and Bob can probably speak more about that. He's an expert in this topic too. It depends on a sample size. It depends on how it's being calculated. It depends on whether the study was done with the arteriovenous sample blood collection. What is the comparator here? I can keep talking about the problems with the MARD. And in my talk tomorrow in India, that's going to be my night here, I will bring up a point that MARD can be misleading. So what I want to just say in one line is that just don't emphasize just on a MARD.
If I can,
Gary also brought up the points about percentage 15-15 and percent 20-20 and other metrics too.
Viral, if I can come in and ask, so if MARD shouldn't be relied upon, do you think the FDA and EMA should have some other marker to look at the accuracy of the CGM systems?
Great question, Manoj. That's why Kerry, first slide of Kerry was about the iCGM standards by FDA. And did you see only MARD there? No. It was percent 15-15%, 20-20 in a different range, right? Hypoglycemic range, hyperglycemic range, normoglycemic range. So FDA does not rely only on a MARD. MARD is one of the metrics, let's put that way.
Okay.
It's not the absolute metric.
Sure. Thank you. Thank you so much.
There is a question in the chat box, and I open that to all panelists. In COVID times, can the CGMS be used for, rather than picking the patients all the time, and in terms of safety use? So is there any data that all of you have required, or any studies that are ongoing?
You are talking of the patients who are in ICU, or you are talking in the patients who are in hospital or outside the hospital?
In hospital, that would be more practical because the healthcare workers would have been doing, and even outside the hospital. So has there been any studies that they have started or they're planning?
In ICU or non-ICU? On inotropic agents or non-inotropic agents? So
I think what the delegates are asking, Mithun, clearly in countries where there is real-time CGM being used more, whether it's the Libre series or the Dexcom, the patients have, of course, benefited greatly, and largely the communication between the physicians has been also based on that. I'm aware of data recently published by Dr. Satish Garg, and I'm not sure whether Viral was also part of the same, publication where they have spoken about the usage of CGM during times of COVID and the lockdown, as to how use of technology has actually helped better communication and transfer of data, of course, from patients to the doctors. The problem in India has been the usage of real-time CGM is only through Guardian RT, which doesn't have a great usage as of now, and we do not have the Libre series, which tends to get used more in India because of wider availability and the cost benefit to the Indian patients. So, which actually gets us to the next question, if I can move to Dr. Robert. In terms of the Medtronic CGM systems, the question very often asked is, what's in the pipeline? Are we looking at non-calibrated sensors from the Medtronic stable?
Yes, absolutely. None of the companies that are involved in CGM are standing still by any means, and certainly Medtronic is not. We are expecting to have non-cal and non-adjunctive use of our sensor with a new algorithm sometime within the year, and then we have already in pivotal trials a disposable sensor, which will have a smaller footprint and I think be much more patient friendly than we've had up to this point. And then extending the length of wear and extending the accuracy is all in our pipeline, and we're in trials and feasibility studies for all of these. So I think anybody who knows Medtronic knows that we're not going to rest on our laurels.
Sure. So on a lighter note, if I can ask Dr. Robert, did Medtronic see the Abbott Libre coming?
Did we see it coming? Of course. Yeah, I mean, each company keeps track of everybody else for sure, and so there's a lot of competitive intelligence that is in our industry, which is very healthy, and it keeps us all on our toes and trying to improve, which is in the end what we want because it benefits the patients.
Of course. Dr. Carey, if I can ask you, and I'm not sure that you're aware of the situation here in India. So Dexcom is definitely looked upon as one of those CGM systems which is highly accurate and one that the physicians and patients wish to use. What happened in India? We are aware that you're not now largely present and available only selectively through channels. So where did the story not go in the success pattern in India? What really went wrong?
Yeah, thank you for the question, Dr. Challa. So as Dr. Jyoti Dev and some of you actually know, I was one of the actual individuals in 2009 to introduce Dexcom G7 Plus to the Indian market. Our CEO at the time, Terry Gregg, we traveled throughout all of India and had the wonderful opportunity to meet so many of you and interact with your patients. That was, again, 2009 with the 7 Plus. We had a specific distributor at that time, and unfortunately things evolved and did not work successfully with the distribution and to be able to really support you as the clinicians in India and as well as the needs of your patients. So we tried again with the Dexcom G4, and as you know, it's the one that's currently available. But again, a different distributor, again, no success. So, what I really want to do today is apologize for Dexcom and our inability to really support the Indian market, but really give the confidence that we want to. And we're taking this very seriously, where we're actually looking and doing a lot of investigation as to what are the needs of the market in India, so we can match what you need. And then the next time that we do come to India, which we do plan to be very soon with G6, it already is currently available and approved in India, that we have the right tools and partners to be able to stay sick and really be part of your clinical practice.
Sure. Thank you. We hope that happens soon, and all the best for that. Okay. Mithun, Jyoti, Banshi. Yeah.
A question for Paul. When do we expect touchdown of your product in India?
Yeah, we have been actually anticipating the launch of Dexcom. Of course, Dexcom was launched long ago, and I think the Indian market could be a different market. And the whole intention of this program and inviting people like you from the international community is to encourage and to entertain your presence in India, because we are completely aware of the accuracy of Dexcom, and all of us are completely aware, and even the doctor, and we have been presenting the data time and again. So, do you have any specific product that you are planning for the developing countries or for the Indian market? Because Indian market, I believe that Manoj will totally agree with me, Midhan will agree, because we have experience in the UK as well. This is out of the pocket expense, the CGM. And Dexcom is priced, very high when compared to any other CGM in India. The price is so high. So it is not just unaffordable, we cannot even discuss the price with the patients. So will as doctors, very sincere to you, will have an option to have Dexcom as a product with a lesser price for India or any other alternative?
So yeah, so thank you for that comment, Dr. Joseph. I really appreciate and empathize with some of the challenges that you bring forward. That's one of the reasons why we've kind of held back in India, Dr. Jyotidev, is to really reassess what is that price point that's going to be able to be appropriate for your patients and for you as clinicians. So the answer is yes, we are not going to enter the market with the pricing that currently has been for G4, and that's one of the things we're reevaluating.
Okay. Anna, if I can move to you before I also have a question for Paul later. But so Anna, from the Abbott side, Libre Pro, Libre 2. What's next? What are we looking at in the next year or two to come?
Of course, it will be a next generation, but unfortunately, I won't be able to share that information with you. But yeah, there will be new things coming.
I can assure you we'll all be shut and nobody will speak about it.
No, I'm still not able to share. But I would like to add in something we discussed about pregnancy before. So I just checked for Libre Pro in India. We do not have pregnancy indication for Libre Pro. That's something we need to keep in mind. That's why the target range, we're not able to set it for the pregnancy recommended target range.
Sure. Yeah. Thank you. Paul, if I can ask you, so today all the CGMs are including the AGP derivation in their reports. So in India there was this earlier belief and myth that AGP is only possible with the Libre Pro series, but today we know that AGP is a product from International Diabetes Center, and people can acquire the AGP and put that in the report because it's gotten popular and is easy to look at, and physicians and patients are understanding the AGP derivation better. Will your system reporting also have the AGP incorporated in it?
Doctor, the AGP reporting will be incorporated, but we are going to have the complete reports only on real-time ranges which has been given by the product. So it's going to be a real-time glucose sensor, and the analysis reports, everything is going to be on that. It's not going to be the ambulatory side.
I want to say something more about our Vygotsky, because Robert Vygotsky is the one who published the data connecting our glycated hemoglobin with time in range, which we keep on citing in our lectures. So that need to be reintroduced again. So my question is, now we are more focusing on time in range. And time in range, I understand that AGP is a property of the International Diabetes Center, and every company has to purchase it and you have to incorporate it in the report. And we are all glad to see that Medtronic is also providing us with the report of International Diabetes Center derived AGP. And our Dr. Banshi Saboo, he is one of the members of the committee, and he has been in the consensus of the ATTD ADA on time in range. And we are now more and more using time in range. So with Medtronic products, we have been using the CGM for a long time. And then the CGM used to be integrated with the insulin pumps. And iPro 2 has been the product that has been most popular in India. But in a recent communication with Bob Vygotsky, you were telling me that that product is going to be phased out. And what is the exact reason? Because I believe that this product is still very popular. Is it because of the inaccuracies or any other reason?
No, so it is correct that we are phasing out professional CGM, but what will ultimately replace it is the ability to use Guardian Connect in a blinded or real-time mode. So rather than have two products, we will have one product with software that can accommodate both uses. Because, as you know, and I think most people who have used professional CGM see a benefit for having blinded CGM. Certainly, all interventional studies use it because the intervention of seeing whatever the intervention is, whether it's a new pharmaceutical or psychosocial intervention, you don't want it to be clouded and with another variable, and the variable, of course, would be seeing what the CGM reading actually is in real time. So most studies, if you look at the literature for the last 20 years and including up to today, you'll see that iPro has been used and occasionally Dexcom blinded CGM with the G4 because that allows the investigators to get an unbiased look at what's going on with glycemia with whatever intervention they're planning. So I think we all recognize the importance of professional CGM, blinded CGM. So we will be able to have that availability in our next generation.
So one limitation with the use of Guardian Connect in India, which we have been experiencing from our patients, it works only with some phones. The Bluetooth connectivity is good only with the Apple iPhone and with selected Android phones. So why should we limit it only to Apple? Any particular reason?
No, well, actually, it should be. Unless I'm incorrect, all our Guardian Connect systems now work with both Android and Apple iOS.
Only the higher Android system. So you're right, it does work, but
yeah. You know, as we all know, the operating systems for the smartphones change all the time, and so to retrofit doesn't make sense. We need to go look forward and make sure that they're operable with the new systems as they come out.
I have a patient who is morbidly obese, a BMI of over 40, and we have difficulties with the use of Guardian Connect. It works, but many a time, even when it is deployed correctly, it doesn't function. So does it have something to do with obesity? In general, need not be Guardian sensor alone. It is a common question. Is it something which is commonly observed?
No, we are not aware of that. You know, as Kerry mentioned, the accuracy and the usability of these devices in type 2 and who are generally obese, if not morbidly obese, is as accurate. Actually, the MARD is actually better in type 2 because their glycemic excursions are not as dramatic as they are in type 1. But that aside, you know, there always are issues with morbidly obese people in terms of their sweat and their ability for these adhesives to stay on. But the actual sensor should be just as accurate in these patients.
Yeah, I totally agree with what Bob said, is that the BMI of 35 to 40, we see that all the time here. So sometimes 35, I feel like, it's normal, you know, it's not that bad. And so sensor should not have any issues with BMI of 35, 40.
Good morning, Dr. Satish.
Good morning. How are you, Jyoti Dev?
Good, good, good. How are you?
Good. Good morning. Good morning. A lot of good faces that I can see this morning. Good morning, Banshi.
Good morning, sir.
you want me to start?
But
Just we were going to wind up the last session. Dr. Kaufman was to join us, but she's unable to. So the session on implantable ever since experience will miss. I can request Dr. Garg along with his talk, if he's been using it, as Dr. Kaufman is not here, our delegates are pretty keen to learn from the experience. If you want to add a few words once you start, Dr. Garg.
I think he can stay now because his keynote, his lecture is going to be only at 8:35, right?
Right. Yeah. So we do have time. We will probably be
we have time. Yeah.
Getting in the session earlier. So Dr. Satish, sir, we were talking about different CGMs, and we had this session on the Eversense implantable CGMs. Would you like to share any experience with those systems?
Yes. So the study has been done at the Barbara Davis Center and many other sites, where they are trying to look at whether this device can work for 6 months. As most of you know, it has been approved for 3 months in the US, but has been approved for up to 6 months
in the EU.
In Europe. But if you look at academically the data, really the sensor does not last for 6 months. Even the European experience says the same. I don't have the final data. I am the global PI on that study that Fran was going to share with you data. I believe they are in the process of analyzing it. There are a few things one needs to keep in mind. Yes, the sensor is very small, but it needs calibrations every day. I cannot imagine myself going into 2021 having patients using finger sticks anymore. And that is one thing that Bob Vygotsky has to work harder to eliminate these finger sticks completely. This is the future. If I see a patient who has a meter with him, which happened actually last Monday when I was seeing patients, this patient has had diabetes for 40 years, was still using the finger sticks. I said, show me your meter. I threw it in the trash, gave him the new Dexcom sensor, G6. 2 weeks, 1 week later, he calls me, he says, Doc, this has changed my life. I said, sometimes you need to listen to your doctors. Most of the patients don't listen, especially in the US. So I think those are some of the caveats. I don't know. At least here in the US, the issue was how much the insurance is going to pay and what are they going to reimburse, because they had the promotion going on for $99, but then there was no reimbursement to the clinics. So we completely stopped it, especially on top of COVID being the issue. So I don't think much is being used in the US right now, partly because it's only 3 months, and I don't know what is their future plan. That's all I can tell you. I haven't seen the 6 months data, but we'll be seeing it soon.
So just one question. Jyoti, go ahead.
Yeah, in DTT, I read an article on the failure rates after implantation. So is it common to have such frequent failures?
So in the original study, if you look at the diabetes care article, about half of them lasted 4.5 to 5 months. So truly it didn't last for 6 months. This new study, I believe they made some changes. This is unofficial. I think it's somewhere in the range of 10 to 15%, maybe up to 20% do not last the 6 months. I don't know the data. I haven't seen the final data set. The study has ended in the US, but I haven't seen the data.
So just one last question on that aspect. How difficult or easy is it for the implant, and who's been doing it at your center? Is it the doctor doing it?
It's very easy. Yeah, even the mid-levels do it at our place. Viral does it. And also Khan, he's expert at that. He has found a way to really track, because sometimes these things move. I remember my days with Dexcom. Carrie was, I don't think she was there at that time, Carrie. This is 25 years ago when we implanted those AAA size batteries in these people. And even in India, my God, they move to the other side of the stomach. The point being that everything moves based on the subcutaneous tissue, its health, as well as the fat content. And so they do move. Khan, who is one of our junior faculty member here at the BDC, in fact, shares office with Viral, found a very nice way to track them so that you can use these, the way you can see where the veins are, same way you can sort of easily detect. So time-wise, depends on the expertise. It doesn't take more than, I would say, average 10 minutes, because you have to have all the procedure. Now, in the US, it's a big deal because you have to have the clean tray and all those things. But so far in the US, nobody was reimbursing it.
I would just add my 10 cents here is the good thing is that for a young endocrinologist like me, we don't have a procedures. And this was the first procedure to do something, right? So it wasn't exciting. Number two is, for me, I have done a lot of insertions and removal. Removal depends on your insertion. So if you put it superficial, 99.9% it will be easy to take out. By chance, if you put it deep, then the trouble starts there. So insertion is the key for removal. And so far, we haven't had any trouble. And as Dr. Garg mentioned, that vein finder is the best way to locate the sensor and take it out if needed.
Thanks, Viral. I was asking this question specifically because we in India at my center did a pilot study for Sensionics. That time it was called SMSI. And I actually needed a surgeon friend to do that minor surgery and insert. So that was the initial implantable sensor that they had. Now, of course, it's developed to this fine insertion system. But as you said, Viral, what it's going to do is convert few of us into interventional diabetologists, something that we all have been kind of envious of our cardiology friends. As interventional cardiologists, we probably are getting a procedure to do. Everyone in this session, it's been a pleasure hosting all of you. I think we had some wonderful session, great discussion. We've been upfront with some frank questions related to India, the cost, the plans ahead, and all of you have been very forthcoming and sharing your thoughts and idea. On behalf of Dr. Mithun Bhartiya, my co-chairperson, and myself, the entire diabetes task force, again, take this opportunity to thank all of you for being here and sharing wonderful thoughts on continuous glucose monitoring. That clearly would seem to be the way ahead. And as Dr. Satish Garg said, and in a way, he wasn't here for the previous SMBG session where we were talking about where SMBG would be 5 years from now. But I think he gave his verdict as to what he feels about SMBG. CGM seems to be the way ahead. Thank you so much again for being here. With this, we end this session and hand it to Hardik if there is a video to play. Or Hardik, is there another?
Can I just make one last comment?
Yes.
You said some of us might become counterpart of interventional cardiologists. I won't hold my breath on that. It is a big challenge to have these insertions, and how much is the adoption, the cost and all that. I would be very careful in making that sort of a leap, especially when the sensors are becoming so good and accurate. 10 days or the 14 days, you just insert size of a hair. I'm not sure I would go that far, Manoj. That's just my thought.
No, that was just on a lighter way.
One last question, Dr. Satish. Do you believe that the MARD is better? Because we were having a discussion on the MARD. Is the MARD better with the implantable sensor?
No, it's about the same. No, I don't think so. And the problem is they are, of course, trying to get iCGM approval. That's what everybody is trying since Dexcom set the new standards a few years ago with G6. And that's why a lot of the studies using the YSI were done here and many other places. We'll see what the data is. Remind you, Dexcom and Bob also, the Medtronic can do that because they have an iSig. They can go back and look at the data and adjust the algorithms. So I wonder if they will have the similar, I mean, I can go into the technicalities, what are some of the issues that they might have, because it's a very different way. It's a fluorophore is what is being used. By the way, this is nothing new. This was described like 50 years ago, the first time that this could be an option to measure the glucose. So it's nothing new about it. So I wouldn't go that far. That's all I would say, Manoj, that to making all of us as an interventional.
You're breaking my dream, you're breaking my heart, but I'll live with that for now. Right. Okay, thank you so much.
Thank you for inviting us.
Thank you.
Thank you.
So we have Dr. Francine joining in 2 minutes. We have Dr. Francine joining in 2 minutes.
Oh, do we? Okay. So I think we've had the discussion of Dr.
Yeah, she actually messed up with the timing, so she's joining in 2 minutes.
So we were supposed to have Dr. Garg's, Dr. Satish Garg is here. His talk was to start at 8:35. If Dr. Kaufman is joining in now, we will probably have a 15-minute talk from her, if okay with Dr. Satish Garg.
Sure. I mean, if then I can sign out if you guys.
No, you please.
No.
Yes, sir.
We will make sure coffee reaches your table, sir.
Yeah, it's going to be a virtual.
Right. So till she joins, and I think we still have Dr. Garg here and Viral and Jyoti. So we may continue the discussion unless there is a technology video, Bansi, that we can play before Dr. Kaufman joins in. Hardik, can we do that?
Yes.
Okay. Let's do that. Thank you.
Hello, everyone. As we've heard today, chatbots can help patients in many different ways, the easiest being managing all appointments. So let's say a patient comes in and the chatbot asks, "Welcome to the hospital. How can I help you today?" Okay, so if the patient wants to make an appointment, the chatbot can prompt, "Are you talking about a general health checkup, or are you interested in meeting a specialist?" It can list all the doctors available, give an option of booking appointments by looking at the doctor's calendar, or even understand if the patient wants to actually say that they want to book an appointment. Perfect. So if the patient wants to book, that's how easy it is. Another very interesting use case for hospitals is assistant.
Hardik, I think we've been through this video. Hardik, can we wind it up? We would like to proceed with the next session.
Help the doctor.
Right. Thank you. Hardik, thank you. I think we'll proceed with the keynote address as all the delegates have joined in and waiting for the same. With this, I will hand it over to the chairpersons for the next session, Dr. Sanjay Reddy, and joining him to moderate this session, Dr. Sudhir Bhandari, who will be joining in, and Dr. Jyoti Dev will also join Dr. Sanjay Reddy to chair the keynote address session. Over to you, Jyoti and Sanjay.
Good evening, everybody. Good morning, Dr. Satish Garg.
Good morning.
Yeah, okay.
Can we have the slide of Sanjay Reddy? Sudhir had not joined, yes. Yes. So Sanjay Reddy is a MD who is a fellow of Diabetes India, who is a member of Executive Council RSSDI National. He is a consultant diabetologist at Center of Diabetes and Endocrine Care at Bangalore. He is a consultant diabetologist at Fortis Hospital. He is visiting consultant at multiple hospitals of Bangalore. He is a principal investigator for more than 30 clinical trials in diabetes, obesity, osteoporosis. He is a vice president of Primer Academy of Medical Science. Along with him, we have Dr. Jyoti Dev, who will be chairing the session, the important session of keynote lecture by Dr. Satish Garg. To introduce Dr. Satish Garg, I invite Dr. Jyoti Dev to introduce Dr. Satish Garg and from few words from Dr. Sanjay.
So Dr. Satish Garg is a close friend of all of us. He's a world-renowned endocrinologist. He's currently the professor of medicine and pediatrics at the University of Colorado School of Medicine in Denver, Colorado. He's widely known as the editor-in-chief of Diabetes Technology and Therapeutics, the prime journal of technology for diabetes, a highly indexed journal since 2006. And he conducts a convention every year, and that is the Keystone Diabetes Conference in the US. So over to Dr. Satish Garg for our prestigious keynote address, and this is on a very currently relevant topic, health economics of COVID-19 and adaptation of virtual care. Over to you, sir.
Few words from Dr. Sanjay Reddy, if you want.
Good morning, Dr. Satish Garg. I think we met a couple of years ago in Bangalore, and we're looking forward in unusual times in a virtual conference, trying to listen to you on a virtual clinic and adapting the same, or probably all of us are trying to do some part of it, but we're glad that you're going to address all of us. So over to you, Dr. Satish Garg. Eager to listen.
Thank you all very much. Let me make sure that I'm able to share my screen, because I've got two computers going here. So share my, can somebody allow me to share my screen? Can you all see my screen?
Yeah. You can see your screen.
Yes.
Awesome. Yeah. Well, thank you very much to Banshi for giving me this opportunity to talk to you all a very important topic, how COVID-19 pandemic might have impacted all of us economically, especially the healthcare industry and the clinics and the hospitals, and what are some of the challenges and opportunities that we might have. I'm going to take about 20 minutes. It'll be difficult to cover all the topics, but I'll try to do my best in the next 20-25 minutes. As all of you know, there were a lot of different terms used: stay at home, shelter in place, lockdown, stay at home. In Colorado, I'm talking specifically about Colorado, but I'm sure the similar lockdown orders were also in place in India. Based on this, I'll give you the global picture of economic burden from COVID, where it's headed, and also talk about COVID and diabetes, especially for type 1 and type 2. What are some of the opportunities it might have created for us, especially as it relates to virtual care / telehealth, and touch base very briefly on some of these topics: new onset type 1 diabetes, how do you manage decay during these COVID times, inpatient diabetes management, and if time allows, telehealth for the elderly and the pregnancy. Last but not the least, could COVID be the cause for type 1 diabetes? I'll give you some glimpses of some of the work that's going on behind the scene. And what are some of the lessons we might have learned from this? The economic impact might be related to loss of income and jobs. As many of you know, it hasn't really shown its impact right now, at least in the US. A lot of my perspective, because the data is available from the US, is probably related to only the US or the Western part of the world. We anticipate to 20% of people will lose jobs, and the real impact hasn't really shown. As my son will tell me, since he's in the finance world, that we have printed so much of money in the US, trillions of dollars, that they have just flooded the market. Go back to 2008, only less than $1 trillion was infused into the marketplace, and that led to a gradual recovery from the meltdown, which was related to the housing market in 2008, and it took about 8 years. But this time you will see some people call it a V-shaped recovery or K-shaped or whatever terms you use. But the fact is that because they went too big, $3 to $4 trillion have been already infused into the economy. So it's an artificial adjustment that has happened. But the real effect of this is probably going to show up in the next 6 months to a year. Right now, people are still buying homes because the interest rates are so low, but pretty soon down the road, when they don't have jobs and when they don't have income, that's when it's going to show. Fortunately, in the US at least, there is no inflation or hardly any inflation because it's also being kept in check, but that will have another impact on the economy. So if you look at the global perspectives, in the US, about 20% of the total GDP, which is huge, $4 trillion, this is before COVID, is spent on the US healthcare. And about $1 trillion, I'll show you this data, is a lifetime cost for type 1 diabetes in the US, which only accounts for about 1.6 or 1.8 million people with type 1 diabetes. Now you look at underestimated number of 30 to 35 million people globally just with type 1 diabetes. You can do the math. If people were to get all opportunities for excellent care, the cost of T1D alone is going to be in trillions of dollars. Obviously, not at all possible. In the US, again, this is older data, not looking into the COVID, about $300 billion in the US, which is 8% of the total healthcare cost, which is huge. And about $1 billion for the acute complications that's primarily related to hypoglycemia and or the ketoacidosis. So we have a much bigger problem even before COVID happened. And now let's look at what happened with COVID. This is the slide I was referring to. It shows what is the lifetime cost that is entailed just with type 1 diabetes, which includes, of course, the societal cost. It's all total cost. It's not only taking care of just the patients, it's income loss, direct medical expenditures, and the societal cost. So this all adds up to about $1 trillion in the US. And this was published a little bit earlier this year before the COVID hit in the US. I don't know what happened. Okay. What is the diabetes cost in Europe? Again, it is very variable. You can look at the numbers. It'll be very difficult for me to go into the details of this, but obviously US is far above any other country. And when you look at the output or the outcome that we see in the US is far lower, whether you look at diabetes, cardiovascular disease, or any other long-term illnesses. So this I updated only about, when did I update this? This slide was updated September 7th, as many of you can see. Unfortunately, this is increasing. I'm sure the numbers are much more right now. Nearly 30 million people have COVID-19. Many of you recall 1917, 1918, about 100 to 200 million people were affected by the flu or the influenza virus. And unfortunately, we didn't have a good accounting those days, but somewhere in the range of 100 to 200, at least it's expected, at least the data shows, about 50 million people at least died at that time from the influenza. So this is once in a lifetime infection that has caused global pandemic. And you can look at the numbers which are growing everywhere across the world. The unfortunate part is, if you now look at the economy, how has it affected the economy? This is showing you a week by week. Go back to January 1 in the US, and now looking at US business and the consumer spending. From 5% went down to minus 12%. So the theme is overall the same. Lumber, steel, coal production, electricity, and the rail traffic, all down. Look at on the right side, the discount store sales, like all these Medi&F and all the stores that people go to, was about 14% just before. The real hit that happened in the US was around first week of March. Look at after first week of March, it's down by 60 to 70%, and anywhere close to having been recovered from any of these downturns. New business applications with the IRS went from 100% down by 30 to 40%. This is a very key indicator. Number of travelers passing through the TSA checkpoint. As all of you know, in the US, we have a TSA where if you are authorized, you can zoom through from 100% back in March 1. You look at to April 20th, it's down to less than 1%. Obviously, that has affected the travel industry, and it has affected all the other hotel industries in big ways. So there is a huge downturn and much more to see in the near future. We have not really seen its real impact yet. So the revenue losses, as many of you might have heard, reported by major US hospitals. For example, $3 billion alone lost by the Mayo Clinic. The University of Colorado is expected, the whole campus, University of Colorado Anschutz Medical Center, where we all are, that's just the medical campus, is headed towards nearly $1 billion loss. And if you include the rest of the campus, which is in Boulder, Colorado, it's about $3.4 billion loss. So many major universities are looking at huge losses that they will have to find ways to fill in. The clinics are losing revenues, average about 15 to 20%, partly due to loss of patient insurance, job losses. Risky patients don't want to come to the clinic. They are scared of getting COVID. I have patients who say, "Doc, I haven't gone from my house at all. I'm not going to come to the clinic at all." So there are X number of patients. Fortunately, they're not a large number, about 10%, don't want to come to the clinics. Telehealth reimbursement, right now the federal government in the US had authorized that they should be reimbursed the same way as though they were being seen in person. Will that continue to be the case? For example, the hospitals are not interested in telehealth. Clinics like ours, we are, but not the hospitals, because hospitals lose money because you can only bill for the physician part, not for the facility fee. So they are losing billions of dollars, thus they do not encourage, and thus they are actually discussing with the insurance companies against the telehealth. So it's really, as much as we want this telehealth to move forwards and maybe the way to deliver care, especially for diabetes, but a lot of insurance companies, at least in the US, are coming in the way. And this is an unfortunate case, but many primary cares, up to 40%, might be going out of business in the US. A lot of family practices are losing about 40% of their revenues, and many of them will probably go out of business. Many specialty clinics like ours are seeing somewhere between 15 to 30% downturn. Now, fortunately, that's in part being covered by at least the research, but if the research dollars are also going to dry up, we'll probably have much bigger problem at hand. So this slide is a little more complicated. It would take me probably half an hour. What are some of the expectations, what might happen in terms of the different shapes of recovery, whether it's going to take a year or 6 months or 5 years, nobody knows. All I can tell you, the takeaway from this slide is this recovery is not going to be quick in the way the politicians are saying. Just wait for a while. Its real effects are going to be seen. You see right now effects which are artificially infusing trillions of dollars into the US economy and the worldwide economy, and that's not the recovery, the way we saw it in 2008, starting in 2009. Let's go back to the second part of my talk, which is the opportunity of telehealth or the virtual care. COVID-19 and diabetes, why they are so interlinked, as many of you know, diabetes and hypertension are consistently the more common comorbidities in patients with COVID. Prevalence of diabetes is about 3-fold higher. And in fact, incidence of diabetes or hypertension in ICU patients is about 2-fold higher than non-ICU patients. Almost a third of patients with severe COVID, who actually end up going into needing a ventilator or ECMO in the ICU, have at least diabetes. This is briefly, I'm not going to go into the details. There were 6 articles we ran on virtual health back in June of this year, and all these articles were written back in April and May, just showing you how you can manage new onset type 1 diabetes remotely, how the transition from inpatient to the virtual care happened in the inpatient setting, and how do you manage pregnancy, and how do you manage the ketoacidosis. Just to give you examples of 2, how did we manage new onset type 1 diabetes? Since I was the only one who was coming to the center every single day after March 15th, when there was a lockdown in the US, so we saw a lot of new onsets. Of course, the pediatric clinic saw a lot more, but this is how we brought the patients, since they didn't know how exactly to inject themselves. We brought them in person for literally an hour or 2 or 3 hours, and the rest of the management was done completely online by giving them free Dexcom G6 from the clinic and following them remotely. And you can see this patient, who was a new onset type 1 diabetes, he delayed going to the hospital because he was scared of getting COVID. So he was admitted in the ICU for ketoacidosis. And when he was way up in the mountains, when the ICU people called me, I said, you don't need to keep this patient anymore in the ICU, just discharge him. And we brought him to the clinic, started him on the traditional basal bolus therapy. This is 2 weeks later, as you all can see. He completely recovered, and he was pretty much in the honeymoon phase. And I followed this patient now for 2 more visits. I can tell you, when I just saw him through telehealth about 2 months ago, he was still in the honeymoon phase. How about ketoacidosis? Because this is a life-threatening illness, and thus one shouldn't take risks. So, and Peters and I wrote this article giving you examples. This was a very interesting patient that I saw, a 26-year-old female with a brain cell germinoma, cancerous, surgically removed and received radiation and chemotherapy. She developed, unfortunately, pan-hypoprit, which you can imagine was very close to the pituitary gland. However, now she presents to Children's Hospital, even though she's 26, with diabetes, with the symptoms of diabetes insipidus, which she already had, was on treatment due to pan-hypoprit. Initially, the doctors there at the Children's Hospital kept on increasing the dose of desmopressin till such time one of the docs said, you know what, when she went 7 days later with type 1 diabetes and ketosis, they checked the blood sugar, she was above 500. Unfortunate, no link with pan-hypoprit. Unfortunately, she was obviously diagnosed with type 1 diabetes in association with this pan-hypoprit. Again, she was managed totally in the outpatient setting, and desmopressin dose gradually reduced to the pre-type 1 diabetes. In fact, now when I saw her 3 months later in the clinic, her dose actually is even less than the desmopressin dose, even less than the pre-type 1 diabetes diagnosis, which tells me that she actually had type 1 diabetes coming on at least I would say for 6 months, but there was no blood glucose estimations or A1C estimations in these patients, at least in the past 6 months. And this is just to show you the data as you would expect. New onset, all blood sugars in the 300, and clearly 2 weeks later, she was clearly in the honeymoon phase. All managed remotely, meaning thereby you can manage these patients very effectively remotely. This is John Buse's center at UNC, where what they did is their diabetes care team, they call it DCT, they transitioned from seeing people in person to inpatient diabetes management, totally done remotely. By the way, this data is based on smbg, but you'll soon see 2 articles in DTT coming up, which are showing you the implementation of CGM in the inpatient setting and what are the outcomes. Remind you, FDA authorized Dexcom, Medtronic, and Abbott to use diabetes management, any of the 3 sensors, in the inpatient setting back in late April. And this data just shows that when they transition week by week, you can see on the x-axis that they clearly had similar outcomes from in-person visits, doing the grand rounds, or looking at their data remotely, which is highlighted here, virtual implementation, time in range, time below range, time above range was more or less identical. And the same group is going to publish soon the data on the CGM. There have been X number of cases that have been reported in the T1D exchange, 51, that many of you might have seen this data, and again, male, females being equal. But most important is that most of these patients were diagnosed at home, highest level of care, because people are delaying the visits to the hospital. Thus, there is increased risk of decay. In fact, there is a paper that some of the pediatric colleagues are working on looking into this, and they are showing that the decay manifestation in type 1 diabetes has significantly gone up. Now, this was important because David Penzier, who is in charge, who is one of the trustees for Leona Helmsley Foundation, he gave some of his perspectives from the nonprofit organizations. What can they do in terms of COVID-19 for managing diabetes? Of course, he is a champion of virtual specialty clinics, and he highlighted some of these changes. That main part he highlighted is, one is you need to find ways that how virtual care can be implemented and be still supported equally and reimbursed by the insurance companies. Second big thing is it could become a disparity equalizer. You know, in the US, there's a big disparity how African American or how Latinos are treated as compared to the whites. That's true at the Barbara Davis Center that I've seen in the past 32 years. Nothing has changed in this country. If you think your country or India has, the disparities, trust me, in the US, there are more disparities than you can ever imagine. And last but not the least, he highlighted the point of psychosocial health, which is so important, especially during these hard times. Many of you must have seen this data that emerged from UK NHS. I'm only going to highlight one point, that in the past we thought almost high mortality and morbidity in people with diabetes was all related to type 2. But when they look at their national data, that's not true. In fact, type 1 diabetes patients died more often, 3.5 times, than twofold increase in death in people with type 2 diabetes. So more death in type 1 diabetes. However, the next slide is more important. It was all related to glucose control, which is good, that if people are in good glucose control, then the mortality in type 1 diabetes may be similar. But having said that, we shouldn't give the message to patients with type 1 diabetes, oh, that's only for the older people, they have type 2 diabetes, they're obese and overweight. No, that's not the case. It is related to glucose control, but type 1 diabetes is an important comorbidity for people with the disease. Now, I don't have time to go into the details. I'm sure I'm running over time, but could COVID-19 be the cause of type 1 diabetes? In our next group, which I think Banshi Saboo is part of it, when we discuss this is a topic that I'm going to discuss at length, that what is, as all of us know, that various viruses have been blamed that they can cause or trigger diabetes. Of course, we don't have the typical Cox postulates being definitely designed, but a lot of people are starting to think whether this could be the cause for type 1 diabetes. I personally don't think so, but at least there are some reports that are showing up in the literature. And I think it'll be very hard to say that. Part of it might be because people are under stress, and stress is a very important risk factor for causing the new onset type 1 diabetes. So I'm not sure this is the cause, but it's something to keep in mind. So I think I sort of highlighted some of these things to you, but very important in this is how do we move forward with the digital health and the outcome assessments. The first digital therapy was approved by the US. As you know, US is really taking a big lead in the digital therapy. Now, Courtney Harper-Elias, who used to be in charge of the device section, now she's in charge of the digital health at the FDA. It really is launching new guidelines. A lot of tech giants have entered into the healthcare. For example, Google. I'm sure you will hear Verily, along with Dexcom, is starting the G7. In fact, next week we are starting the first preclinical study on the G7 Dexcom sensor. Amazon is partnering with Berkshire Hathaway and JP Morgan to form a healthcare company just because healthcare is so expensive, and thus they want to look at a different alternative in the US. Many of you know Apple is focusing on many of these. So there is huge interest on the digital platform. This was a very important internet leaders. The question was asked, what is the digital future could mean empowerment and cost efficiencies? The internet leaders increasing trusted with healthcare. So the question was asked that with which tech company would you share your healthcare data? Forget about with the physicians. That was lowest. They don't want to share the data with the physicians or the insurance companies. Look at what the patients' responses were. They trust more Google, Amazon, Microsoft, Apple than the healthcare. So needless to say that people have lost faith in our profession, and we need to do a much better job in improving that. I think this is my last slide. I hope I've shown you in briefly the economic burden, which is, if I was to give you a long talk just on the total economic burden of COVID, it is amazing. It's going to end up to trillions of dollars in terms of direct or indirect costs, and specifically to diabetes, it'll be in the billions. Death in type 1 diabetes is higher. Is that true? Which I showed you the data. We don't have any randomized trial. It is only the data which is being reported. Some of the changes we would like to see, the telehealth being reimbursed the same way and across the state lines. As you know, in the US, if you're licensed, let's say in Colorado, you cannot see a patient through telehealth in Washington, D.C. Now that patient can come in person and see you in the clinic, but I cannot do the telehealth. Some of that burden was taken away under a federal law back in mid-March, but it's no more implemented. Most of the insurance companies at the end of September are going to stop that. And cost savings by avoiding hospital admissions with DK, managing diabetes. I didn't go into the data. Pregnancy was very effectively managed by Helen Murphy's group in the UK, and the article is in DTT. I think it is a very interesting article, how they managed and how they came up with all these remote data. The technology is making it easier, of course, for the cloud-based applications. Of course, we need to replace A1C for time in range or glucose management index. I'm not sure whether it's time to think of replacing by estimated A1C. At least I can tell you FDA does not trust in that. Allowing providers to have the consults remotely, I've said it time and again, there are a lot more challenges than what we want. Removing barriers for the disparities. To me, this is the biggest problem. The rich get everything done. The poor are the ones who are dying from the disease, COVID and/or diabetes complications, or the minorities. And thus, telehealth could actually remove many of these disparities. But however, I'm not sure if that'll happen. And maybe the nonprofits and the industry partners may have an important role in this. Future loss of health insurance and post-COVID reimbursements are totally unknown. Well, thank you very much for listening. I'll be happy to answer any of the questions that people might have. I hope I didn't take too much time.
No, sir, you're right on target.
Good morning, Fran.
Good morning and good evening for me at the end of the day. And I know you're starting your day just now. So any questions from the audience? Anybody has a question?
Dr. Satish, a quick question. You have been discussing about management of type 1 diabetes remotely via telehealth. But in most of these examples, patients were initially admitted. So by law, can you start insulin via telemedicine for a patient for the first time in the US?
So two-part answers. The two examples I showed you, the patients, the second patient who had panhypopit was not admitted to the hospital even though she had ketosis. She didn't have ketoacidosis. She was not admitted in the hospital at all. In fact, She was just brought for half an hour to an hour in the clinic to show her how to take insulin and give her some samples and start her on the Dexcom, and she was on her way. The first patient was admitted in the ICU because he delayed the diagnosis, even though his uncle has type 1 diabetes. But that patient again was brought to the clinics. If you're talking about a type 2 diabetes, yes, one can use remotely, teach them how to start insulin using these insulin pens. We've done a lot of pump starts and many other things remotely. Absolutely, you can do that. But in a new onset who doesn't know how to inject, is scared of hypos, and thus you have to teach them how to deal with. So those new onset type 1 diabetes, where it's life-threatening, we had to bring them for an hour to teach them the basic things. But in terms of pump, which I'm sure Fran can talk to it, or starting somebody on Tandem, Medtronic, or somebody starting on Abbott or a Dexcom, you can do all of those remotely.
Thank you. Thank you.
Thank you, Dr. Satya. Just to share data from India, we had a publication a couple of last week, the Times of India, across all states. The data is similar to that of the US, but they didn't do the difference between specialty care versus GP practice, nor corporates across the board. There's a 55% decrease in all sorts of medical consultations of people coming in. So I don't know. I think the real thing will be shown another 3 months later. Now I think there's all this right now is not the time, as you were showing us data. Probably next 6 months we really know what is the real impact.
Sanjay, I think
Can I have a question?
They showed specialty-wise, endocrinologists, diabetologists were still better off. They were still having 40 to 45% flow. I think the worst hit were, of course, orthopedics and cosmetic surgeons, where the footfall was almost 10-15% only. So,
cosmetic surgeons. There's a question that somebody is asking, can any speaker elaborate on traceability studies on quality insurance? I don't know what he means by traceability studies. CGM system gives interstitial glucose measurements. Malati.
That is again a question on accuracy.
I'm sorry?
That is again a question on accuracy of the CGM sensor, since it is measuring the interstitial glucose values. The age
So we've come a long way in terms of the measurements and how these algorithms are created. And I'm sure Fran can talk to you at greater length on this. There is no doubt in my mind that there is always going to be a lag. If the glucose rate of change is anytime exceed 3 or 4 milligrams per minute, by the way, which is extremely rare, I would say less than 1% of the times the blood glucose rate of change exceeds more than 3 or 4 milligrams per minute. If it is less than 1 or 1 to 2, it has hardly any. Yes, it'll lag behind by a few minutes. That's why what we tell our patients, do not look at the individual numbers. Look at those trends. Look at the overall, what you've gotten glucose values every 5 minutes. Whether you use Abbott system or Dexcom or the Medtronic system or the Senseonic system, doesn't matter. Look at the overall trends. That's more important than looking at the individual numbers.
I think Dr. Makkar had a question.
Good morning, Dr. Garg.
Good morning.
Raj Makkar here. So you just talked about the new detected type 1 diabetes that you had to bring to clinic for a couple of hours to train them. So in this kind of situation, can't we use some educational videos to train the patient and talk to them into it?
So, I mean, one could, like Helen Murphy's article, if you see, they have created for pregnancy almost all to be done remotely. The new onset type 1 diabetes, where they have never injected insulin, where they have no idea about hypoglycemia and the glucagon need, we felt, now maybe going forward, we can try that. We've not. I must say, like we are doing remotely, initiation of sensors, Now we are doing remotely initiating the pump therapy. But we have not gone that far to the point that you are asking just because we were not comfortable. I'm talking about mid-March to mid-June is when all this happened. It is an experiment that is worth looking into, whether you can initiate somebody a new onset totally from home. I don't know. Fran, do you have any?
Well, whether it has to come to our offices or to a primary care, or to actually, some people are supposing some of these mini clinics or even urgent care where they're just quickly taught to do the injection, but all the rest of the cognitive issues are then done remotely. So,
which is what we did.
Yeah.
Which is exactly what we did. All their education regarding carb counting, regarding the details of hypoglycemia, exercise, alcohol, everything to these adults with new onset type 1 was all done remotely by the staff. It's just the initial part, how to inject, give them samples, that part was done. And maybe it could have been done remotely, but we were all locked down suddenly on March 17th.
Yeah,
in Colorado.
I can understand. Nobody
don't
was
have that
prepared.
experience.
Nobody was prepared for this.
Yes.
But henceforth, I think this can be a worthwhile idea to have, educational videos on training how to use a pen or inject, and simply give a demo with those videos.
People are talking about for the injection, Satish, so the pharmacy, since they have to go there anyway to get the medications, whether the pharmacist could teach just that that injection issue.
Yeah. Now, remind you, many of us, Barbara Davis Center totally manages only type 1. Fran knows us well for 30 years. So this is the exclusive center where we treat our patients like a family member. But out in the Timbuktu, yes, people could go to a pharmacist where you call in the prescription. What will be the outcomes 1, 2 year, 5 year later? I have no idea. Nobody's going to be able to do those studies unless we have another outbreak of this COVID.
Thank you.
So not for that.
Yeah, I know. Over to you, Fran. I just took your time.
Yeah, I think if you're finishing on time, and then we have another talk coming on. Thank you very much, sir. It was a pleasure listening to you, and thanks for sharing your wisdom. And I request you to hope we get to meet sometime, not virtually, physically, short.
Sorry.
Thank
All
you.
right.
Thank
Take
you.
care.
Sanjay and Jyoti, thank you, Dr. Garg. Dr.
Nice
Frank.
to see you, Satish.
Good to see you, Fran.
So, Dr. Frank Kaufman, in fact, we did introduce her earlier. Good to have you, Dr. Frank. She's a Chief Medical Officer with Senseonics, Distinguished Professor Emeritus of Pediatrics at the University of Southern California, the Center for Endocrinology, Diabetes, and Metabolism, Children's Hospital, LA. Dr. Kaufman will be speaking to us about the experience with the implantable Eversense CGM systems. Over to you, Dr. Kaufman.
Yeah, so first, please let me apologize. I'm on the West Coast of the US, so the time difference is quite pronounced. It's 3 hours. And when I got the invitation, it had said the East Coast time, and I didn't realize that. So I deeply apologize. Plus, I also deeply apologize. I'm having a little trouble with my voice. We have many fires now, actually quite near to where I live. And you can smell and appreciate the smoke. So many of us are becoming hoarse and allergic. When I moved to Southern California over 45 years ago, I thought it was paradise. And now, unfortunately, it is something that is experiencing fires throughout the entire West Coast of the United States. But I am so honored to be here and appreciative of the opportunity to talk a little bit about Eversense. And unfortunately, Eversense is not available in India, but let me go forward. I think I'm in control, maybe not, of my slides. Oh, there we go. So let me go through the components of the Eversense CGM system. So it's fully implantable and long-term. So there's really 3 major components: the sensor, the smart transmitter, and I'll tell you why we call it smart, because it really is, and then the mobile app. So the sensor is fully implanted. In the US, the indication is now for 90 days. Outside the US, mainly in Europe and South Africa, the sensor that's available there is 180 days. And we are waiting, we are just submitting next week, in fact, our submission for the 180-day sensor in the United States with many modifications and improvements. So we're looking forward to that, hopefully in the next number of months. The smart transmitter is worn over the sensor, and in fact powers the sensor through near field energy. And it also calculates the glucose, so it gets the raw signal and turns that into a glucose value. It's placed on the skin since it doesn't have to hold something in place that's transcutaneous. The adhesive is silicone-based and very mild, and it can be removed without having to replace the sensor, so you can take a shower with nothing on the skin at that point. The transmitter is lightweight, it's water resistant, and its really unique feature is that it vibrates when there's an alert that is being triggered by the system itself, whether for high or low, either actual or predicted glucose values, or for issues with the battery. Whatever alert may be brought over to the mobile phone is also triggered on the body itself through the transmitter. And then all of that through Bluetooth goes to a mobile app on the phone. It provides all of the glucose trends, the alerts, it prompts for calibration. That data can be shared with 5 care partners, and it automatically uploads into the cloud. So the data management system is holding on to the data, which you can then pull down either as the patient or the provider yourself, or anybody who actually has the ability through the username and password. So just to kind of go over this, so the body-worn transmitter wirely powers the sensor that is placed subcutaneous. The skin is closed over it. The sensor has an antenna that receives this near-field RF energy, and then it sends back through, after it's calculated the interstitial glucose value on a polymer surface, and it uses fluorescence rather than enzymatic measurement. And of course, you know, when we talk about the difference between the blood glucose value and the interstitial glucose value, we talk about it as lag, but they're not exactly the same value. The interstitial glucose value doesn't always equal, and this is, as you can imagine, physiologic and normal. It doesn't always equal what the blood glucose value actually is, particularly as Satisha talked about during rapid change in glucose values. So then the sensor returns the data to the transmitter, the glucose value is calculated, and then that's sent to the patient on the mobile phone and stored in the data management system in the cloud. So let me go over some of the data, because I could talk and talk and talk, but what really matters is what have we been able to show, particularly to the regulatory agencies, both the FDA and the EU regulatory body, as well as what have we been able to show the scientific community. And then, of course, we translate that into something that the patients themselves and their family members can understand to make the decision whether or not they want to consider an implanted long-term CGM. So the MARD, and this has been done now in 3 studies, and with the algorithm that's available in the commercial device, the MARD, the mean absolute relative difference between the sensor glucose data and the data obtained with a YS. We do a number of these. We always do our studies, as does everyone else, at Satisha's center, at the Barbara Davis Center, because of their excellence and their ability to do these kinds of studies, along with many other centers. So the MARD is 8.5, which is really comparable, if not best in class, compared to other CGMs. The adherence, so you can take the transmitter off for a short period of time. It needs to be charged every day. It comes with a specialized cradle Takes about 10 minutes to charge it to last the next 24 to 36 hours. So it's not on all the time. People prefer to shower with it off. And of course, sometimes people want to keep the transmitter off for special occasions. We just got wedding photos of somebody who uses the device. She had the transmitter on, but when she walked down the aisle, she chose to take the transmitter off for that brief period of time. But adherence with getting data is quite high, because once it's in for 90 days. All you have to do is put the transmitter over it, and you'll be able to get the continuous glucose monitoring data sent to you. The time in range has been about 59% during these studies. And then the ability to detect hypoglycemia, and there's a specific way that this calculation is done, has been 95%. So this is over 22,000 days of data, compared points, where we compare the data of the sensor as well as the data from the YSI instrument. And so this gets to over 2 million sensor readings. So quite a bit of data to come to the single value of the MARD of 8.5%. So this has been an important slide for us. We can do, of course, all the studies in the world, which are always quite important. But what really matters is, what can we glean through culling the data management system that has all of the patient's data in there? What can we really glean as to what's happening in the real world? So we wrote a manuscript. It was published in Diabetes Technology and Therapeutics in 2019. And it looked at the real world experience with the first US commercial user. So it turned out that we evaluated 205 patients who, as soon as they had completed the 90 days sensor wear, we analyzed all of that data and then reported it. So the mean sensor glucose, now of course, these patients are for the most part type 1 patients, but it is indicated in the US and the EU also for insulin taking type 2 patients. Many of them are using pumps, some of them are using MDI. This is a tool, so what they're capable of doing with the data is, as you can imagine, very independent, individual by individual, clinic by clinic, physician by physician. So we end up with a mean sensor glucose for this entire 90-day period for the 205 patients of 161. CV, which is a measure, obviously, of glucose variability of 0.35, which is quite good. And now this GMI, this glucose management indicator, which is like an estimated A1C of 7.18. Then we can kind of look at the time in hypo, which is quite good. The time in range, which is now 62% better than what we did during the clinical trial. And the goal is to get it to 70% or above, but quite good compared to other systems reporting. And then, of course, the time in hyper by different ranges. And, obviously, overall showing that this is a very viable tool that patients can use to get to the kind of values that they're really hoping to get. And with a very good percent of time with the transmitter on in the real world. And then, of course, when we look at those paired points, the MARD, when we do it against the YSI, is always much lower than the MARD that we get in the real world compared to finger sticks that the patients put into the device. But a MARD of 11 in the field is actually quite excellent. So very, very, what we feel is good data showing the value of this as a CGM, comparable, and in some ways maybe a few things a little bit better than the other transcutaneous CGMs that are available. The safety data, as you can imagine, we do have a differential risk. Somebody is undergoing a very brief in-office procedure to cut the skin. The incision's about 3 to 5 millimeters. The sensor is placed with special instruments that we give you. and then it's closed with steri-strip. So obviously the healing process, it can be individual, but we see very, very few infections at the insertion site. Most of them are, I think the tendency is to be over concerned. We'd rather see somebody take oral antibiotics if there's a question than not. So 4 patients, so 2% of mild infection. 4 patients, they initially could not remove it when they went in for the first procedure. There's specialized tools we give as well, a clamp to be able to remove it. Everybody who's doing these procedures are trained by us. And I'll show you, we're able to do that training now virtually. And then any irritation to the transmitter patch or adhesive is also quite low compared to other CGM systems. So our real world data, we've continued to expand on that. We just presented this at the ADA, now up to 1,600 patients. And you can see the at the top, I don't know if you can see my cursor, but the sensor glucose mean value now for 1,600 patients, still 161. The time in range, still 62%. The time below range, very comparable. So not much change. And what brings us down, of course, what we're all aware of is this young adult age range where they don't wear it as much. Their glucose values are much higher. Their time in range is much lower. Their time in hyperglycemia is much higher. This has been brought out in the type 1 exchange. I think we're all aware that the young adults continue to do poorly with diabetes management, a little bit better than what's reported for them in the type 1 exchange, where the mean A1C was about 8.5 to 9%. Our GMI is 7.53 in this age range, but still suboptimal. And then we can look at the older age in the US, what we call our Medicare age range, and we can see how well they do now. Their A1C estimated is less than 7. Their time in range approaches the 70%. And the good news for them is that the time in hypoglycemia is not much higher at all. So, really looking at good overall by age range, what we would expect to see. There's been increasing adoption of CGM by payers, including now of Eversense, over 200 million Americans through our insurance carriers. And this includes the Medicare and Medicare Advantage programs in the US. And 3 Medicare companies are now, or distributors, which is regional, have now published, and as well as the national Medicare system for the reimbursement for Eversense is now available in that age range. So I do want to show you, we have more data also from Europe. So we have a post-market registry study that we did in Europe in 15 countries, 3,000 patients, over 5,000 sensors. You can see many were on their 2nd sensor, some were on their 3rd sensor, some were on their 4th sensor. Very low AEs, so these are just, some minor, and I'll go through them here. 3%, 0 serious adverse events in this registry. So you can kind of look at infection less than 1%, failure to remove less than 1%, adhesive patch irritation less than 1%, any kind of issue with the wound healing or bruising, also 1%. So I do want to show that we've got now evidence. There's been a question, can you do this repeatedly? So the indication for use is you put one sensor in one arm, you take that sensor out, put the next sensor in the other arm. When that wear period's done, you take that sensor out and put the next sensor back in the contralateral arm. Is everybody doing this? No, many patients off-label, unfortunately, keep going in the same arm over and over and over again. And because this is known, there was a big concern whether this could be leading to an issue. So in a large, now looking at 1,000 centers over 2 years, lots of paired data points in the 100,000 to 200,000 range for sensor cycle 1, sensor cycle 2, sensor cycle 3, sensor cycle 4. And then looking at the accuracy as well as the safety profile was confirmed, but we can see there's no change from one sensor to the next sensor to the next sensor to the next sensor. And we know that many of these sensors are going into the same area as a sensor was just removed. The GMI, you can see here this estimated A1C being quite excellent. The time below in the 54 range, the time in target, quite good, and no indication that anything is deteriorating over time. And now in Europe, we have many patients who are at 10 sensors. They are now in Europe, again, the 180-day sensor, so it's quite some time. Of course, they started in Europe with a 90-day sensor. In the US, we have patients who have been using 10 sensors as well. So no indication that there's any deterioration by going into the same area, or even, as indicated, changing area from one sensor to the next. And you would expect this because transcutaneous sensors are going into the same place. We're all living and measuring in the same place at subcutaneous space, at interstitial space. And with the transcutaneous sensor, actually, there is a fair amount of trauma every time you put that sensor in and remove it as well. So good news for all of the sensors in this space, that it doesn't seem to be an issue. Now, I just want to quickly go over a study that was done in the EU in Italy. By Dr. Arace and her group. So multiple sites in Italy, 100 patients were evaluated, and this is with a 180-day sensor. And they looked at, and now with real A1C data, this was a prospective study, independent of Senseonics. So all the patients, I don't know why it keeps changing, but I'm sorry, of 7.4 starting A1C to 6.9, so quite a good reduction. 63% time in target to 69% time in target. But if we look at those who were CGM naive and not used sensors before, we see quite a significant reduction in those with MDI versus those with a CSII or pump, a significant reduction in A1C, significant improvement, as you can see, in time and range. And even those who had been using sensors before, still a bit of a reduction in A1C, but what does this really indicate is that you can come from another sensor and still use the Eversense for at least if stabilization or slight improvement of the data. So, but the real impact is no deterioration of data using the implanted sensor compared to the transcutaneous sensors. So good A1C change, improvement time and range, and of course the CGM naive patients had the greatest improvement. So in conclusion, Eversense is the only long-term implantable sensor. It uses fluorescent technology, lasts up to 90 days in the US or up to 180 days in EU. And here's where I do want to say we are going for an indication of 180 days with an improved sensor platform in the United States. Hopefully we'll know that in the next months to come. And then we're starting studies now in our study sites, actually, which are in Romania, for a sensor that will last a year. We're hoping perhaps to be in studies with those by next summer or fall of 2021 to be able to get an indication for a sensor that lasts a year in the United States and in Europe. Accuracy supports a BARDA of 8.5. Real world data shows excellent time in range when using this as a tool for diabetes management. The EU registry data supports its safety. Repeated sensor cycles continue to show accuracy and safety, which is sustained. This independent study in Italy shows A1C reduction and increased time in range when using Eversense, and stabilization. If you're coming from another A1C, certainly no evidence that Eversense is a product that could deteriorate control compared to other sensors. And we do have a robust innovation pathway for this novel CGM device. So I thank you for this wonderful opportunity to share this with you. Again, I'm so sorry about getting the time confused and I'll be able to answer any questions if anybody has any. So thank you all very, very much.
Thank you, Fran. Great job.
Thank you. Thank you, Dr. Frank.
Yeah.
We actually did take the liberty of having the discussion before you joined in, as while we were waiting for you to join in, and a lot of discussion on different CGMs with the other speakers on the topic we've already had. But we'll still invite questions from any of the panelists and speakers here, and we'll also have a look at the chat box for any questions on the same. So we're aware, Dr. Frank, that Essentia Diabetes Care will be the one responsible for getting it in India, and they're working towards getting it soon. And any idea what kind of approval they would have in India? Is it going to be 90 days or 180 days?
I think maybe by the time they get it through, the hope is it would be the 180 day, but I'm not sure. And the improved 180 day, which will hopefully be out within a half a year.
And this one still requires calibration every day.
So the new one, the product right now requires 2 calibrations a day. The new product will require 2 calibrations for the first 20 days, and then after that, a calibration a day. So, I mean, when you think about it, you have to charge the transmitter. So you have to put that off for 10 minutes. Then you put the transmitter on, you do the calibration, and hopefully you're done for the day.
Frank, this is a different question, not specific for your sensor. When we are using Libre Pro and the other sensors, rarely patients can develop an allergy, and it can be an inflammation or sometimes an infection. Though the numbers are less totally, but it is a significant side effect. And I read somewhere that it is very rare, since it is an implantable sensor. Skin allergies are relatively very rare with Eversense sensor. So does it make any sense?
So I'm not sure I understood. So with the insertion process, there's very few.
No. With insulin pumps and with sensors, some patients on repeated use, they are developing skin allergies.
Oh,
Yeah, and Eversense, since it is implantable, do you agree with me that the allergy will be less? Of course, I know that the transmitter is going to be there.
So, it's a completely, all the materials used have been obviously extensively studied. And, just so you know, if somebody were to be lost to follow-up and they don't have the sensor ever removed, the FDA is aware of that as a possibility. So it's actually been approved as a permanent implant as well, if it doesn't get removed. I mean, that's not what we want to see happen, but if you were to lose a patient and they had the sensor in for the rest of their lives, there's no evidence that there's anything in the sensor that could cause a delayed hypersensitivity or some kind of response at all. It is all pretty much inert, and there's no, anything that's anybody's been able to show could potentially lead to something like that. So repeated use somehow induces some hypersensitivity.
Perfect. Dr. Sadish, how do you get allergy? This is a question to Dr. Sadish. If a patient is developing allergy to Libre or Libre Pro, how do you manage it?
So I want to answer it 2 ways. I'm not sure it's really the allergy. Repeated use of any sensor, whether it's Abbott, Dexcom, Medtronic, it doesn't matter which sensor. It is mainly because the tape is sticking onto the surface, and anytime you remove the tape, you will see you're removing part of the skin. So if a patient continues to use on that site, which they sometimes do, not the same, but the similar sites, it's likely that exacerbates a reaction, local reaction. I don't want to go that far, causing it an allergic response. Now that can happen, which is extremely rare. I'm not saying it cannot happen, but it's really more of a skin issue that you'll have. Now that is a big advantage with Eversense. It is something which is implanted. Now they do have something which you do put it on top, but every day, Every 24 hours, you got to replace that. So shorter lasting tapes will always have less skin reactions. If you look at the Synergy tape, which we are doing the study, which Medtronic, of course, Fran's previous company knows very well, people are loving it. It's so small, the sensor, and same as the G7. So I think it's all a function of the tape more than the hypersensitivity.
So it is
And
an
one of
adhesive
the
material.
why the adhesive for Eversense is more mild is we're not holding anything really in place, right? So it's just it's
and not only that, Fran, it's only there for one day. So 24 hours, people have to replace it every day. That's a downside, but the upside is that you don't get the skin reactions.
Right, the skin can breathe in between.
Yeah, exactly.
And Dr. Kaufman, in terms of the data and for Eversense, does it have an initial period or towards the end which one should be cautious about? So does it take a while for the readings to come in which are reliable? Some of the devices we have seen the first 24, 48 hours to be kind of ignored before you start actually seeing the readings. So any of those kind of takes for the Eversense?
Yeah, that's a good point. So day one is worse. I mean, there's no doubt, but you have only one day one in 90 days, right? Or 180 days. And what is truly happening, which is why it's so important on technique, is to control bleeding. So, once you make the incision to use pressure, wait for some homeostasis before you put the sensor in, because if there's a lot of blood where the sensor is going, it will cover the sensor surface. So it's a hydrogel membrane. It's a little bit like a contact lens. Mm-hmm. And if there's blood there, it interferes with the fluorescence. So that's part of the reason for us. And with the transcutaneous, there's just some tissue trauma that needs to settle down for the sensor the enzymatic reaction or the fluorescent reaction to work the best. But we can see though, those who, really take the time to get good, hemostasis and then put the sensor in, we don't have quite as long a period.
Is it approved in the pediatric age group? Is it approved for insertion in the pediatric age group?
No, which obviously hurts me a lot, but we're going to do it next. Yes. One of our problems, it's one of our advantages, and one of our problems is if we have a sensor that lasts 6 months, we have to study it for 6 months. So at Satish's site, those patients were in the study for 6 months. When we go to a year, that study is going to last a year. They want to see what's the last day data. So the studies are very long. The patients have to be very committed. They came in 10 times for frequent sample testing in the 180 day. And, we're hoping that we'll be able to convince the FDA not to have double that for 365. As a result, these studies are very, very expensive.
Okay. I guess that brings us to the end of this technologically advanced day. I think we've had a wonderful day one to our RSSDI Diabetes Technology Symposium. Yes, we thank Dr. Satish Garg, Dr. Frank Kaufman, and all the speakers for the day for joining us today. I think we've had some wonderful insight into where technology is heading in the field of diabetes. And we look forward to another exciting day tomorrow. Again, thank you and have a wonderful day, everyone. I'll hand it over now to Dr. Banshi for winding the day and giving us all a reminder for what's in store tomorrow. Thank you.
Thanks, Manoj, Mithun, and Jyoti Dev, who are the part of this technology network for RSSDI. Thanks, Frank Kaufman and Dr. Satish Garg. Thank you for joining. And thanks to all the speakers and all the faculty members who joined for today. It was really a wonderful day and very exciting and very enlightening also. So tomorrow sharp at 9 o'clock, we again once meet Dr. Mithun, Dr. Jyoti Dev, and Dr. Manoj Dr. Jyoti Dev, I have to remind you 2 times tomorrow 9 a.m. because
You guys need to go and sleep now. It's late for you guys.
good
Yeah.
night for India and good day for US. Thank you.
All right.
Thank you.
Take care.
Again, I apologize.
No.
No problem, Dr. Hoffman. Thank you. It was wonderful listening to you. Thank you.
Thank
Thanks,
you.
Hardik. Dr. P.V. Rao is there. Dr. Ritu Jodi is there. Thanks. But we have 949 doctors, Manoj. Now,
That's good. That's good, Bansi. I think let's wind up and get back fresh in the morning.
Yes.
Right?
Absolutely.
9 o'clock.
Thank you.
Dev, I'll be calling you at.
Yeah, wake up, Jyoti.
I will.
Work night. Jyoti, going to work a night.
I have to call Jyoti.
I will be there. Bye-bye. Thank you. Within